and monitoring, which are part of what we at Radboud call the evidence-informed deliberative processes, EDP, in which stakeholder participation is central. Stakeholder involvement is a key element. Stakeholder involvement. The term came up several times yesterday, and in different ways. I'd like to refer to this taxonomy, which is from an article which is not that recent, but which distinguishes between 7 Ps, the 7 Ps, the 7 stakeholders that one can distinguish: patients and the public, providers, purchasers, payers, public policymakers, product makers, and principal investigators. Principal investigators is a bit an odd term, but what is meant here is the research community, academia. Patients and the public are mentioned here in one vein, as if they're identical. I put an asterisk just to say that, to me, those are 2 different concepts. They're often used interchangeably. Let's involve patients, or let's involve the public in benefit package decisions. But they're clearly very different. Yesterday it was mentioned already that patients, sometimes some patient organizations are able to express a very strong voice. They're quite vocal, and by doing so they really exert an influence in benefit package decisions. Other patient organizations are much less vocal. But the public is a different entity. Not everyone in the public is every citizen is a potential patient, but not necessarily a patient yet. And patients organizations usually plea for their own case, better management of diabetes or chronic heart failure or certain malignancies. So they very often have a particular focus. The public doesn't necessarily have that focus. And I personally prefer to speak about taxpayers. And we've had profound discussions in the Netherlands, and we've done even a citizen forum with ordinary citizens, proposing them cases of treatment trajectories, and we asked them the question, would you or would you not include this in the benefit package? And initially they said, yes, of course, we should include that because it's a severe disease and it hits so many people, or it leads to undue expenditure or different arguments. But gradually people started to realize, well, this is about public money, and this is about how our tax contributions are being used. So in principle, it's our money. So a very interesting discussion came up, and 2 conflicting values came up, whereby one group of our citizen forum participants said, well, for certain conditions, well, we should express solidarity with anybody who is affected by a certain condition, regardless of the type of condition, regardless of age, regardless of everything. We should reimburse everything. We should express solidarity. And others who said, well, but this is public money, and the condition we're talking about here is something that patients can do something about themselves. And things came up like obesity, reduction of stomach reduction, for instance, bariatric surgery. I'm not saying I support that position, but those are values that came up. Or orthopedic surgery, people who take undue risks while going on a ski holiday. Should I, as a taxpayer, pay for treatments that can easily be prevented if people would take less risks? Smoking conditions due to smoking. So there were tough discussions, and what came out very clearly is this conflict between solidarity with people who are affected by a condition and the principle of people's own responsibility. So patients and the public may have different perspectives, and I think it's important to acknowledge that. Professor Vinod Paul yesterday called for the inclusion of services provided by private sector providers, and he mentioned that a bone of contention, at least in some states, and he referred to neonatal care as an example. And later on yesterday, the example of cesarean section, coverage of cesarean section came up. Dr. Vinod Paul raised the question, can we offer something, and I've written that down literally. He literally said, can we offer something that is compatible with the business model of private sector parties? And he was referring especially to rates, acceptable rates. Likewise, one can ask the question, can we offer a health benefit package that is acceptable to all these stakeholders, or at least to most of them? And that touches on the issue of legitimacy. Let me say up front that there is no guidelines for health benefit package design or health benefit package revision, but there are guidelines. There's no blueprints because countries are unique, and it became also very clear yesterday that states, I'm not telling you anything new, but states in India are rather unique. Context matters, so you may take different benefit package decisions in different contexts, and the exchange of international experience is very useful. I'm citing here the example of a paper from India. Dr. Prinja is the principal author of this one, where at an early stage the experience in the design of the PMJ benefit package in India was discussed. You may have seen this cartoon elsewhere, but benefit package revision, design or revision, updating, it's all about setting priorities within certain resource limits. This gentleman, I suppose it's the Minister of Health, looks a little at a loss in deciding among competing priorities. I think that's something with which we are all familiar. But the crucial thing is here, competing priorities and restricted resources. Not only budget, also manpower. That was mentioned again yesterday. You may be short of staff, medical doctors, nurses, or whatever. We in the Netherlands, we are short of nursing staff these days, which limits the possibility to provide services, and which also may affect decisions about inclusion or exclusion of services in benefit packages. Let me emphasize also that universal health coverage, we all know the principle, the concept. We are familiar with the cube, which you can see here. But let me emphasize that it's an aspirational goal. It's about services, it's about population coverage, and it's about financial protection. So there's the three dimensions of this cube, and the challenge is how to enlarge the blue part of the cube as much as possible in a smart manner. Not only in a smart manner, also in a manner which is considered fair by stakeholders. And it's these three, the issue here is how to achieve universal health coverage in a progressive manner, in a manner, as I said, which is considered fair. Dr. Prinja yesterday mentioned three basic questions: what to buy, whom do we buy from, and at what price. I noticed that in yesterday's discussion there was little discussion about the population coverage. I'm not sure whether that is something that is uncontested. You have a huge coverage. Figures were mentioned of, if I'm not mistaken, 55%. I may have it wrong. But there was little discussion about this horizontal axis, but a lot of discussion about whom to include. For instance, private providers, the axis that goes horizontally, and the vertical axis, prices, of course, and to what extent do we protect patients, and also to what extent do we reimburse service providers for what they perform. So how to achieve this in a manner that is progressive, stepwise, and which is considered fair? So these three dimensions are in fact the knobs that one has control over as a benefit package manager, if you like. Three dimensions, 3 degrees of freedom that largely constitute the span of control for decision makers when it comes to benefit packages. So it looks quite simple, 3 dimensions only. Yet, the Minister of Health, you all know that other cube, which is very difficult to put together. It's not as simple as that, and the question arises, why then is it so difficult in reality? It's not only technically challenging, and yesterday we covered the technical part of it, how to do cost effectiveness analyses, how to take into account cost effectiveness ratios, are they the dominant criterion, or what other criteria are being used, how to conduct budget impact analyses, calculate fiscal space. The technicalities are pretty challenging, but how they are taken into account is often contentious. And there's 2 other forms of complexity: harmonization of the benefit package with, I can guarantee you it's not me. There's no So the complexity comes in at least 2 other forms apart from the technical part. That is harmonization of policy instruments, how to make sure that the benefit package is harmonized with other policy instruments, and I have a slide on that, I'll come back to that. And the issue of legitimacy, how to ensure legitimacy and buy-in from stakeholders. And that's the very reason why appropriate governance mechanisms are required for health benefit package revision. And also for sustainability reasons, these mechanisms, of course, need to be institutionalized, need to become part of daily practice. So legitimacy, I provide a definition here: the reasonableness of health benefit package decisions as perceived by stakeholders. There's at least 7 different types of stakeholders. The reasonableness as perceived by stakeholders, which determines societal support and which eventually determines acceptance of decisions and sustainability. So what is required is an agreed pathway to legitimate decision making with respect to service inclusion or exclusion, eligibility of target populations, co-payment levels, reimbursement rates. And that's, for that reason, the evidence-informed deliberative processes have been developed. Methods for priority setting. I'm not going to talk about the 2 first points, gray shaded, but what we should acknowledge, and perhaps I'm repeating myself here, is that stakeholders, the 7 Ps, may have different perceptions, may have different interests, and therefore may have conflicting priorities. There's broad recognition that the process of health benefit package revision should be perceived as fair, so as to ensure maximum understanding and societal support, which is different from making sure that all stakeholders are or that all priorities and interests are being satisfied. But as long as there is maximum understanding and support of whatever decision is taken, then we could, that is something to aim for. I'm referring now to a publication by Norman Daniels more than 2 decades ago, Accountability for Reasonableness. He presented a framework, the A4R framework, Accountability for Reasonableness, that has 4 conditions for fair processes. Number 1, all relevant societal values should be considered. And as I said, different stakeholders may have different values, societal values. Number 2, transparency must be ensured for whatever decisions are taken. Appeal procedures must be organized in case stakeholders object to certain decisions, or when it turns out that certain benefit package decisions don't work out the way they've been intended. There must be a procedure for stakeholders to appeal against decisions once they are taken. And these conditions, the three earlier conditions, must be regulated and enforced. There's this slide, I apologize, is a little too crowded. Let's focus at the bottom part of it. So ideally, the accountability for reasonableness framework, the A4R framework, sets those conditions for fair practices, but it's not very practical. It has turned out, in reality, in countries that are involved in benefit package design and revision, it has turned out not to be very practical. And that's, again, one of the reasons why we developed this practical guide for legitimate health benefit package design. EDPs, evidence-informed deliberative process. There's evidence, and yesterday I think there was already a lot of emphasis on terms like our decisions should be evidence-informed, research-based, data-driven. That's uncontested. What we're doing in benefit package design and revision should be evidence-based. Deliberation is important among stakeholders, ideally involving all the 7 Ps, and that's a challenge. I'll come back to that. And it's about processes, a stepwise practical approach to support agencies, HTA bodies, for instance, not only in low and middle income countries, also in high income countries. The same applies in Western Europe, for instance, in designing or revising health benefit package. So the aim of EDPs, the eventual aim, is to make rational or fair choices across the 3 dimensions of the universal health coverage cube. Coverage decisions, service coverage decisions, population coverage, and cost. So this is how the EDP process looks like. 6 steps, numbered from A to F. And as I mentioned in the document is available on the internet. I'll provide a link later on, but it's an A5 size document, which is increasingly being used internationally. And as I mentioned in my introduction, I'll be talking to the steps A, D3, E, and F that I highlighted here, which I also pointed. I put an arrow to the corresponding steps in the PMJ management cycle, revision cycle process. Some basic premises for health benefit package updating. Any form of governance, for it to be successful and sustainable, it is key that mandates are clear and uncontested. Mandates of agencies involved. And that these mandates do not coincide or conflict with the mandates of other institutions. That looks perhaps a little like a no-brainer, but that is actually important. That is very clear who takes the eventual decision on a inclusion or exclusion or a certain rate, which agency or which person. In our country, in the Netherlands, it's the minister who has the final say. We have an advisory committee that advises the minister, but the minister may ignore the advice. He or she would have to have good reasons, but in principle, she can ignore such advice. And because of the delicate nature of the work, it is important that the agencies involved are not influenced by undue pressures of any kind, political, commercial, otherwise. Although, of course, I reiterate that, stakeholders have their own interests, have their own values and priorities. But the key word here is undue pressure. So that should be avoided, undue pressure from any of the stakeholders involved. The agency that eventually decides or advises the minister should be allowed to operate independently, free from undue influence of individual interests, regulators, practitioners, or pharmaceutical companies, which sometimes requires the signing of a no conflict. Actually, we did that in one country. All participants that were together and deliberated about the benefit package in that particular country signed a statement of conflict of interest. And some of the people did have interests, for instance, researchers who get funding from a pharmaceutical company. They did declare interests, and when the treatment was under discussion that involved a drug from that particular company, they withdrew from the discussion. And the prevention, the last point on this slide, the prevention and management of conflicts of interest must be specified in statutory provisions, including a declaration of absence of conflicts of interest. That's what I just mentioned. I was glad to see, for instance, this framework, this institutional structure for PMJ in India, which shows very clearly the agencies involved. I'm not sure, I didn't check that, but I suppose the agencies involved here all have their mandates. I'm not sure, that's for you to perhaps comment on, whether all the agencies involved have a very articulate mandate when it comes to benefit package revisions, but it's clear that those mandates are not conflicting and that they are clearly specified, also for accountability purposes. There's no correct approach to health benefit package updating and the operation of an HTA agency. But it is important to have general procedural and methodological principles that support standards of transparency, good governance, and credible evidence-informed decision-making. And in that respect, I think this document that was launched yesterday, and the other one, this is the manual, the other one is the yes, exactly. They go a long way, I think, in providing this type of transparency. So it's easy for stakeholders to verify how PMJ works, who's involved, and on what basis decisions are being taken. So if, and as far as possible, the backup by a legal act, or at least policy and procedural acts, is a must. An underlying regulatory or policy framework that sets out governance arrangements, appeal procedures, that articulates the composition also of the committees that are involved. In the first place, the advisor, the harmonization with other policy documents. If that needs to be secured, for instance, standard treatment guidelines, essential drug lists, if those tools, instruments are in place and uncontested, it makes it easier for PMJ managers, health benefit package managers, to take appropriate decisions. Perhaps an example from Ghana that came up Monday during our discussions in the JLN network meeting. In Ghana, Ghana has a national health insurance agency that deals with reimbursement of service providers. The work of the NHIA is made relatively easy because of the existence of uncontested standard treatment guidelines. Anything that goes beyond, outside, any treatment, any reimbursement that is any claim from a hospital that is not in line or that goes against agreed standard treatment guidelines, the NHIA, the National Health Insurance Agency, can easily ignore that and will not award such claims. Same goes for essential drug lists, procurement procedures, accreditation systems. If you get, if you're in charge of reimbursement or processing claims. If you get claims from an institution that is not accredited, obviously you wouldn't award such claims. You wouldn't honor such claims. Now the first step on, how am I doing with time? Taking perhaps a little. Installation of the advisory committee. This first step in the EDP process. It's important to make a distinction between the technical team that prepares and conducts assessments of treatments, of interventions, that conducts cost-effectiveness analysis, for instance, and the advisory committee or task force, the independent body, that appraises the evidence and the limitations in evidence and formulates the recommendations for the final decision-making authority. Those are separate responsibilities. I'm not sure how separate they are in India, but that is probably, from the viewpoint of governance, a thing to keep in mind. What I do know, or what I do think is the situation in India, that what you call HEFTA, the Health Financing and Technology Assessment, is it a department or unit, constitutes the technical team that does the technical work. And at the national level, at the NHA level, you have an expert committee, and at state levels, and a governing board that makes final decisions. And at state levels, you have, and I got that from the presentation yesterday from the gentleman from Tamil Nadu, you have what he called a state-empowered committee for ratification. Well, if the terms of reference, if the mandates of such a committee are clear, then I think you have a transparent process. And that is a good, an example of good governance. But the separation of those functions and mandates is important, and the articulation of what they are able to, well, what their role is. Questions that come up when installing an advisory committee are listed here. What's the role and what are the tasks of the advisory committee? What should be the composition? Who's in or who's out? In the Netherlands, for instance, we have a committee that has only 9 members. 9 members, 9 individuals that advise the minister about the inclusion of certain drugs. We have an open system, but certain treatments need to be appraised by the advisory committee based on technical work that has been done by HTA specialists, prior work that has been done by them, but they advise 9 members only, including 1 or 2 clinicians, an economist, obviously, an epidemiologist, an ethicist, and other specialties, but they sit on that committee, try to come to a consensus and reach a consensus. How can stakeholders be involved in such an advisory committee? In the Netherlands, we don't have patient or patient groups, patient group representatives in the advisory committee, but we do have a mechanism whereby patients can claim time during meetings of the advisory committee when they deliberate over a particular, take Spinraza, which caused a lot of public debate in the Netherlands, Spinraza for the treatment of cystic fibrosis, I believe. A very expensive drug, a rare condition. It costs about 400,000 per person per year, which is an enormous amount of money. There's a lot of public, it appeals to the public in the sense that children are affected, and of course children's lives need to be saved, but it's expensive. And by incorporating all such, that kind of treatments, eventually cost will rise, and our insurance, how do you call that, contributions would go up, which is not what people want. So several questions here. How should a decision be reached? Should it be reached by decision, by voting? How to avoid undue influence? Those are relevant questions. And in the EDP guide, which I just showed, you see examples of how countries go about such questions. Here you see in Canada, France, UK, Australia, etc., for instance, whether members of the committee have voting rights, whether patient representatives are or are not included, whether the committees have an advisory role or a binding, decisive role. So that is something that is a source that can be used to see how other countries go about the functioning of of an advisory committee. The number two point I wanted to highlight is the appraisal part. The appraisal, as was mentioned yesterday already, involves the interpretation of the results of health technology assessment in order to be able to eventually develop recommendations. So it involves a combination of social judgment, not always in a quantifiable manner. Sometimes you have qualitative information, and it involves, ideally, it involves stakeholder deliberation to facilitate the judgment process. The biggest challenge here is, of course, how to best trade off different criteria. But what is important here is that there is complete transparency about how a decision was eventually achieved and which arguments were put forward by members of the appraisal committee or the advisory committee in favor or against inclusion of a certain treatment or intervention. I'll skip that last point, but I was pleased to see yesterday Dr. Andres' example of the Netherlands. Cost effectiveness is often used as a dominant criteria, but it sometimes may be misleading. In the Netherlands, we had a big debate about the inclusion of both Orkambi for cystic fibrosis and also about Viagra. Viagra is proven to be cost effective, but it's not included for other reasons than cost effectiveness. The main argument was people who want to use that, it's at their own discretion, they should pay it for themselves. Orkambi, on the other hand, was proven not cost effective, or at least not at that time, not 100% guarantee that there was cost effectiveness, but it was included provisionally, conditionally. And that's another instrument the advisory committee has. One can include a condition provisionally, conditionally, and then enter into a discussion, into a debate with the pharmaceutical company about the price setting. And that's what has happened in the past 2-3 years, quite a few times in the Netherlands. Conditional approval, conditional inclusion of a treatment, of a certain drug, on the condition that the pharmaceutical company reduces its price. I'll go straight to an example from Pakistan, where I was personally involved in an exercise there where they reviewed the entire health benefit package for primary and secondary services only, excluding tertiary level care. But what we did there is, or what the team did, they provided evidence summary sheets for individual interventions. In this case, it's a simple example, but the provision of aspirin for cases of suspected acute myocardial infarction, and then rated the scores on the various criteria that they had selected to appraise interventions. So cost effectiveness, this particular intervention ranked 38 on a list of 86. The quality of the ICER, of the cost effectiveness ratio, incremental cost effectiveness ratio, the potential DALIs averted. In this case, it scored very negative. That's why it got color red. And the budget impact, which was low, and that's why it scored green, or was labeled green. And that very much helped the deliberation among stakeholders, which included clinicians. There were lots of clinicians involved in a meeting as big as, well, even bigger than this one, where people deliberated about exclusion or exclusion of a long list of conditions, which involved active participation in the appraisal process, and which eventually led to a kind of consensus, because it was a transparent process. It led to a national consensus about the total benefit package that was eventually agreed upon. I'll skip this one because it appeared yesterday in the I will not call you forward to read this one. I've simply enlarged the thing a little, and then it's still perhaps not readable. But the EDP guide has examples from several countries, Brazil, France, Germany, Thailand, and several others, about how HTA agencies go about the appraisal stage. So you can draw from that, and whether they base their decisions mainly on quantitative analyses or on qualitative, how they trade off criteria, and whether their meetings are open or closed. As I said, in the Netherlands, these are open meetings, open to the public. You can ask for speaking time, and that's what sometimes parents do, or people do. I witnessed one meeting where a mother in tears pleaded for the cause of her child about a rare condition and a very expensive type of treatment. So that really, well, is something to witness. The last step is communication and appeal, and I'm coming to the end of my presentation. Communication and appeal is the one but last step of the EDP process. It's obviously important to be very clear and open, transparent about the final result of the benefit package revision, inclusion or exclusion, rates, populations covered. But also, and you see an example here from Thailand, HITAP in Thailand, HITAP, which is quite a developed, well-developed HTA agency, which advises the government about health benefit package inclusion or exclusion. But not only the eventual result is important to communicate with stakeholders, also the process through which results were, or decisions were arrived at, and the considerations that had played a role, positive or negative, supportive or against inclusion. Part of the we call that step communication and appeal, and I mentioned in my introduction that it's important to give stakeholders the possibility to request for revision or reversal of a certain decision. Characteristics of an appeal mechanism, you see them listed here. I'm not sure whether you have that in place. We do know, I'm sure, and we witnessed a few examples yesterday where people contested the exclusion, for instance, of cesarean sections from the package. Well, appeal must be made in a formal manner, of course, and then what you see here with indicated with several ticks, it must be clear on what grounds appeals can be made, to whom you would appeal, who can appeal and who can't, minimum requirements, how the appeal will be handled. These are all aspects of good governance of benefit package revision. And as much as possible, these appeal procedures must be regulated and enforced as per the conditions of the accountability for reasonableness framework. Monitoring and evaluation, I will leave that for the sake of time, but those of you who are interested, I think these slides are going to be shared with you. So I'll skip that. To sum up, good governance and institutionalization of benefit package adjustment comprises the development and application of explicit processes, like we have seen in these documents, for the generation and use of evidence, preferably localized evidence, and stakeholder deliberation as much as possible so as to inform decisions. It requires clear mandates, clear terms of reference, and probably also some capacity strengthening, because especially stakeholder participation is not something, and it also depends on culture and history. It probably involves some capacity strengthening. One point I want to reiterate or emphasize, which is not mentioned here, stakeholder deliberation is not only to obtain buy-in, but it's also important, it may be important to improve the quality of the eventual decision, because if you leave out the perspective of one or two of the stakeholders, the decision may be, well, lopsided, maybe incomplete or inappropriate. There's examples, you can see them here, examples from the Global Commission on Evidence. There's a journal article, which one of my colleagues co-authored. So examples, plenty of examples internationally, which one can draw from. And that concludes my presentation. Thank you very much for your attention.
Thank you very much, Dr. Leon. That was a fantastic presentation, which we all enjoyed. For the next session, I'll be requesting the chair of the session, Dr. Naban Peter, Chief Executive Officer of the Arunachal Pradesh State Health Agency, to be please seated, please come and be seated on the dais. Thank you, sir. Requesting 𝒔𝒑𝒊𝒏𝒈 𝒂𝒏𝒅, Joint Secretary, Department of Health Research, to please come on the dais. Next, requesting Dr. Sangeeta Arun, Project Manager, Karnataka State Health Agency. And last but not the least, Dr. 𝒂𝒊𝒕𝒊𝒛𝒊𝒏𝒈, Executive Director and Division Head, HPQA at the NHA. Requesting Dr. Dhananjay, if you can please introduce the speakers.
We request our Executive Director Sudha Chandrasekhar also to come on dais. Welcome you all for today's another technical session. I would like to introduce our chair today, Dr. Naban Peter. He is a medical graduate and he also holds an degree in medical technology from IIT Kharagpur. He has an experience and he has been associated with health insurance schemes in Arunachal Pradesh from more than 12 years under the government of Arunachal Pradesh. Welcome you, sir, for today's session. And I would also like to introduce Dr. Sangeeta Arun, who is the project manager for Suvarna Arogya Suraksha Trust from SHA, Karnataka. She has an experience in both clinical research and claim adjudication process from more than 10 years. We welcome you also, madam, for today's session. I would like to hand it over to Abha to continue.
Thank you very much. And also introducing 𝒔𝒑𝒊𝒏𝒈 𝒂𝒏𝒂𝒕𝒊𝒏. Ma'am is a Joint Secretary in the Department of Health Research, Ministry of Health and Family Welfare. She is from the Indian Forest Services from the Himachal Pradesh cadre and has been an IFS officer for more than 30 years. She has been a part of the COVID-19 Empowered Group and is leading a number of programs at DHR, which includes the Viral Research and Diagnostic Laboratories, the Human Resource and Capacity Development, as well as the Health Technology Assessment in India, which we'll be hearing more about today. So to begin this session, I now invite Dr. Sangeeta Arun to please make a presentation on the work that's being done in the state of Karnataka about governance and institutionalization of HPP adjustment. Is that your presentation? I'll open it.
Good morning. It's a privilege to be here, especially presenting before Dr. Sudha, who was a pioneer in Karnataka. Like Dr. Leon mentioned, it's an advantage to be presenting the second day, but rather a disadvantage also because all the important points are covered. And you feel like a kid, like, oh, I'm next, oh, this is covered, what next? But nevertheless, these are certain validations and processes we've included in the state for rationalization of our state package in accordance with HPP 2022. So let me begin my presentation. Thank you. A little history about our health benefit package. Earlier, our SAST, which is called 𝒂𝒑𝒊𝒛𝒊𝒂𝒂𝒕𝒊𝒂𝒂 Surakshā Trust, initiated health benefit packages as early as 2009. It was on a pilot basis with a small scheme. However, it evolved with an amalgamation of many schemes together, like RSBY, Yashaswini, Accident Benefits Scheme, RBSK, and we formed Arogya Karnataka in 2018 with the intent of universal health coverage. Later, Ayushman Bharat was introduced, and since both the schemes had the same ideologies and syncrasy, we co-branded them as Ayushman Bharat Arogya Karnataka. About the eligibility, it's similar to the center scheme. The basic sum assured is 5 lakhs per family for eligible households. That our identification is based on the food card, the ration card, and RSBY families also. In addition to that, we have the universal health coverage, which covers the above poverty line patients as well. But however, that's on a co-payment basis. We pay 30% of the package rate, and the remaining is funded by the beneficiary. So what do we cover? We've grouped them under 4 sections. We call them simple secondary, complex secondary, tertiary, and emergency procedures. The primary treatment and simple secondary procedures are limited to public health institutions. So I think that is our main gateway to encourage patients to use the public health systems first and reduce the burden on the health system. Then we have the complex secondary procedures, tertiary and emergency procedures performed at the public health institutions as well as the empaneled private hospitals. Complex secondary procedures and tertiary procedures require referrals from PHI. This is again a very important, and we pioneers at Karnataka to keep this gateway. This ensures that the patient first goes to a private institution, he gets evaluated. If the hospital doesn't have the capability and capacity, they refer them to a higher center. The higher center could be a public institution or a private hospital. However, for emergency procedures, the patient need not go to a public health institution. He can visit any of the network empaneled hospitals. About our package, currently our health benefit package comprises of 1650 procedures across 25 specialties. All procedures are single specialty procedures. However, we have cross specialties, which are one procedure represented in multiple specialties. They are included as sub-procedures to the main code. Implant cost is a part of our main package. It's a comprehensive package, unlike the present package at the center where you have stratification. You have the procedure cost, you add on the implant cost. But at Karnataka, we have a comprehensive package which includes everything from the medications, nursing charges, the procedure costs, and also the implant. Our package rates are differential. We have differential pricing for government institutions and private. All private institutions are paid 100% of the package cost. Public facilities are paid as follows. 50% of the cost of the package for simple secondary procedures, 75% of the cost for all specialties except cardiology, and 100% for all cardiology specialty procedures. Why is this done? The difference in this amount, like 50% or the remaining 25%, is pumped back to our public health institutions, something called a revolving fund. We use this money to strengthen our infrastructure, capacity building, and other IEC activities. These are some of the special features in our Karnataka. We have an ABRK cell. I think very few states have this. This cell is an interface between the public health institutions and the SHA. Any grievance or any conceptions or any changes of plans, the first approach is this cell, who deliberate the further processes or things to SHA, the State Health Agency. Then we cover APL beneficiaries also. Like I mentioned earlier, we pay 30% of the package rate. We have the gatekeeping mechanism. We have the online referral system, which ensures that the patients are first presented to the PHIs and then referred to the higher center. Again, we have the reverse fund flow, the one I mentioned earlier, pumping back the government's money for infrastructure building. We incentivize doctors and the staff at the PHIs. We have cross specialties, around 500 cross specialty codes. And we restrict certain procedures like hemodialysis, robotic surgery only to certain PHIs. This is again, I think, one of the important aspects which prevents misuse. As hemodialysis is also present in the National Program for Dialysis, ensuring checks like these will avoid duplication of usage of packages. Then we have the formation of expert committees for approval of misuse procedures like total knee replacement and total hip replacement and cochlear implant surgery. Coming to the main discussion, the revision and expansion of coverage. With the introduction of HVP 2022, the state initiated the rationalization exercise of revision of both the rates and the procedures in accordance with the central package. This is mainly done to ensure transparent and fair participation of important stakeholders, and the subcommittees were formed to review and deliberate on various aspects of the package revision. We had 14 technical subcommittees we were constituted by grouping overlapping specialties. What did the subcommittee comprise of? It constituted a fairly balanced committee consisting of clinical experts, senior specialists from individual departments, representation from both public and private hospitals, senior program managers, and NHG representative. Our Dr. 𝒔𝒑𝒊𝒛𝒊𝒛𝒊𝒏𝒈 was our representative, so he was almost present for all our meetings, gruesome meetings, but yes, thank you, sir. And we had an exhaustive discussion with an appropriate moderation. Like sir was mentioning, there's always undue pressure from the stakeholders to include various aspects, but there was a moderation in those askings. What did we do? We structured the documentation and findings, and we fixed the accountability. All the stakeholders were asked to sign on these papers and also confirm through email their concurrence on their decisions. So what exactly we did on the subcommittee meetings or the technical expert committee meetings was, we validated and matched the procedures, the master sheet from NHA and our state package. We did a one-to-one matching of procedures, one package matched to many, and cross-specialty. If the representation of a particular procedure was justified in different specialties. And we did a price review, the appropriateness of the package rate, and rationalization. And we had opinions like why not increase the rate above and over and above these two procedures? Why not take additional procedures like yesterday somebody was mentioning about HIPAC, robotic surgeries, and high-end drugs. These were the main recommendations by the subcommittees. As you know, there's a differential pricing in HVP 2022 packages, Tier 1, 2, and 3 based on the 7th Pay Commission. However, our committee suggested to adopt Tier 1 prices across the state. This was not accepted by our decision-making committee. They said we will stick on to the differential pricing. Wherever the rates were lower in HVP 2022, the committee suggested adopting higher price of ABRK. For certain procedures, this was accepted. The committee suggesting adoption of higher procedures was accepted. Certain procedures, the committee suggested higher than ABRK and HVB 2022. This again was not accepted by the committee. Addition of certain new procedures over and above ABRK and HVB 2022. This is under deliberation. Probably we're putting up proposals for the new procedures and their cost implication. And the government institution suggested that the payment to them be made on par like the private hospitals. Right now I showed you the differential pricing where they get 50% for PHIs and 75% for complex secondary and 100% for cardiology. They wanted 100% for all procedures. This again was not accepted by our committee. The analysis of the data. Utilization and financial data availability was possible because of a reliable IT portal. We analyzed utilization data of both public and private hospitals, district-wise, the procedure categories and specialties. For new procedures which were not present in ABRK, we made assumptions for arriving at the cost implication. And we also accommodated for a possible increase in utilization about 10 to 20%. And we projected one with the actual financial implications and a probable increase in utilization of around 10 to 20%. It was deliberated multiple times because, as you know, it was an interaction between private and public sectors. Then we summarized all the packages and the financial implications were presented to the government. The ones represented in green are the ones we've completed. The processes are complete. The proposal has been submitted to the government. It's still under process. And the final decision for the amalgamation of packages is yet to happen. Now, coming to the governance and institutionalization of HVP, we, like Sir was mentioning, we've used the regulatory leverage of the act we have at Karnataka called Karnataka Private Medical Establishments Act, KPME Act. This act mandates that every private medical establishment actively participates in the implementation of all national and state health programs in a matter such that the state government may specify from time to time. So under this act, the private participants are obligated to accept our health scheme. This act promotes those participants who are not under the scheme. In Karnataka, at least, we have many hospitals, private hospitals, which are not really happy with the present ABRK package. So we've written letters to them that we are in the process of implementing amalgamation process where you have higher rates and quoting this clause of the KPME Act so that they come on board to accept our scheme. All the rates, other than this act, we have an expert committee for recommendation of uniform packages for healthcare assurance schemes. This is a committee also mentioned in this KPME Act. All these rate changes, procedure changes, have to go through them and endorsed by them before we put it on paper. So we finished that meeting also, post which we have submitted the proposal to the government. And what happens when they don't accept? So in this case, there's a clause. Like one of the governance principle is that you can use your legality or the judicial knowledge. In this act, in this clause, they say that you can raise a complaint or you can de-empanel a hospital, or if the hospital is not empaneled, you can cancel their license. So we've sent a letter for this also, to hospitals who are not participating to come on board. That was the, am I audible? That was for hospitals who don't accept to be on board for the health schemes. On the positivity, where hospitals are noted to be adhering to all the policies of the scheme, we've proposed to accept this green channel prioritization, where 50% payment of the claims is made to the hospitals upon adhering to the policies. The way forward, to be specific to the state, the financial implication has been worked upon and submitted to the government for approval. We've taken into consideration the utilization of procedures, the differential pricing across districts, adopting high rates of the two packages, implant costs, etc. The probable package will be an amalgamation of the existing ABRK packages and HPP 2022. And the packages unique to ABRK shall be retained. The future of the evolving HPP. Like ma'am was mentioning yesterday, it's always a crunch of time and we need to release a scheme and we just do which is easier. But the way forward would be using these governance principles and evidence in HPP policy making to achieve the UHC goals. The main goals of UHC are the equity. So what do we take into consideration? We form the package taking into consideration these criteria. One is the disease burden data, the utilization data, the monitoring and evaluation data, and the cost-effective data. Examples for this equity are using evidence in HPP design and stakeholder engagement. The next criteria is the efficiency. More health for the money guidance based principle, and we do a cost-effective analysis for that. The examples are, we specify methods of service provision. This we could do through our memorandum of understanding with the hospitals. We specify what are the methods and policies they have to adhere to. Treatment protocols, and using generic drugs which would reduce the costing. And financial protection, another goal of UHC. We would take into consideration studying data of out-of-pocket expenditure from the beneficiaries, study provider records. Examples for these is putting a cap on high-cost diseases. So that brings an end to my presentation. Thank you. Any questions? Yes, ma'am. Ma'am, like, I hope everybody heard ma'am's question.
Ma'am, I'm Dr. Anandalakshmi calling from Puducherry. I just wanted to know the reason behind for compliance for 50% and 75% for secondary care and 100% for cardiology packages.
Ma'am, most of the infrastructure, capacity building, and the manpower is already available with the government. So these 50% is simple secondary procedures which doesn't require much of manpower, expertise, and consumables. So we give them only 50%. The 50% is retained with us. We pumping it back to the system. 75% for complex and tertiary is because they involve a little more expertise. Yeah. 75% is because of the expertise in tertiary. And cardiology, again, we had a deliberation because initially that was also placed at 75%. But we had hospitals coming back, Center of Excellence, which is Jayadeva at Bangalore, coming back telling us that that package rate was not feasible for them, and they may be provided 100% reimbursement.
Okay.
Thank you. Thank you.
Thank you very much, Dr. Sangeeta. That was a very insightful presentation. Before we have the next speaker come on and make the presentation, we want to show you a video. So if you'll just give me a minute.
This is regarding the reservation you have shown that the simple surgeries you have reserved for PHI and secondary complex and then tertiary for private. Now just tell me how beneficiary identifies that where to go, because we were also thinking to reserve many packages, but the thing is that how beneficiary will go. Maybe they will go to private hospital and private hospital will not tell them that this is reserved for the public institutions. How actually you are implementing. On papers it is reserved, but how you are implementing to the ground.
Indian healthcare system is complex and caters for the needs of 1.38 billion people. Health system consists of hospitals, pharma industry, health insurance provider, etc. It is constantly under pressure and has limited resources.
Can you start again?
Indian healthcare system is complex and caters for the needs of 1.38 billion people. Health system consists of hospitals, pharma industry, health insurance provider, etc. It is constantly under pressure and has limited resources. Every stakeholder has their own perspective on what the healthcare system should prioritize.
I deserve the best treatment available for my health issue.
I know what's best for my patients. Let me decide what treatment is to be given.
Our latest health technologies are expensive but give better results. They should be used by everyone.
Decision making should always be evidence-based and consider value for money.
How can we ensure healthcare is equitable when resources are limited and there are so many high priority diseases to treat?
Ultimately, policymakers need to make smart budget decisions that lead to good quality healthcare services for all citizens and help the country achieve universal health coverage.
A health technology assessment or HTA can help. HTA is a widely accepted multidisciplinary process where a health technology such as drugs, medical devices or health programs is evaluated for its clinical effectiveness, cost effectiveness and equity issues. It helps policymakers make evidence-informed decision that is strategic, transparent and robust. Health Technology Assessment in India or HTAIN is a program under the Department of Health Research, Ministry of Health and Family Welfare, Government of India, which undertakes health technology assessment for the government.
Established in April 2017, HTAIN has completed more than 30 studies and many more are underway. Let us now see an example of how HTA can help policymakers in decision making.
Okay, the incidence of cervical cancer in the country is worryingly high. Treatment for cervical cancer is already offered, but a universal screening program would decrease its incidence. How do we know if it's affordable and how to roll it out efficiently? How can health technology assessment help me to find the right answers? Health technology assessment in India, HTAIN, is the answer. If I have to launch the screening program, will it be cost effective? Cervical cancer screening is rather cost-saving strategy in the long run. But considering the limited available budget, it should be first rolled out for women of age group 30 to 65 years. Screening by VIA method yields best results. Screening should be done once in 3 years.
Likewise, HTAs can be used to inform a variety of policy decisions, including introduction or removal of technology from a health benefit package, prioritization and design of health programs, efficient budget allocation, costing of health services, strategic purchasing during procurement, drafting of standard treatment guidelines. Altogether, this helps the government in its commitment towards universal health coverage. A strong health system is the foundation of a healthy country. HTA plays an important role in taking India towards universal health coverage. It is health that is real wealth and not piece of gold and silver.
I now invite 𝒕𝒐𝒕𝒊𝒏𝒈 𝒂𝒏𝒅, Joint Secretary, Department of Health Research, to tell us more about HTIN and the work it has been doing to support the updation of health benefits packages.
So very good morning to everyone, and it's a pleasure and a privilege for me to be here, and I have Dr. Shankar to thank for, and NHA, believe me, is our primary client that we hope to serve through HTA in the country. So this is known to everybody that we all know that we need to ensure quality and affordable health to our people. New technologies are coming and they are more expensive. Out-of-pocket expenditure in India is quite high, and we are also committed to meet UN sustainable goals within the available health budget. But the good point is that now we are committed to enhance the health budget. And also we are very lucky to have very good entrepreneurs in our country who are providing frugal and quality healthcare, not even to our country, but also to people abroad. So when we talk about increasing prices of technologies, and right now you're sitting here as NHA representatives, we all have this problem that rupee can be spent only once. So we need to find best ways to optimize the resources available to us, and HTA could be one of the solutions wherein an evidence could be provided to say whether a technology is clinically effective, cost effective and equitable. Does it cover the safety issues? Is it socially inclusive or not? So all these answers can be given by HTA, and we can compare the existing technologies, whether to continue with them or to undertake new technologies. Oh, I'm going back again, sorry. So these are the technologies which can be assessed through HTA: the health benefit packages, the diagnostic devices, medical devices, programmatic interventions, surgical interventions, guidelines for standard of care, drugs and vaccines. HTA, as you've heard through our previous speakers, is not something new in the world. We have more than 60 countries in the world which have HTA bodies. HTA is becoming a major tool for priority setting and creating evidence for decision making. NICE has been known for helping NHS to standardize healthcare interventions in the country. We have Indonesia, where it's important that health benefit package is first assessed through HTA before it is undertaken. HITAP in Thailand is another example that our previous speaker were talking about. And the European Parliament has come up with a joint HTA Act recently, and increasingly in many countries HTA is being used. So recognizing the potential of HTA, it was formed as a part of component in the National Health Policy 2017, And in April 2017, HTAIN was established under the Department of Health Research. So we have been since, we were first working as a pilot project, and later on with the intervention of 119th Parliamentary Standing Committee, who said that it should be broad-based. And there was a working group of ministers which was formed post-COVID, who advocated that we need a centralized HTA body in the country. In June 2021, we have a full-fledged program in the Department of Health Research. So HTA works as a three-tier structure. At the top is the board, which is chaired by member health of Niti Aayog, Dr. Vinod Paul. And we have representatives from all other important stakeholder organizations. And then we have our technical appraisal committees, which appraise the studies. And Dr. Sudha is one of our members who's sitting here. To undertake the studies, we have technical partners and resource centers, and we have 18 of them all over the country. And I would be very happy to say that Dr. Shankar is leading one of our best resource centers, that is PGI Chandigarh. And then we have a secretariat in the DHR who is coordinating all these activities, and Dr. Kavita is here with me, who is taking all this forward. So how do we actually go about it? How do we select the topics, and how do we undertake HTA? So right now, because of our resource limitations, we are not taking direct topics from the industry. We take it from the state government or the central government. And then we prioritize the topics. A technical partner or a resource center is identified who undertakes the study. There is appraisal by TAC. Then we have the stakeholder consultation. And then we take it to the board, who actually approves, and the whole recommendation comes out as a policy brief, which we share with state government and central governments to implement. So just to give you a few examples of the kind of work that we have been doing, one of the examples being safety engineered syringes, and you know that there are many adverse outcomes of unsafe injections like hepatitis B, hepatitis C, HIV. So these are few of the important diseases that could be caused by unsafe use of injections. And although we have kind of adopted safety engineered syringes in our vaccination programs, but in our therapeutic programs they are not being used. So this was a question posed to us by the government of Punjab, who wanted to adopt the safety engineered syringes, and we told them that they would be cost effective below rupees 1.9 rupees. So accordingly it was introduced in the state of Punjab. Andhra Pradesh was quick to follow, and it was also adopted in the national hepatitis guidelines of the Ministry of Health. Similarly, another example would be cervical cancer, which the video talked about. We have very expensive tests like DNA tests, but for a screening of a population, it was recommended that we use visual inspection with acetic acid, and it was found to be cost effective for a population group within 5 years of period. Similarly, we also got a question from government of Tamil Nadu. They wanted to do rapid screening of hepatitis B and C at primary health centers, and we found this exercise cost effective. So similarly, we have had similar questions on designing of programs and which activities should be taken first by the health departments, and we are trying to provide evidence to them. For the point of care facilities to be introduced in the health and wellness centers, we've been working on pulse oximeters, digital immunoglobinometers, portable ECG facilities, portable audible devices, hearing devices. So we've been working on all these issues, and we do not talk about a brand that it is we just talk about the technology, whether it is cost effective or not, and we give our recommendations to the health ministry. So another example is that recently before our minister, there was a question whether the transcatheter aortic valve replacement surgery can be reimbursed through CGHS or not. So we took a HTA of the whole procedure, and it was found that this would only be cost effective between 3 to 5 lakhs, and a corrective action was taken. The Honorable Minister immediately constituted a committee to work out the cost of the valve, which was most expensive, and we had Department of Pharma looking into it. So these are the kind of successes that we have seen through HTA. Then we've also been working on the standard treatment workflows, helping to make them cost effective. Our biggest client, like I said, is NHA, and we've been working on costing of healthcare services, and we have data showing 855 packages which were used in the PMJ 1 to 2, and we are working on more now. We have also been working on rationalization of various packages. For example, the cataract surgery packages were reduced from 9 to 2, and similarly we've also been working on other such packages. Our biggest strength right now is our National Health System Costing Database, which has data from 200 public healthcare facilities from 12 states in India, right from primary centers to tertiary centers, and I think this data would be very useful for the group who's sitting here. And this has all been facilitated by Dr. 𝒂𝒂𝒂𝒂𝒂, and I think he'll tell you more about it. Our HTA is based on very robust guidelines, and we have our own manuals, and we try to make our recommendations as scientific as possible, more and more scientific, very robust, I would say. These are the kind of activities, the interventions that we worked on. We worked on medical devices, health programs, diagnostic devices, guidelines, drugs, surgical interventions, point of care, health benefit packages, and even in the pandemic, the questions came to us regarding costing of testing kits, as well as the kind of procurement of machines that was to be undertaken. And we recommended that the Cobas machines, which were like very popular in the initial days, we found them not to be cost effective, and we recommended that the government should not go for their procurement. So right now also we are working on very important strategic programs of government, wherein we are giving evidence as to their cost effectiveness and clinical effectiveness. So these are some kind of programs that we are now running through. So we have been trying to bring HTA through a legislation, but right now we are now working on HTA board formation, a formal organization. You know, right now it's a scheme of the government. We wanted to be a permanent body so that the whole process is institutionalized. And like you have seen in the video, it will help in introduction of new technologies, removing obsolete technologies, priority setting of health interventions, streamlining of medical reimbursement packages, because the rates vary from state to state. That is obvious, but there has to be some kind of baseline that we are working on. And it will also give a kind of branding to our indigenous industry when they have an HTA tag. So this is all that is there from my side. Thank you. So, did I close it?
Thank you very much, ma'am. Can I get the computer? So we'll just give a minute. I think this morning has been filled with a lot of IT challenges. Hopefully after tea we won't have so much difficulty. Okay, so I will be inviting the last speaker for this session, Dr. 𝒂𝒂𝒂𝒂𝒂, to talk more about some of the processes that are now being institutionalized at the NHA for evidence-informed decision-making.
Thank you very much, Dr. Abha. So basically, what we're trying to show through the session today is that all what we were talking yesterday was about giving you an orientation of some of the methods that that can be applied in order to make decisions around health benefit packages. We also talked a little bit about since morning as well on the governance and the institutionalization of these methods. Now, the presentation by Madam just before me actually tried to give you an insight into what has actually been put in place within the Indian healthcare system in order to institutionalize such a method of decision making. And perhaps the presentation by Madam gives us a confidence that the experience of the last 4 years is quite robust enough for public sector decision makers, policy makers to perhaps make more and more use of such systems that have now been established. And what I'm going to talk through as part of my presentation is that what we have been trying to do in order to bring a greater interface and interlinkage between the kind of decision making that we do on health benefit packages within NHA and the DHR's HTIN program. So the coming back to the cycle that we've been hearing since yesterday, the presentation that I'm going to have right now is going to focus much more on the initial parts of this cycle, which talks about how do you accept some of the submissions or nominations for new topics, etc., and what kind of governance frameworks can we establish. So that's the fundamental part that I'll try and cover during my presentation. And the background is something that has been repeated often. Dr. Sangeeta also did mention about this fact that they keep getting a lot of submissions. There are new technologies, new drugs, new molecules that keep getting invented, and we are always under sort of pressure to consider that inclusion of those new medicines or diagnostics or other healthcare technologies. And so we perhaps may need some kind of a formal structure or criteria in order to make such decisions. I remember I was once talking to Dr. Yacht, who happens to be one of the leaders of establishing this HTA-based decision-making systems in Thailand. And I asked him that, you know, what is it that people see as an advantage of your system for their decision-making? You know, I asked him very candidly. I mean, I asked him that, do you really think that people value your evidence, or what is it that they value the most about you? He said, the policy makers, the one thing that they value the most about us is that they consider us as a punching bag. You know, so for anything that goes wrong in a decision, it's always this evidence that had guided us. Okay, but for anything that good that takes place, the credit goes to the system. So the point is that you always also need to defend your decisions. That's the point that I'm trying to make. And there can be nothing better to defend your decisions on such inclusions or pricing than to have some robust evidence that enables you to stand by what decision you have made. And in that sense, within the NHA also, we have now constituted a vertical unit which is called the Health Financing and Technology Assessment Unit, which is HEFTA. And the reason why we established this was because we wanted to have some kind of an institutional structure which liaises on a more day-to-day basis with the HTIN in order to make these decisions. And we also wanted, because as Madam mentioned in her talk, that the topics that they receive and the evidence synthesis and the generation that they do is primarily on the request of public sector organizations. Any decisions where there is a Ministry of Health or a State Department of Health or a state insurance board or anybody, it's a public sector entity who is entitled to submit any kind of a request to the HTIN. However, we do recognize that in our context, the scheme that we run, half of the overall hospitals are from the private sector and half of the claims are also from the private sector. So in our scheme of the things, it is hard to ignore the important stakeholder that exists on the private sector side. So as a result, we have created a system whereby the NHA can receive topic submissions for topics that need to be considered for inclusion within the health benefit package. And when we accept these topics could be submitted by state health agencies, this could be coming from the hospitals, industry, pharmaceutical manufacturers, these could come from doctors associations, patients' rights groups, and individuals who could be healthcare providers, doctors, etc. So the point is that we wanted to broaden the horizon of the stakeholders who can potentially submit these nominations. And we've created a portal on our NHA website to receive the requests for new inclusions. And initially when we started off this entire process, the cycle that we created for submission of new nominations was, we thought that we'll create a 3-month window which begins from April till June. And the reason why we created only a 3-month window was because we do recognize, having worked with the HTIN, that creation or generation of such evidence takes some time as well. So it generally takes about 6 months to 9 months to create such a robust piece of evidence that could be used by policymakers. And in that sense, since we are also on one hand saying that any revision in the health benefit package would have to be done on an annual basis, which should be coterminous with the financial cycle as well. That means the new package gets announced around the month of April every year. So which means that we have to finalize any package revision around March. And that means that we need to have the evidence also with us. I mean, the decision making needs to begin from between the quarter of Jan to March. So which means that we should have all evidence with us by December. And in order to do that, we wanted to have that 6-month window for us to generate the evidence, etc. So that's why initially we thought we'll keep it a quarterly submission of topics itself. But we had a wide consultation even on this issue, and which has culminated in the pricing policy document that you received yesterday. And a lot of requests came to us that no, you should not be restraining yourself to just a 3-month window for receiving these new submission inclusions. So you should have it around the year. So we've revised that. So we've said that, okay, on the website you can keep submitting us requests all through the year, but definitely as I said, and as I've mentioned earlier as well, that the process of generating this evidence takes time. And so which means that if there is somebody who is submitting a request in the month of January, it's very unrealistic for even the HTA agency to generate evidence and to send it back and for us to consider it for any kind of a revision process. So which means that earlier the requests that are submitted, the better it is for us to get that communicated to the HTIN, for it to be for an evidence to be created, and then that evidence to be used for decisions on any kind of a rationalization. And when we ask people to submit the topics for inclusion into the health benefit package, we have given them a standardized template on which to give us the information. And the reason why we want this kind of standardized information to come is because we want that there should be some, that the person who is submitting should also be able to provide us with some information that may be of relevance for us to even consider for any kind of inclusion request. And a lot of this information that we are asking are things that are perhaps also going to be of use to the HTA agency in order to do their analysis. So for example, what's the kind of disease condition that is going to be addressed by the intervention that is being proposed? What's the technology? Is it licensed? Is there any current treatment package that exists within PMJY that addresses this particular problem that their new technology is proposed to address? Is there any kind of data on impact, that means the clinical effectiveness, etc.? What is if this topic comes from the industry, then this becomes a relevant question, that what's the current price and what's the best discounted price that they would be willing to offer? And is there any existing evidence that is available on cost effectiveness, etc.? So there are a range of different issues on which we have made it mandatory for the person who is submitting a topic to provide us with this kind of information. Similarly, we are also cognizant of the fact that there might be certain technologies, drugs, etc., that may have certain implications in terms of certain legal issues or ethical issues, etc., or even issues related to feasibility for that matter. So you want to introduce a let's say, Madam was giving an example of cervical cancer screening, not very relevant in our context, but introduction of, let's say, a pap smear means that you need a lot of cytopathologists to be doing that testing. Now that places a restriction on the health system to make use of such a test for the purpose of screening at a large population level. So those are some of the examples of issues related to feasibility. Or for example, you want to introduce, let's say, robotic surgeries, but then you need trained manpower to operate on such equipment as well. So those are some of the things that I specifically refer to when I say feasibility issues. And then we also recognize that when we open it up on a portal like this, we are bound to receive a lot of requests, and we do also recognize that not all those requests perhaps may be relevant to be evaluated, and so there is some methodology, some objective criteria that we have established in order to even prioritize the set of requests for inclusion that we receive. Because we also do recognize that there is a capacity constraint even on the other side to maybe evaluate all the set of interventions within the stipulated time. And so we have laid these criteria as well, for prioritization of the topics that we receive. So these are criteria that would enable us to make some kind of scoring and place certain topics at a higher level of priority for consideration to be included, and certain topics to be placed at a lower level of this thing. And these are some examples. So for example, is there, so what's the kind of magnitude of health problem that a given new technology addresses? What's the kind of economic impact that people are currently facing in terms of high out-of-pocket expenditures that this potential new treatment, if included, could help address, etc. Then there are other issues that are listed here on the slide, and this eventually gives us a kind of a priority scoring for each of the topic that we receive. And this is again these two things that I've mentioned in the slide so far, the detailed set of information to be provided for a new inclusion, as well as the set of criteria that we would be using for prioritizing these topics. These are again provided as annexures to the policy document that has been shared with you yesterday. So once we receive the topics and once we prioritize these topics, then we either simply reject a particular topic which falls low on the priority, or we select a particular topic to be further evaluated. And in order to further evaluate, then we have options that is there no evidence available, and then if there is no evidence available, we refer it to the HTIN for assessment. If there is some evidence available, we consider whether or not this evidence is generalizable in Indian context or not. Because since yesterday and day before also, when we were having discussions on the sidelines in the JLN meeting, we realized that while we can accept evidence on clinical effectiveness of a given drug or a device which has been generated elsewhere, it's very hard to generalize the evidence on cost effectiveness given the differences in healthcare delivery structures and the costs of healthcare in different countries, etc. So in such cases, there would be some kind of pragmatic approaches, but we will consider that whether there are some pragmatic approaches that could also be considered. And this is the kind of framework. I think Leon did open it up during his talk as well. He had it on one of his slides as well. And this is just to show the kind of institutional structures that we have conceived to operationalize. And here the role of NHA is primarily only to perhaps receive the set of topics from its stakeholders, which are very diverse and go beyond the public sector. And then based on some sort of priority listing within the NHA, we shortlist the topics that need a rigorous evaluation, and those topics would then be submitted to the HTIN, which has a more formal mandate. This was being referred to in your talk as well, that which organizations. So when you have institutional structures, they should have clear mandates as well. So the mandate of actually generating the evidence is with the HTIN, because they are the ones who have all the wherewithal to undertake such assessments, etc. And so they would be the ones who would then take it forward, going through the rigorous process of evidence synthesis, generation, getting it reviewed by their technical appraisal committee. There's a very systematic process of stakeholder engagement and consultation also that goes through as such evidence is generated. In fact, once the report is generated by the HTIN, they also put it up on their portal for public viewing as well, and they invite comments from anybody who can download the report and give a feedback before it is finally put up to the board for recommendation. So there is very elaborate system of stakeholder engagement and consultation and getting the feedback from a wide variety of stakeholders. We've also we are also trying to consider institutionalizing processes whereby there could be evidence that could be used for some kind of strategic purchasing decision making. And I was having this discussion yesterday and some over tea and lunch, and I had feedback from some of the states mentioning that there should be some systems of collective bargaining and price negotiation which goes beyond just fixing the prices for the healthcare providers, but it should be with the manufacturers and perhaps the industry as well. So those are things that we are also trying to put in place. These are things which are not yet finalized and crystallized, but these are things that are work in progress. So finally, I think this is the last slide that I have. So eventually we need some criteria to also make decisions based on the evidence, and the 3 criteria that we found to be most relevant, and I see a lot of resonance in these criteria which are listed on my slide and the ones that Dr. Sangeeta mentioned in her talk, that so broadly speaking, I think there is not much difference in the thinking process between what we are thinking here and what a lot of states are actually thinking. So we do consider that interventions that are cost effective, that means that are able to maximize the health benefits to the people, should be prioritized. Interventions that have the greatest impact on reducing out-of-pocket expenditure should be prioritized. And finally, interventions that enable a greater access to care for the ones who are the most vulnerable, that means that are distributionally more beneficial to the ones who are the poor and the vulnerable, should be prioritized. And if we are able to do that, in a way, we are also making it congruous to the principles of universal health coverage, where we want to maximize the population coverage or making sure that all health services are available. We want to reduce the financial burden, and we want to make it equitable. So these are the set of new structures for governance and institutionalization of uptake of evidence and analytical methods for decision making around health benefit packages that we are trying to put in place at the NHA. Thank you very much.
Thank you, Dr. Shankar. I now invite the chair of the session, Dr. Peter, for his comments and reflections after listening to all the 3 speakers.
Thank you very much for giving me this opportunity to chair this august audience and august presenters. In fact, this is a big opportunity for me to be representing far end of the country, northeastern, and like we come here as a learner, more to learn than whatever presentations that have been made in the last day and today. We take it as a learning process, because we come from I represent a place where there are the policies are taken not on evidence base, but on pressures, on intuitiveness, whatever the bureaucrats feels like it's logical and rational. So for these learnings or whatever the policies that are being taken at the national level, for this to percolate at our place, we want, like, in fact, I'll be representing northeastern states. I feel that the policies, whatever is taken, take into considerations our perspectives as well. Because when you talk about health benefit packages, I have attended many such workshops where there are different stakeholders from different states some states they want that no, the package rate should be reduced because the financial burden for us will be too high. But for us it doesn't matter because our footfalls are less. We don't have facilities in our own states. We have to refer up people to outside our own state for getting benefits. Say like for cardiology, whatever in the consultations that we were taking, the packages that you have made, say like you have decided for procedure cost it's 29,000, or implant cost for a single pacemaker is some 45,000. But when I consult my cardiologist, the only cardiologist, and the only procedure that they do in the institution is the pacemaker. And now what they tell me is that, see sir, देखिए आपका ये जो pacemaker है हमारा इधर तो होगा ही नहीं. तो what is saying is आप जो 45,000 डाल के रखा है वो हमारा इधर 1,80,000 होगा. तो 1,80,000, how is that 1,80,000? वो कहते हैं देखिए हमारे इधर सप्लायर तो है ही नहीं, और हमारा इधर लाइक फुटफॉल्स भी कम है. वी डू मे बी 1 case in a month. तो when we do one case in a month, most of the pacemakers that are purchased directly from the suppliers. So like the supplier, they bring that all a single pacemaker for that dedicated person to the institution. So that whole process of just bringing that pacemaker itself is so costly, because no supplier would like to keep those pacemakers purchased and kept, because that turnover for a year वो साल के लिए रखने के लिए उनके पास ये क्या नहीं है, कैपेसिटी वाला ऐसे सप्लायर है ही नहीं, लोकल सप्लायर. तो हम वी डिपेंड ऑन कलकत्ता, वी डिपेंड ऑन न्यू दिल्ली, वी डिपेंड ऑन मे बी गुवाहाटी समटाइम. सो इसलिए our like the way we look at things are different, and like I think whatever like the cost effectiveness analysis that we are talking, budget impact analysis that we are talking, the HTA we are talking about, these things, if it can be started from our place, and instead of centrally यहाँ पे बैठ के think tankers लोग आके grouping, आपका जैसा developer partner should come to our place, establish an institution there, then study a scenario and give us means of doing things for us. So I think I take this, maybe this is given opportunity for me to appeal to all the development partners to please come to our place, start our study a scenario and help us give services to the people.
Thank you very much, sir. Thank you for very candid remarks. Thank you. I do want to highlight that HTIN has a regional resource center in Northeast at IIPH Shillong, so which does, and so in any topics that you have maybe which are relevant to Arunachal Pradesh, perhaps that is a center that could actually do that study. So just wanted to mention that. Wanted to open up for questions from the audience. Is there anybody who would like to ask questions from any of the speakers? Requesting if mics could be passed around. Ma'am, you want to respond? Okay. Do you want the question to be repeated, or do you have it? Okay.
Asked about the gatekeeping mechanism, right? How do a patient knows where he has to go? We have this gatekeeping mechanism, the online referral system. Suppose I walk into some center, whether it is PHI, if he has a capacity, he will treat it, or else he'll refer me to a higher center. When I go to the higher center, I have to have that referral letter with me. Initially, we had this manual referral letter where the treating doctor used to write it manually. Now we've shifted to the online referral system, which refers. And also we have our ASHA workers who sensitize patients about our PHI systems. For emergency procedures, you don't need a referral. The patient can go anywhere. So if normally the PHIs at the CHCs and the primary healthcare centers will not be doing the tertiary cares. So the patients directly go to the empaneled private or government hospitals. Did I answer your question, ma'am? Sorry, ma'am.
Package rates between the private and the public institutions.
Yes, ma'am. There's a differential pricing which we spoke about. You asked me about that 50%, 75%, and 100%. So 50% for PHIs.
No. I just want to know the package rate between the private institution where you're refunding 100%, and for public health institution it is in different grades.
Yes.
Is the package rate the same?
No, ma'am. That is what we talk. We have a differential pricing. If
no, for example, suppose you take for a single stent as 70,000. 70,000 is the same for private institution and public health institution?
Yes, because it's cardiology.
Okay, you take, for example, don't say cholecystectomy, which is though reserved for private public institution. Suppose it is for 45,000 in a private institution. Is it the same for public?
If it is reserved for PHIs, we wouldn't have it in private. But yes, it would be the same. But we don't have, if it is reserved for public institutions, we don't have that in our packages in the private, ma'am. We exclude. We have 291 procedures which are exclusively for public health institutions out of this 1650. So 291 procedures are only for government centers. So our public packages is 1650 minus this 291.
Okay. Are the private institutions aware of it, that these packages are aware? Have you done adequate capacity building for them, ma'am? Or
Yes, ma'am. After a lot of deliberations and, you know, it's a tried and tested method from 4 years, it's successfully running, ma'am.
Okay. Just to add, ma'am, in the IT itself it is restricted. Those packages are not visible for the private when it is reserved already. And secondly, rate-wise it is same, but the reimbursement what is done is different. So the packages, when we say a package rate list is the same, but when they reimburse to the public and the private at the financial level, the differential pricing will act.
Thank you, ma'am.
Thank you. Are there any more questions from anybody in the audience? Can I have a mic on the right?
This is just a comment regarding these inclusion requests in the portal, in the PMJY website also. So it will also be helpful if, is there a list of the inclusion requests that were rejected and why it was rejected and what stage it was rejected. If it's in the publicly available in the portal, it's helpful for the states to know whether some request has been given in the past by some, let's say, some pharmaceutical or pressure institutions. Because those companies may put pressure, may send a request through NHA and then come through SHA, and we know that it has already been put in the past. Another is regarding the Karnataka, madam mentioned that hemodialysis is also reserved for some PHIs. So why is even a simple procedure like hemodialysis reserved for some public health institutions?
So thanks very much. I think it's a good suggestion. We are already thinking of setting up a system of actually giving a feedback to all those who have raised. So in our conceptual plan, we had thought that we would definitely revert back to the person who has made this nomination of a particular topic. But it's a good suggestion that we can actually put up the final decision on any particular request that was received up on a portal for anybody to see as well. So that makes it more transparent and everybody can be aware of it. Sure.
Okay, I think we will conclude the session over here. So that there's one more question.
I'll have to answer.
Oh, sorry. Yes. And there's one more question also, I think, at the back.
We have the Pradhan Mantri program for dialysis at national level. So in Karnataka, dialysis through this program is run through a PPP model. So we have 161 centers which are identified, public centers which are identified to run dialysis. So all the hospitals we've reserved, these do not fall under our scheme because they're receiving funding from the central. These do not fall under the schemes. However, the other institutions which are outside this 161 hospitals, They send us requests that we have the capacity, we have dialysis machines, we have the centers, we've done a mapping, and the nearest dialysis center is like around 40 kilometers away. So based on that mapping, we sent this request to the team which heads dialysis, the directorate team which heads dialysis, and they give us that yes, you can open up for these institutions, because they do a mapping and they say yes, it's far for the patients. So based on that, we take our decisions for opening only for certain private institutions.
Thank you, Dr. Sangeeta.
Thank you.
May I have a mic over here in the center of the room?
Hi, my question is to Dr. Sangeeta that since you were saying that there have been these differences and you have a revolving fund involved, so is the onus of infrastructure also on on the state government, because you have this revolving fund? And also would like to understand how were you able to convince the public providers to be okay with this methodology of payment, restricted payments?
It's a similar committee, ma'am. Like I said, any rates go through our KPME meetings. Whether even there's an increase of 1 rupee, the committee sits and deliberates. So initially, yes, there was resistance, but we put forward the fact that public health institutions receive funds from the center. You have the buildings, you have the government doctors, the salaries are paid from the state, you have the infrastructure capacities, and all the other required manpower. So this fund is, we call it a revolving fund because they can use it for incentivizing the team which performs the surgeries or the treatment. We incentivize the ASHA workers. This boosts the confidence of, it's strengthening the public health system. So when you're pumping back the money, there is a fair distribution to the entire team. And it also helps in strengthening their IC activities somewhere where they don't find funds, like procuring some, a digital computer or, some X-ray machines and OPGs. They use these funds to, strengthen their systems.
Ma'am, one question last. Ma'am, when you said you want to strengthen it, we are giving only 50 and 75. So the public health is not getting its full flexibility.
Ma'am,
and the load is also there in the public hospital.
No, this is over and above the already formed system, ma'am.
Already formed only, but the public system is strengthening will not happen when you give only 50 and 75 and 100, no ma'am. You're giving full thing to private hospitals.
Ma'am, earlier we weren't giving that also. So the systems were running quite well. When we were not pumping in the money back to them, the systems were running. They weren't under the scheme. They didn't know that you will get something from the scheme. They didn't know they had a revolving fund. So this is augmenting what they already have. So it is, yeah, like Sir said, it's a state-specific policy.
Okay.
And there were requests, ma'am, as I presented, the government institution, requested that they be paid 100%.
That is
there. That's placed for
deliberation. That's what I feel.
All right. It's placed for deliberation, ma'am. Thank you.
Thank you. I do realize we have one last question from an international guest, and maybe we could end, if the speakers would permit, on the left-hand side. And we don't want to hold you back from the tea break, and we are running about 15 to 20 minutes late because we had a late start in the morning, so we'll end after this question. Please go ahead.
Yeah, my name is Ruby, and I'm from Ghana, the National Health Insurance Scheme of Ghana. In Ghana, we implement our benefit package across both public and private facilities, the same package. Once your facility is credentialed to provide service at a certain level, whether healthcare level, if you're private or public, you can provide that service. So I would like to kindly ask for some understanding on the rationale for reserving some procedures for only private facilities. Is it because of the capacity, or to reserve a segmented, to keep them in business, the private facilities, I mean? Thank you.
Ma'am, these 291 procedures which we are talking about, the simple secondary procedures, these do not need an expert. You don't need the specialist. These are simple procedures like, attending to a diarrhea or a simple illness, any simple illness, a laceration, a wound closure. So the public health institutions, we have doctors just with an MBBS degree, right? So these patients go to them without, they don't need any additional skills. So these 291 procedures are simple procedures. They don't need an expert, expertise to handle them. So we're strengthening the public system again.
Thank you. I think we do need to end the session now. But before we leave, I want to request Dr. Shankar, if you could start by giving a token of appreciation, a memento to Dr. Peter. Please, a big round of applause for our chair. Now requesting Dr. Sudha, please, if you can give a memento to 𝒔𝒑𝒊𝒏𝒈 𝒂𝒏𝒅, Joint Secretary DHR. Dr. Shankar, request if you can give the next memento to Dr. Sangeeta. She's made an excellent presentation, elicited a lot of questions. A louder applause. I think everybody's tired now. We need tea. Thank you. And last but not the least, Dr. Sudha, if you can give a memento to Dr. Leon for his amazing session on governance and institutionalization of updating our HPPs. A little louder applause, please. Thank you. Thank you. So we'll break for tea, and please come back in 15 minutes. We do want to start the next session on time and to end today's day on time. So thank you. National and subnational experiences on how good governance principles are applied to institutionalize evidence-based processes for updating health benefit packages. For this panel discussion, I invite the chair of the session, Dr. Sudha Chandrasekhar, to please come on the dais. Also inviting Sheena Chabra, Senior Health Specialist at the World Bank office in Delhi, who is the moderator for the session. I now invite the panelist, Dr. Pankaj Arora, Divisional Head NHA, Dr. Priyanka Lalwani, Dr. Ajay Tandon, Lead Economist at the Health Bank. And we have two international guests. From Kenya, we have Dr. Samson, who is Head of Department, Benefits and Claims. And from Indonesia, we have Citra Jaya, Deputy Assistant of JKN Research. Please, if both of you could also come on the dais. Requesting all of you, please take a seat. You can continue the conversations during lunchtime, but we really need your attention and participation for this panel to be meaningful. Requesting for people who are right at the back of the room, please, if you can be seated. Yeah, okay. Thank you very much. So I want to introduce the moderator of this session. Sheena Chabra is a senior health specialist at the World Bank office in New Delhi. In her career expanding over 3 decades, she has a very strong track record of impacting both national and state health programs related to a wide range of activities from universal health coverage, reproductive, maternal and child health, infectious diseases, water and sanitation. In areas, again, a very wide range from health policy and strategy, health financing, health systems, public-private partnership, as well as monitoring and evaluation. At the World Bank, she leads the technical advisory services that are provided to national health financing programs, which includes ABPMJY, and she also advises the work done by Niti Aayog and the Ministry of Health in the annual State Health Index. Before joining the World Bank, she was working in the Health Systems Development Division of USAID, and before that she was a senior project director at the Social and Rural Research Institute, and also has at one point been a lecturer at Lady Irwin College. So handing it over to Sheena Chabra to introduce the panelists and take the session forward.
Thank you very much, Dr. Abha Mandirota. I think we have a very exciting panel here. We've been talking a lot since yesterday in terms of governance and how in terms of that plays a role in terms of the evidence that is generated and what finally happens to the health benefit packages, what gets in, what gets out, at what price the packages get in. And also, you know, we have been talking about various things in terms of whether there are clearly laid out processes or not, what is the kind of stakeholder engagement that one has in that, are the decision making evidence-based, are they transparent, are they communicated well to all stakeholders or not. So there have been many issues that we've been talking about. And with those constructs, I think what we are going to attempt to do over the next hour or so in this illustrious panel that we have, we are going to be looking at actually distilling experiences both at the national level as well as at the subnational level to see how do these governance principles really play out in terms of optimization of benefit packages and in terms of looking at how we go about updating those. So as we look at it, I'd like to very quickly introduce our panel. First of all, I'd like to introduce our chair, Dr. Sudha Chandrasekhar. As I say, I'd like to introduce her. I think everybody in the room knows about her, but we couldn't have hoped for a better chair because Sudha really brings in the rich experience of working on health insurance and also on other health schemes, both at the subnational level as well as national level. And she has the unique distinction of working at the technical level, at the programmatic level, at the policy level. And she comes with very skills which range from, she's an MD in community medicine. She's also done a master's degree in health economics and pharmaconomics. She's also a PhD in health economics from the London School of Hygiene and Tropical Medicine. And I also know that recently she's done courses on ethics and legal aspects. So she really comes in as a very rounded person to very aptly chair this panel. We also, in terms of, and I'd like to move on to the other panelists that we have. We have Dr. Pankaj Arora with us, who's a director at NHA. And among other things, he really leads the convergence initiatives at NHA, which looks at the merging of the different schemes. He's also now been tasked to look at issues related to empanelment of hospitals, operations, claims, adjudication, etc. Then I'd like to introduce my other panelist, Dr. Samson Kohora. He is the head of the department from the Benefits and Claims Management at the National Health Insurance Fund. And this National Health Insurance Fund is a national social health insurance in Kenya. So to my left, we have Dr. Ajay Tandon. He's a lead economist with the global H&P practice at the World Bank. And he comes with a PhD in economics from the Virginia Tech, and he also has a distinction of working with other development partners, ADB, WHO, and also has had the visiting research appointments at both Oxford and Harvard. So you can see the kind of panel that we have packed here. Then to his left is Chitra Jaya, who is a Deputy Assistant Director of Research and Development from the BPJS Kesehatan, which is the Indonesia Social Health Security for Health Agency. And to his left is Dr. Priyanka Lalwani, who is a Senior Hospital Consultant from Chhattisgarh State Health Agency. So welcome to all the panelists. And with that, what I'd like to do is to turn to Dr. Sudha Chandrasekhar to just help us set the context of this panel. And then the way we are going to run the panel is we have specific questions that we're going to ask each of the panelists. And at the end, we are going to open it to the participants to be able to ask questions to any of the panelists that you would like. So that's how we are going to try and run. I also know Dr. Abha told us that we are running a little late and we should try and catch up. So what I would request each of the panelists to do is to be eloquent and, in terms of be comprehensive in their responses in terms of how they take each of these questions. So over to you, Dr. Sudha.
Thank you, Sheena. The main intention of this panel, especially for the state health agencies who are represented here, is to ensure how you can have this processes done and embedded within your state health agency strongly. Because it is very important that whatever you have heard will not work out with just some champions in the state health agencies who are very transient. So we need to make sure that the processes are so strong that the institution will take it up forward, and I was very happy to see Karnataka that is doing quite well in the processes, mainly because we had those legal measures wherein we had the KPME amendment in 2017, where we were very explicit on how we are going to handle the health benefit package processes and setting pricing and how different stakeholders will be involved in that. So in that sense, certain legal processes and Clinical Establishment Act is actually there in all the states. So that is one measure to use it to institutionalize the process within your SHAs, and also to define and document and communicate to all the stakeholders what is the the best process you will follow. So how do we institutionalize that? And I think that is, I can see the experiences already coming up from Chhattisgarh, how they are doing it. So it is important that we listen to both the international and the national experiences. And I think it will be a very enhancing session for all the participants here.
So I think I'm going to begin with Dr. Samson Kohara. Can you share with us what is the framework that you use in Kenya for really looking at decisions related to the health benefit packages? What's the kind of framework that you have for revising these packages? And as you allude on that, you can also talk about what some of the challenges that you face.
Thank you, Chair. Just as a brief introduction, Kenya is a country on the eastern side of Africa with a population of about 51 million. And this translates to about 12.74 million households that need to be covered as far as UHC is concerned. The National Health Insurance Fund is a social insurer, and after a piloting exercise that was done across 4 different counties, it was decided that the health insurance platform would be the best way towards scaling up towards UHC. Now, as regards the question on the framework that we are using, yes, we have a national framework that has been adopted within the fund to inform what needs to be done towards UHC. The framework has 4 pillars. The first pillar is what to buy, that is in terms of the product. So to be able to identify the product, we have a 12-point criteria. 7 points are regarding the micro factors, that is at the patient level factor, and then 5 points are at the national level factor. So that's where the health sector priorities as far as the government is concerned comes in. The guidelines comes in. The micro factors includes things like what benefits are likely to shield the population from catastrophic health expenditure, the prevalence of particular conditions in the country, the issues of equity, and the issues of sustainability. Then the second pillar is on where to buy them from. I think in the earlier panel there was a discussion about what is used to inform whether to buy from private facilities or government facilities. So in the country we seek services or we buy services from the private, the government, and also the mission or the faith-based facilities. And how we do this is we categorize them into either comprehensive contracts or non-comprehensive contracts. So regardless of the ownership, if a facility has a comprehensive contract, then the rate of reimbursement will be the same across. Then the other bit is how much we reimburse for this. So this dictates the amount that is going to be reimbursed and what needs to be met out of pocket. So in surgeries like cardiac surgeries, not the full amount is met by the fund, but then the out-of-pocket payment is defined. And as a fund, we have a target of reducing those out-of-pocket payments over time. And then the fourth pillar is regarding the monitoring and evaluation indicators. So we have criterias like the service need criteria, so that we identify areas in the country where there is a particular population needing a particular service, but then the number of service providers are low. We also have indicators like the medical loss ratios. We have indicators like the solvency ratios and all that. So those are the four pillars that inform the framework. Thank you.
Thanks very much, Dr. Samson Khora. I'm going to come back to you with some follow-up questions. But before we do that, I'm going to turn to Dr. Ajay Tandon. What do you see, Dr. Tandon, in terms of the 2 to 3 biggest challenges that you see that really face, in terms of, if you look at governance, and which related to benefit packages that you see, what that PMJ may be facing, or also in terms of globally what you see some of the key issues?
Thanks very much, Sheena. I think I'll focus more attention on global experiences. I think there are many people on the dais here who are much more knowledgeable about PMJ, and I'm also afraid to criticize PMJ sitting next to Sudha. No, I'm just joking. No, but some of the challenges that we see emerging globally, especially as countries move away from supply side financing towards this demand side insurance financing, where there's a separate purchasing agency that then defines a benefits package and raises financing, and sort of takes over a lot of the financing functions more generally in terms of revenue raising, pooling of the revenues, risk pooling, as well as pooling for redistribution from the well-off to the poor, but also in terms of the purchasing, what is it that you're going to buy in terms of the benefits package, but also how is it that the providers are being paid. One common challenge that we see is really one of capacity. So the capacity weaknesses, just in terms of, in some countries, it's an issue of just not having enough staff, not having enough, the quantity of people that's required to run these agencies, which now have taken on a very different role than the sort of the traditional supply side MOH financing role. And even in some situations where the staffing is adequate, I think just in terms of the ability of the staff to carry out some of the functions beyond some of the basics are a key challenge that we observe. So in some cases and in some situations, this is also true in the case of India, some of these agencies have been able to contract out some of the things, not in terms of necessarily defining the benefits package, but in terms of processing, so using third-party administrators, or as is the situation in India, in some states, you pass on some of the things to insurance agencies. But even there, to be able to manage and steward whoever you're passing on some of these aspects are a key challenge that we are focusing. And so I think that is something that needs to be taken account of, and also within countries, differing capacities across states or provinces is another thing that we often see. The second biggest challenge from a governance point of view, and again this comes up over and over again, is who is accountable for what. So it ends up happening that many times when these purchasing agencies like NHA or BPJS under Indonesia are set up, there's an incomplete transition of roles and responsibilities. So it looks like now that there is sort of a tripartite thing emerging with MOH on one side, the purchasing agency on the other side, and then you have the providers. But many times these purchasing agencies are actually not empowered to take on the full range of roles that allow them to play, fully participate in taking over the health financing function. Often this leads to confusion as to who is accountable for what. In Indonesia, for instance, their purchasing agency does not set the benefits package. Their purchasing agency does not set the reimbursement tariffs. All of that is still done by MOH. And so in the case of Indonesia, in principle, nothing wrong, but at least as long as we are clear what is then BPJS held accountable for. I still remember many years ago when I visited Indonesia, I used to cover Indonesia, the agency told me, we are not a health agency. And I was so shocked to hear that. They're like, we are a financing agency. But then they are held accountable really for paying claims on time and sort of taking some of the decisions that have been made by MH. So I think this other key point challenge, that not clear what is it and who is accountable for what separately, but also collectively as a system working together. What is it that we are holding these different agencies accountable for? And finally, just very briefly to also mention that I think somebody also in the audience raised this question. The other challenge we're seeing over and over again, especially in Asia, in East Asia, in South Asia, is this whole thing where, yes, they're coming up with sort of demand-side financing and a purchasing agency, but then the purchasing agency actually doesn't do the full reimbursement. So the public sector continues to get financing from the government budget. So a lot of the salaries, the equipment, the medicines, and so on and so forth. Again, I won't use perhaps India as an example, but Indonesia, it is still paid by the government. And we used to always ask them, what is the role of the purchasing agency? What is it that they're paying for in the public sector? And typically, they're paying for what used to be collected as user charges earlier. So it's a top-up on top of what already the government budget pays. Now, again, nothing wrong with this. In fact, this can be leveraged to very good effect. If some partial financing is given from the demand side, you can tie it to quality and so on and so forth. But more often than not, we see a lot of confusion as to what is it that you're buying with sort of this partial reimbursement, and how do you compare and contrast with the private sector, which doesn't have this subsidy coming from the government budget. And so there's a lot of cost shifting onto out-of-pocket spending and private insurance that tends to occur. So I think these sort of are very common challenges that countries emerging on this pathway tend to face, and I think there are also a lot of lessons to learn from each other.
I think, Ajay, you raised a very important point in terms of, in the previous session, we saw the Karnataka experience where in terms of the benefit package prices were same, but what actually got reimbursed to the public sector was, in terms of variable between 50 to 100% depending on the type of package. There's also this whole body of work which I know NHA is doing in terms of looking at how do you move from schemes to systems, looking at how do you use the, there is a whole guideline which is available on how do you look at the PMJ revenues that are being generated. in the public hospitals, how do they get plowed in, whether to look at augmentation of infrastructure, looking at gaps in consumables, looking at incentives for the service providers, etc. So I think that this is a very important point as we look at in terms of improving access and expanding to both public and private and panel providers, how that can be done. So really interesting point on that. And I think this sort of raises the next question that I have for Dr. Pankaj Arora, and that is, if we look at universal health coverage and ultimately we look at in terms of merging of the different risk pools, and perhaps if we wanted to move towards one nation, one scheme, where all for reducing fragmentation, what is your, and I will come to the challenges in a bit, but first I wanted to talk about what do you see the opportunities for really merging different health schemes, be it the central government health scheme with other state employee schemes and insurance schemes, and there's so many other schemes, whether it's for building construction workers, ESIS, etc., with PMJ. What do you see as some of those opportunities, if you can allude to that?
Thank you, Sheena. A warm welcome to all the chair and ladies and gentlemen in the meeting. So definitely the Government of India has a vision of integrating several schemes. We have integrated few already. One is CGHS, which is the largest scheme at present for the government employees, and we are integrated ESI in 157 district, going on maybe into all states except 4, and BOCW we have done with states, and several states are asking us to do it for them, like Uttarakhand, Uttar Pradesh, Nagaland. They are coming up with asking us for putting up a scheme for them and converging on a single IT platform. Now coming on to a question that one nation, one scheme, and how does it help for convergence of these schemes? Yes, definitely it takes care of the fragmentation, and even we have seen a deduplication helping us reducing the number of people which are enrolled in both. But the most important thing is that the beneficiary get the thing cashless on a single IT platform, and everything is recorded. And there's a lot of data which is there, and there are a lot of things which can be coming out of it as studies which can be used further for strengthening our health system and giving the benefits to our beneficiaries. For the hospital, it's a win-win. They get all the things on the IT, and they can check anything and everything. Earlier, the bills were lying in the offices, and you need not trace it where they are. Actually, now they are visible. We have a dashboard. Hospital can see where at which level they are, and when they're getting paid, they get the UTR immediately. They can reconcile everything immediately. These are the things which really are needed at present, and I think we should integrate all the scheme in one as such, because all are government beneficiaries. But that is a policy decision, and if it comes, it will help us in zeroing it in fragmentation, and as well as giving us the power of doing collective bargaining more so with these hospitals. For example, Uttarakhand has done so. They are nearly to covering 90% of the population. So hospitals, things depend on the government now, that what is the rates they decide. The hospital can be asked to give it low if everybody is getting treated at that place. So definitely I think this is one step towards one nation, one scheme, and for UHC.
Great. I think you've told us what the positives are. Being on the other side, where you're really trying to work on the convergence of the different schemes. I know in terms of BOCW, CGHS, also working with state governments in terms of looking at integrating their schemes with PMJ, etc. So what are the kind of pain points are you seeing in terms of, as you look at this merger, especially in the context of the health benefit packages? And as we look at this merger, not only the pain points and the challenges that you see, but in terms of what you're doing to address these or what you're planning to do, I think what could be potential solutions? We'd like to hear those.
Thank you. It's a really important question. There are two things now. One is with the state thing, which is like BOCW. BUCW is actually a state perspective. The state, they are a tripartite agreement, and the state welfare board does that. And definitely there are problems in the logistics of it, and getting the things done getting the agreement on and getting them on board, because there is a third party involved. So it's always difficult to get the work done rather than doing yourself. That is only the one thing, but definitely where it has come up, they are really happy. The people are getting the benefits, which they were not actually. They were running otherwise here and there. Now they are getting in on IT. They have a card. They go. They get treatment. Nothing to pay. Absolutely marvelous for the beneficiaries, and similar for the hospitals. Now coming on to CGHS. Now there's a big question there. It's totally different than PMJ. PMJ is, as you said, what about the packages? So this package-based thing, you have everything in one bowl. But CGHS is a line budget item thing with a base price, and there are few challenges in the way of claim adjudication also. They need a lot of checking to be done, as there's not a package. You have to check each and every item, and a lot of fraud can happen, and you have to be very more vigilant than the PMJ type of stuff, where only a package is there. You can't overprice it actually. And coming on to the solution, you were saying what we have thought about it. We have to integrate the standard treatment guidelines, as I was discussing with our HPV team and SDG team. We have to have them in place as in PMJ, as well as we have to think about shifting ourselves up a ladder into the package system in CGHS also, or for that matter any other scheme. Because if you have to grow and you have to do the things at a national level, at one nation, one scheme, you have to have similar pricing, similar packages, all similar things. Right now, NHA is doing both. We have PMJ running on our platform, we have CGHS running on our platform, and we offer those to all the convergence projects. If they want PMJ, yes, well, please welcome, these are the rates. If we have to go for CGHS hospital, these are the rates. But in a long run, if we have to run the scheme properly, then it has to be the hospital-based package thing. Thank you.
I think you raise a very important point in terms of what could be the possible roadmap going forward, and incorporation of the standard treatment guidelines could be in terms of the very next step. I think that's a very important point that you raise. The other aspect, what really happens, and we are seeing that with the schemes which, if you look at for government employees, etc., where there may be different benefits that one gets with the different kind of rooms, fully paid, etc. So if you look at those, how do you integrate some of those aspects with a 100% government-funded scheme where some of the non-clinical benefits may be different?
Yes, so we are going to work, we are already working on that, and for example in CGHS we already have the criteria of the beds and private wards and semi-private wards, but yes, PMJ hospital we are running with only general ward at present, and we have recently set up a committee, and we are studying how and what rates will be the right rates to go nationwide. And I think we will be coming up with this policy of giving those rates and available in the PMJ hospital, so that if the packages above, over and above, they can get the benefit of the room and all. Just one point I'd like to add, the one thing which states and CGHS or any other scheme which will be benefiting right now is that they usually had to get reimbursement done earlier. On this IT platform, it's cashless. Hospital can follow up with the agencies which, or the institutes which they are giving this thing. Earlier in reimbursement, the hospital used to charge anything they wanted, and the patients used to get only the CGHS rates. That was really unfortunate. They were paying 3 lakhs and getting 50,000 out of it. So this will make that thing go. That's a big pain point actually. And being a railway officer, I've worked in railways, and a lot of payments which we reimbursed were really peanuts actually to the amount of pastries spent. So you can't compare pastries to peanuts actually. So we have to pay for peanuts as peanuts, not for pastries. Thank you.
That's an excellent point. I'd now like to move to Chitra Jaya, and I know that I think we've got our name tags a little mixed up here. With Chitra, I think the question that I had was about 6-7 years back, Indonesia really moved towards integrating 4 different health insurance schemes into a single payer scheme. And given that there was very strong political commitment that actually got you to merge the different schemes, and that political commitment was also backed with strong regulation and legislation, and what Indonesia is facing now are fiscal deficits. So given that situation, what has been the experience in terms of really addressing those? What are the kinds of steps that you've taken? What's the kind of roadmap that you look at? So would love to hear the Indonesian experience around that.
Yeah, thank you, Sheena. As you mentioned, the national health insurance in Indonesia is a product of a integration of 4 major health insurance schemes and another more than 100 state health insurance. So the process has been extremely long. So we took about 10 years to the 4 national health schemes to finally buy in and integrate with the national scheme. And not to mention the other hundreds of local schemes that we need to advocate individually in order for them to join the scheme. And because of the strong pressure from the members, particularly for those that belongs to the better health insurance benefit, that they want guarantee that they will receive at least the same level of services once they join the national health insurance, then the government made a political commitment to make sure that the national health insurance benefit package would be at least the same as the best that is available. So a budget impact analysis was conducted, and it shows that the government will not be able to cover those expenditures, but the government, because of the commitment, continue to approve the schemes. And as you mentioned, we are experiencing financial deficit, at least in our first 5 or 6 years of our implementation. So, but because of the strong commitment, again, the government are willing to cover all the deficit. But at the end of the 5th year, I think the government have said enough is enough, and the president have made a strong instruction to the Minister of Health. You need to do something about this. And one of the clear instruction is about to revise it, at least to review the benefit package. So unfortunately, the revision of the health benefit package in Indonesia is influenced more by the financial deficit. So there's the analytical framework, the governance framework that was presented yesterday was conducted sporadically rather than systematically. So some data was used, some projection was used, but fortunately at the 2020, the government finally decided to increase the contribution rate, and currently the financial deficit is no longer exist. So what have been the process of revising the health benefit package during that financial deficit era there's no really continuation on that, and right now the government is shifting to focus more on the national health targets and which targets are not being achieved yet, and how to ensure that those targets can be implemented into the health benefit package. So that's currently what's happening in Indonesia.
I think I had a follow-up question on that in terms of, as the government has increased the contribution, what do you see in terms of the response to that increasing of the contribution, and how is that being managed?
Well, as usual, all increase in contribution will result in protests, and it's become something that is a common thing because we've done it a couple of times. But eventually, because we started with a population with a very low health insurance literacy, but along the time, people understand that the importance of this scheme, and finally they understand that, okay, this increase is necessary, and the government no longer can afford covering all the deficits. And it is also backed by the low health utilization during the COVID pandemic, where the pandemic is covered by the government budget outside the health insurance budget. And also the COVID pandemic increases the health awareness of the society, and then become more aware that, okay, we really need health insurance.
I think talking about the engagement of the stakeholders in communication, I'm going to move to a subnational experience and move to Dr. Priyanka Lalwani, who's from our SHA Chhattisgarh, to really understand in terms of how the different stakeholders have been engaged in the whole process of updating the HBPs, what processes have you followed in the state to ensure transparency, and you know, in terms of have you faced similar kind of resistance that was mentioned by our colleague from Indonesia. If you could just reflect on that.
Yes, thank you, Dr. Sheena. This I am from the Chhattisgarh, and it is in the center of India, just neighbor of our Madhya Pradesh, and we can see the sister or parent of our state. Our state means got separated from main Madhya Pradesh in 2000. And there were state schemes, state-sponsored scheme at that time, tertiary, for the tertiary. Rest of the things were like fee for services. The first scheme, I remember we have started in 2004, and at that time it was a political thing, and we started with few 30 procedures, that too with cardiac, and those who have the expert said, we want to include this. Even an injection also was there in our list. That injection, I think, is hepatitis vaccine or something. So I joined in 2010 after my experience from private and other department. Then I saw this 30 DCs in our HBP at that time, 2004-05, was so hit in our state that 30 diseases they are covering. Actually, this is not the 30 diseases. It is actually repetition of the things. I have seen diabetes mellitus they have mentioned. Then in the other 30, you will see that they are giving insulin. So see the kind of packages we were having. Now this state is having, before experience of IAB PMGY, we were having RSBY. That RSBY we have universalized with our APL population also, and we given this name is MSBY, Mukhya Mantri Swasthya Bima Yojana, along with RSBY. That was of rupees 30,000 per annum per family coverage. That 30,000 we were able to cover the secondary care, that you can say the primary, secondary or not complex. But still I have seen in this our package list, we have included very high-end procedures, not cardiac or cardiology, but I have seen that we have included urology and few surgical cancer surgeries, like you will see Whipple surgery also at rupees 28,000. So whenever we used to visit hospital and we used to meet experts, they started scolding in almost all meetings. What have you made it? And we referred it from CGHS and all. Actually, this was given from this mole. At that time, it was from the mole. So we didn't say it. Still with rupees 30,000, we tried to manage it, how to make this list more viable so that our stakeholders, especially I'm talking about providers here, they accept it. But still we have not removed this few procedures which are very of high cost, because somewhere we said, even our bureaucrats also said when we used to visit different districts, at least you keep this in list. Some kuch to madad milega, means they are also accepting that somewhere will be there is OOPE. So we didn't say ki this surgery, particular surgery is definitely going to have out-of-pocket expenditure, but we have kept so that at least kuch help to ho jayegi beneficiary ki, that is in our back of mind. Although we have said in our definition that this is now the beneficiary need not to pay anything in private, but we know actually what is happening in our practical this field. Now in 2017, I precisely don't remember it, but which year, but we shifted to rupees 30,000 to 50,000 for our state only. We have increased to this financial coverage. When we got this 50,000, we thought to include some of the cardiology procedures, simple procedures, and we were happy that we are going to add this cardiology thing, simple few surgeries, and we added. During this time, we started thinking of making this HBP more practical. When we wanted to add, in our process of HBP defining, we wanted to have our experts' opinion, but this cannot be done in a day or two. It took us at least, I remember, 12 months with each specialty group to sit and understand what they want. And it was not just one sitting with a specialty. There were, first we given this with a group, like few trust hospital, government hospital specialist and private hospital. They, at least with each specialty we took 3-4 meetings to arrive at one list. That is, actually we haven't gone through this HTA and something, all this technology. We were not aware of it, that someone is doing all this thing in our country. So what we did, we taken all this South State package master, because I have seen they have done already very good listing of Arogyashri, then in Tamil Nadu also, Karnataka also, and I think Maharashtra also I have seen. So we made it comparison, whatever we have and whatever they have. We have seen the drastic gap is there. It's big lengthy, because we have done a lot of work in HBP. So we made it comparison. The name is also similar in South State, but we over here was having very short name, non-defining, and it is very vague. So we thought to include even the nomenclature defining also. In nomenclature, we also included when to book this thing under a scheme, because otherwise if we write something, they will book for anything. So like we have made it bracket of some stone size also. Now it is a part of STG, not currently, but at that time we have made it in the package name itself. So this took us at least a year to reach out to some proper form of HBP. But what is that? After that we have done the technical work. This is all technical. Now it is, we have to present it to our authorities, to policymaker and all what we have done. They appreciated our work, and then it comes like some change in our government. In meanwhile, there is 2018, we got a change in government. Now they said we have to converge this scheme. Now we have a state-sponsored scheme and this ABPMJY on the other hand. Now our big hospitals, they want to work with only this state-sponsored scheme. They were big protester for this. They don't want to get this ABPMJY with us. So there are 10-12 hospitals. They don't want to work with PMJY. Now with the convergence, they were having very protest, we will not work. Now our political leader, especially Honorable Health Minister, they asked them, and he started visiting different divisions. We are having 5 divisions in our state. He started from the north of Chhattisgarh, because his Vidhan Sabha Kshetra is there. So he started, we all moved to his place, division. He held this 2 days meeting, and he asked all PHC, CHC doctors and private doctors, and he opened forum for HBP. I have never seen such a meeting in my life, that all are sitting here, all doctors, they started saying about anything, and he's listening all this. Then next he went to the south of this Chhattisgarh. Chhattisgarh is having like a diverse thing, means there you will see in the south of these things is an Naxali affected forest, dense forest, and in the south, north you will say coal part, mining things. So you will see that all are having some different inputs. For the same thing they have said something else, and the other thing is just contrast of that. So we were listening and minutizing everything in the all 5 divisions we had, and it took us month with him to visit all these places. And I was the person, and along with my team, who is writing everything, because in next day he asked kya kya bola mere jan ne, and I have to note it down, and you have to give it in your converged scheme with ABPMJY. So it is ABPMJY, how will we include all these things, what these people are saying? Because there is another body, NHA. Means it is SHA, it is political, and then it is NHA, we have to explain them also. Because this is a state specific thing. They will always say ki you have to have uniform, and how in a state with this, it's a federal structure, how will we have uniform things? So this is in our mind, definitely we are going to face something from NHA also. And it was there. Then we got approval from state and everything. In January 2020, we conversed and we launched our ABPMJY DKBSSY. This one name we have given, we have to use one master, same TMS, BIS, everything. Now it comes with the HBP. Everything we have implemented except HBP, because we have not received anything from approval from NHA, and we have implemented converged scheme except one thing, HBP. But we cannot disclose that we have not yet received implemented HBP to political leaders. We said okay, everything is okay, now we are having everything. We have reserved packages. That reserved packages also is having some principles which we have to follow in our state. We had a meeting with our, there is a SHRC, State Health Resource Center, and you must be knowing Jan Swasthya Sahyog, they are in our committee member. They were helping me since beginning in almost everything, and they are like partner, means stakeholder partner. They helped us how to define this government reserved thing in our ABPMJ scheme. So we took 2-3 principles that the particular procedure must be available to all public hospitals. If not available, we have to do CAB analysis and we have to provide that facility so that they can do. And second, it must be abuse prone, means if it is abuse prone, you have to shift it to public hospital. Third, it should not be an emergency thing. So on that basis, we have reserved 166 procedures. In that, we have reserved even knee, hip replacement also, because we were afraid. Before that, we were in insurance, hybrid. Now with assurance, we were a bit afraid that sabke gutne badal jayenge and all these things, we were a bit afraid. So we have still reserved it. Still we are working how other states are doing with it. We recently heard of Gujarat experience, so we stepped back before opening it. So then from January to July, it was a struggle with NHA. I don't know if NHA person is here with that struggle period, because they all have left. They all are, I mean, Rohija sir is aware of this. So it was a struggle with him, and our principal secretary intervened, and she even personally met Dr. Indu Bhushan twice, thrice. There are COVID time also, and we were continuous meeting with them. Then because we have conversed state specific things, state sponsored scheme, our hospitals are not going to accept if we will not listen to them. So we were having separate package master from this NHA with 228 separate packages. We were having high rates in surgical onco, neurosurgery, and one more cardiology. Cardiology we accepted as such, but this surgical onco and one more specialty as a neuro. Neuro, we revamp it totally. Neuro, what we have said, okay, because in state-sponsored thing, we were giving them 2.2 lakh something. And now we have to reduce it to 50,000, 60,000. So we said, okay, we are increasing this rate. But along with that, how we adjusted that neuro per care day, something we have added. For your extended days, you will be having, accordingly they have accepted. On 4th July 2020, I remember we inaugurated HBP in converged scheme after 6 months of our scheme. And here what we did in transparency, we have even have this opinion from beneficiary also. There is 104 toll-free number, because you cannot speak to all beneficiary what we have in our list. That was the question from me to Karnataka also, how they have ensured that government mein jo reserved hai, how, because beneficiary does not know which thing is reserved and which thing is not reserved. Like we have reserved normal delivery. Although this ABPMJ is not saying normal delivery is a part of a scheme, but we have in our state, it is state sponsored thing, because we want to give something to PSCs also so that they also have claims. So how to explain this? Because the woman is going to deliver, she does not know whether it will be a normal delivery or C-section. If she is normal delivery, okay.
Dr. Priyanka, can I request you to I know it's very interesting, but I think
okay, but it is that we have done.
Okay. So yeah, I didn't mean to cut you in between, but just to wrap up quickly.
Okay, it is like that. We have committee. We have transparency 104, we explained this too, and we have used IEC thing like wall painting, pamphlet during BIS drive. We started giving this to beneficiaries. These are the things which is reserved for government, so that they get all these things we have done. And experts committee with specialty wise, that we have done. And now this new thing is coming up with technology, that I think will be having support from NHA on this, because in a state we will not be able to do it. That's it. Okay.
Thank you very much. I think really a very interesting story in terms of how you really moved on this. I think with this, Dr. Ajay Tandon, I had a question for you. What do you see? Because I think we also heard Priyanka talk about the challenges of a state scheme and looking at the national scheme and the merger. So if we look at the federal structure, what are the global experiences where you've seen, what are some of the key challenges facing the countries that are implementing health insurance schemes in a decentralized context? So if you can allude to that, please.
Thanks, Sheena. So yes, there are some advantages and some disadvantages. So I'll just briefly talk about that. So one of the advantages of allowing, I think that's one thing that I think India has done very well, is it allows the NHA to set almost like a minimum package that has to be provided, and then the states can add on depending on their fiscal capacity or their political exigency or demand from the thing. So the states can actually, some states have expanded coverage beyond those covered originally under the PMJ. Some states have almost universalized coverage as well. You can also have the choice, as you pointed out, to add on to the benefits package. So for instance, in Tamil Nadu, we saw that they had already included some diagnostics and some outpatient procedures at private clinics as part of their benefits package. And so there is that very clear sort of advantage of allowing this kind of competitive federalism to occur, that you allow states to you sort of give a basic minimum, and then you allow the states to go over and above that, and then you learn from those experiences. In fact, there's a lot of learning, already was alluded to by some of the speakers, that has led India to where it is now, going back to original tertiary care packages that were introduced, was it Andhra Pradesh first, and sort of setting the stage for RSBY and other schemes. So that's a clear advantage also to experiment with different ways in which you can incentivize providers or to try and get enrollment rates up, and also to allow the system to be more responsive to local needs, to local differences in disease burden. There are also big differences in India in terms of the age profile across states. So the southern states have much higher share of their population that are elderly. So there are these clear advantages in allowing for that. In fact, Indonesia used to have a lot of decentralized schemes, Chitra, not just at the province level, they were also at the district level. So Indonesia has actually decentralized not to the state level but to the district level. They went, so it goes from the center, health is actually a district subject in Indonesia. And in Indonesia, they had district-specific schemes. There are 700 districts? So not every district had its own scheme, but they used to cover the scheme. And I still remember several years ago the look on my boss's face, because Bali has suddenly decided to have universal health coverage for everybody. It's a very rich province in Indonesia. It gets a lot of tourists, and they said, no, we are not just going to cover the poor, we are going to cover everybody, and with a very generous benefits package. And so we said, we have to go to Bali for a fact-finding mission. So, all of us put in the requests, and the manager had a heart attack. But actually it was in some ways a good thing, but then it's a bad thing. And maybe Chitra, you can elaborate on that. The bad thing was that there was so much diversity in the fiscal capacity across provinces, across districts, that you actually ended up seeing growing inequality. So there were some provinces, this is not just Indonesia, in other places as well, where if you had richer subnational units or units that had better subnational entities that had better capacity or were much more progressive, ending up moving away from the rest of the country in some ways. And like I said, one good thing is it also is a beacon. It helps then, can help pull up others as well, that, hey, if you can do so well. I think the case in India, you always look at Kerala or Tamil Nadu, they're really doing stellar in terms of health outcomes. But it also makes a tendency to embed and calcify some of those inequalities, unless there's a proactive move to try and then adjust for those. That has to happen. And I think one of the conscious efforts that was made in Indonesia's context was to prevent some of that inequality across provinces and across districts to get out of control. So it was a mechanism by which to bring everything back. The other, this could be an advantage or this could be a disadvantage as well, is sometimes in a very decentralized context, you also can introduce some of these programs, there are mechanisms to actually re-centralize what was sort of getting decentralized, and again alluding to the fact that you can try to sort of try to have a minimum common standard at least, and then to allow some states that are able to move forward to move forward, but then using those lessons and using their experiences to build the capacity of all states, so that all sort of the tide lifts all boats, so it's not just that some catch the tide and move forward and others do not. There are many countries that have very decentralized context and quite complex. So I think Indonesia is probably one of the most complicated ones that I have looked at, but Nigeria, Pakistan, I believe Nepal is also now decentralized down to the district level. And so it comes with these advantages of being local, of adapting to local context, and the disadvantages of the fact that if you have big diversity within the states. But I mean, there are also mechanisms by which you can try to re-equalize some of those differences by having equalizing financing or extra capacity that's provided to weaker states. So not necessarily an across the board thing that decentralization is always good, but it can be good, but in some cases it can actually lead to unintended consequences that need to be corrected for. Thanks.
I think Dr. Tandon, I would have loved your previous assignment and gone to Bali to study some of this, but I think the point that you're raising is a very good one, and that I think comes to our last segment of our panel discussion, and that relates to the institutional mechanisms and the processes, etc. So I'm going to turn to Dr. Samson Kohra. How have the HPP updating process been institutionalized so that you really are able to protect the principles, processes, methods, and from different interest groups sort of influencing that? What kind of structures are there, and what's been your experience?
Okay, thank you for that. In terms of institutionalization of the processes, we've utilized both internal and external mechanisms. So internally, we've come up with policy documents, we've come up with guidelines, we've come up with ISO processes. When it comes to a benefits review or a benefits design process, the whole process is defined. Start by indicating exactly what you want to achieve out of that review. It goes through a systematic review of what is happening in other areas of the world and what other countries are doing. Then have this first stakeholder engagement where we get inputs from different providers, different practitioners, and then define an inclusion and exclusion criteria in terms of who can be contracted for the same, what is the scope. And then from there, we also define who can be able to offer the service in terms of the specialization. So if it is cardiac procedures, then we are restricting it to cardiologists. And then from there, we'll get the input from the different facilities and also do market surveys. We come up with the costs. Once the costs have been defined, then we also define the monitoring indicators. And then from there, we bring in the actuaries. So the actuaries look at simulation in terms of the likely utilization and the costs that are going to be needed to finance such a change. And then once a final decision has been made, that is what is taken to the board of management so that it can either be adopted fully, partially, or rolled out as a pilot as we seek to fully institutionalize it. During that time, we do the monitoring and evaluation. Then when it comes to other engagements, we have forums for public participation. Is actually a legal requirement by the constitution in the country. So whenever public funds are being used for specific activities, then public engagements have to be done. So we always have this within that cycle. Then externally, there is legal backing because there is an NHIF Amendment Act 2021 that was assented into law in January 2022. So it gives us a legal backing in some of the revisions that are are to be done as far as benefits are concerned. And since the fund also does revenue collection, it also gives the legal backing when it comes to who needs to contribute, how much they need to contribute, and how often these reviews need to be made. So it gives a provision that the reviews need to be made every 2 years. Then the other legal backing that is still pending, once a law has been passed in the country, paper is prepared on regulations. So the paper has already been prepared, but it has not yet been adopted. We are hoping that this is going to be done once the new parliament comes in. We are having elections in about 10 days' time, so we are hoping that the new parliament that comes in will be able to endorse the legal regulations. Thank you.
That's really very, very impressive, and I think very rich learnings there. I'm going to turn to our colleague from Indonesia. I have the same question for you in terms of if you can allude to what kind of written guidelines, normative frameworks, or manuals, etc., do you have, and how does that process work?
Yeah, thank you. From Indonesia, I think, as I've mentioned previously, that we haven't really have a formal guideline or framework in revising health benefit package. And the process that we have currently working is that in 2018, once the President give a specific instruction to the Ministry of Health to revise the health benefit package, then we engage with the other stakeholders, mainly the ministries, to form a team. And myself, coming from the research department, we conducted a study about how to develop at least some criteria to determine which diagnosis or treatment are going to be included into the health benefit package. And we have, because our limitation in the National Health Insurance is only to provide recommendation to the Ministry of Health, then once we finish the study, we provide the recommendation. Then at some instances, the Ministry of Health uses that recommendation when he explains the plan to revise the health benefit package. But again, due to the positive cash flow of the National Health Insurance, then it's become unclear whether the framework are still going to be used. And currently we are more focusing on the primary healthcare reform, and the Ministry of Health is planning to add, like health promotion and disease prevention benefits into the JKN, like 14 different health screenings. And since Ajay mentioned about Bali, can I just share a little bit story about, because I was there in ground zero about when the Bali province eventually joined, because Bali is one of the last provinces that joined the National Health Insurance. I was stationed there, and just some context, because the governor of Bali was the former head of the police department that solved the Bali bombing, so he was a national hero, so he was very feared, and he is very firm with this decision. We want to maintain this scheme. So numerous advocacies and communication was made. Even we invite the state attorney, just a gentle reminder, just, if you don't follow this national insurance, then you are considered breaching the law. And then eventually at 2017, the governor, okay, we will join, and we invite you to a meeting like this. And all of the media was there, and I remember precisely what he said, because okay, Bali will join the National Insurance, but we are very reluctant to join. And this is in front of the media. We have a local scheme with 99% satisfaction index, and if I hear a single complaint from my people, I will opt out from the National Insurance. So this, just to give you some idea about how we the attempts for us to ensure that local schemes are joining us. So thank you. Just want to share that.
That's a very high bar in terms
Sheena,
of
can I
keeping
just
to 90%.
add a traditional Balinese massage was part of the benefits package. I'm not kidding.
Very generous.
Okay, I'm actually cognizant of that we are now at the brink of running late for the session. But in terms of institutional mechanism, Dr. Pankaj, I had a very quick question for you. As we look at convergence of the schemes, etc., what kind of institutional mechanisms have you put in place, or are you planning to put in place, that ensures that, when we look at convergence, there are some common principles and processes and methods which are applied, which are consistent, which are clear, which are transparent, don't vary from scheme to scheme. So what is being done on that front?
Yeah, a really important question, and it really has been done well by NHA. So we have two models already running. One is a CGHS model, and second is a PMJ model. So CGHS model gives you the benefit of getting the treatment in CGHS hospital, 1800 odd hospitals which are there, with the advantage of private and semi-private ward for the people who are having that thing. And for PMJ, it's right now general ward, and as I told, we are going on to increase it to the same principle, but on the HPV package list. The advantage other advantage which we have is availability of a rock solid grievance redressal system and a call center which is 24/7 with highly efficient trained people. So not even if you're raising the complaint, we have an absolute marvelous website for raising a grievance redressal, for raising a grievance and getting it redressed. But we also take care of any kind of grievance which is coming in social media, maybe Twitter, Facebook, or anything else, or all the grievances which are coming to the call center. We take care of each and every grievance and till it is closed, including the quality of it. The quality is monitored, and now when I was leading the grievance last year, we put up a ATR in it. The states earlier used to upload just like that a paper which was required, and it doesn't had any document which was fulfilling for redressing the grievance. But now they have to file a full action taken report, and if they don't, they will get the grievance opened again. So these are the few things which we have, and definitely we are coming up, and we said that the things of STG and HPV have to be in place for PMJ also, so for CGJ also as in PMJ, and all the states can also join us in getting it done. Thank you.
That's very, very impressive, really. So I know that we are now at the brink in terms of the time that was allocated to us, but I had promised that we will open it to questions to the participants. So the first 3 people that raise their hands can quickly ask their questions. I would request you to keep your interventions very, very, very brief. Okay, so we have 2. Okay, so we're going to go with 2. Please go ahead. Please introduce yourself and then ask the question.
Is it working? Okay. Hi, I'm Izani from Health Financing Section in Ministry of Health. I'm wondering, when you do the engagement with the stakeholders, especially when you already have the benefits package, and you outline what are the services provided by the private sector, what are the services provided in the public sector. So how do you how governance help in monitoring whether this benefits package, especially in the private sector, is being delivered by the providers? What I really want to see is how we capture those patients that been denied from getting the services that should be provided by the private sector.
In terms of who would you like to respond to the question?
I think maybe at the NHA level.
NHA, okay. All right.
So yes, that's a very important question, and a lot of fraud goes on if you don't monitor it. There are 2 things by which you can do it. It's during the admission and after the admission. So the first part first. So when the patient is admitted, especially for the surgical packages or for otherwise medical packages sometimes, for medical package we need a photograph every day that the patient is admitted and what is the treatment he is getting or she is getting. And for surgical, they have to put a photograph of the patient getting operated in the operation theater, and what are the things used. They have to put the label of the mesh or implant they're using. Then it still can lead to fraud, definitely, if you use somebody else's label, but still that's what at present is there. We were discussing the same thing, that if somebody in private has been operated and his label can be used otherwise. So that is a system we need to develop further, but for the time being, this is what is before the discharge. Now coming to after the discharge, NHA has built a very stringent and good call center which calls you on the second day of discharge, and it asks you few questions including was the PMAM happy, was it able to give you good guidance, was he helpful or not, did you get the discharge properly, did you get the treatment properly, did you get the discharge post-discharge medicine properly, and what is the satisfaction overall score for you in the hospital. Absolutely it's difficult for call center connected, but there is a good connection rate of 30%, which is usually there in any call center, and to your surprise it will be amazing, the results are that 99% people have given a score of more than satisfactory, 80% really good, and 6% excellent. So this is what is coming up, and we have a further follow-up on 15th day to see if they had some problem. Did the hospital, when they went to the hospital, did they respond to that or not? So these are the two things which are there in post-discharge. That's what it is, and there are states which are already doing the follow-ups on their own also. Thank you.
Just to add on, we have denial of treatment grievance as a very flagged process. So there is an SOS grievance system also. So in cases of denial, because that is one point wherein, you know, if you do not connect and resolve it at that point in time, you miss that opportunity. So we have the SOS grievance, and denial of treatment is flagged in the dashboard so that it is reviewed and immediately addressed. So it takes a priority in times of any kind of grievance redressal.
Thank you very much, Dr. Pankaj and Dr. Sudha. We had a hand from this side. Dhananjay, not yours. I think there was other hand from this side. It was your hand only? Okay, sorry, you've come here. Sorry, I couldn't see that far. So you've come forward. Please go ahead.
Thank you, Dr. Sheena. I have one question for Dr. Pankaj sir. The thing is that the 2-day session, what we have seen, and the different states have spoken with us, few have given a very good, set a very good example because of the convergence not within the schemes. It was a convergence within the whole health system. I mean, other departments of health also have converged with the mainstream of health insurance, which has yield them a very good result. So how we are thinking forward on that perspective is one question. And the second one, I don't know whom to ask, but it's like we make lot of laws, and we have seen a series of acts which have been named by different participants from last 2 days. But the complaint against Indian scenario is that we are a very good process makers, but very late implementers. So what makes us to energize our implementing capacity with a buy-in from the hard leadership? So how we can do that? So these two are my questions.
So I'll answer your first question first, and second also I'll answer, because that will be easy to answer actually rather than the first one. So the first one is definitely everybody has to be in hand in glove rather, to make it really work. See, nobody, health is a subject in which every ministry plays a role. It cannot be done by the health ministry itself or by the state itself or anybody itself. It has to be a combined effort actually. And this is the place where it is done properly, like you're saying Kerala and Tamil Nadu are able to do it better. They have all the support. That's the reason. They don't pull the leg of anybody else. So when they go in hand in glove, that definitely it will be a good golf shot. It will be far away. So otherwise without glove, your hand will just get abrased and all. Second question, yes, for implementation. That is a really good question actually. We are very good policy makers. Every day we release another policy, but yes, it has to be seen on ground first to make effect. For example, I'll just give you an important example. I'll take 2 minutes extra, but it will be a real good example for everybody in states. The hospital at present, whichever state I have visited, they don't know the price of the hospital benefit package. Still, they know the price of the HB 1.0. You visit any hospital, they don't understand that. The only scar they have is that what a policy we have made, and there are no rates, and even they had the gallbladder rates have gone in UP from 12,000, 11,000 to 36,000, but they still remember the 11,000. Last week I visited UP. 11 hospitals had only given me rate 11,000 rupees of gallbladder surgery. They were already hospitals performing at 20 to 500 and going to 36,000, and they are performing in cash in 20,000. But they don't know the rates, that's why they don't perform. Because the implementation also includes the awareness. Why Swachh Bharat is a success? There is IEC involved. So the IEC part of it has to be there. That is the most important part in any scheme. You have to tell people, the beneficiaries, make them aware. Hospital, make them aware. Make them know that they can raise their grievances. Make them aware they will get the premium payment. Make them aware yet there are good rates actually, which they are already doing in cash. They're getting more than that. The profit drives them to give you the benefit to the beneficiary as a byproduct. And if it is a byproduct, it will be easy to get. If you ask it as a primary goal, they will ask, why should we do it? We are already getting the patients. Less than 50 bed hospital get it easily done because their rates are low. So that's what it is. You have to implement it by reaching out and asking the people and telling the people the policies and the benefits. Thank you.
Very important point in terms of communication. And that actually comes to our concluding part of the panel, and before I turn it to Dr. Sudha for her final comments, I would really like to thank all the panelists for your very, very rich insights. And you've really provided very candid, you didn't hold back your experiences and challenges and laid it out all on us. So it's a difficult journey. Governance is not an easy subject, but as yesterday we were talking about that HPP is the heart of a health scheme, and I think governance is the heart of HPP. So we have to get that right, and that's a continuous journey that one needs to make. But thanks very much to all the panelists for extremely valuable comments. And with that, I'm going to turn to our esteemed chair, Dr. Sudha, to make her final comments.
Thanks, Sheena. I think each of the panelists have given very clear directions on how they have gone through their process in their countries and states, and also how we can go ahead. So in that sense, just to sum up, a key takeaway message that from this panel is to ensure that we need to walk the talk. Because we do come up with all these frameworks, processes, and we do try it to the best of our ability, but somewhere we stop. So we need to ensure that we continue our efforts, as Priyanka was telling. It took a long time and it took a lot of efforts, but I don't think so they stopped. I have seen them engage repeatedly with the concerned stakeholders and trying to get their buy-in and trying to convince them and explain to them how the processes are involved, and especially the addition of the people in the process is something new, and not many states have done it. So that is something that is important, that we need to listen to even the people, and it could be a collective action through the patient groups, or it could be something which is a more broad-based consultations through public, putting the list in the public domain and inviting the feedbacks. So still we ourselves, NHA has not done that. We have not given any public consultation on our packages. We have always restricted to the limit of our expert committees and reviews in states. But we have not yet gone public with our list and taking inputs. I think that is something that we can take things forward and move that next step. And definitely the challenges everyone has, raised in how sometimes we need to rise above it and make sure that we are able to implement and enforce these processes and be consistent in it, so that everyone has an expectation. Yes, the stakeholders are very clear that this is how it will be done, and this is the process that has been done, and it is for posterity that the next leadership that comes in always are able to take it forward. So I think with this I would like to close the session, and thanks everyone for being quite active in the process since morning. So I think there's an excellent lunch waiting for you, I think we can continue the discussions over lunch if there are any other pending points. Thank you. Over to Abha.
Thank you very much, Sheena, for excellent moderation, and Dr. Sudha for chairing this session. I now request Sheena, if you can please present a memento to Dr. Pankaj Arora as a token of our appreciation. Thank you very much. Please, a big round of applause. Requesting Dr. Sudha to please present a memento to Dr. Ajay Tandon. Thank you. Sheena, again requesting if you could get up and please present a memento to Dr. Samson. Dr. Sudha, requesting please present the memento to Mr. 𝒑𝒕💊💈. Big round of applause, please. Everybody's got tired. Lunch is awaiting you. And Dr. Sudha, if you could stand and please also give to Dr. Priyanka Lalwani. And may I request, Sheena, if you can please give to our chair, Dr. Sudha. And last but not the least, Dr. Sudha requesting if you can please give to Sheena as well. Thank you for an excellent session. Thank you very much. So we'll be breaking for lunch, and we are again running a bit late. We are half an hour behind schedule. So requesting if you can please come back in 45 minutes. So we aim to come back at 2:15. Lunch is served right here. They'll just be moving the partition, so lunch is on the right side. So we'll see you back at 2:15. Thank you.
From the PMJY perspective. As you are all aware that we had released a consultation paper also on value-based care, and many of you have been responded back to that, and Dr. Shankar Prinja is going to take again a brief session on the complete value-based care. And now we are going to have a session from Dr. Sudha Chandrasekhar on DRGs. So I request you, ma'am, to continue.
So good afternoon. I hope the lunch was good. Yes, no? I don't think so. There's no noise. Still no. I think you didn't have your desserts. Yes? Little bit now. Okay. So now I would just be giving a brief about the how we are planning to strengthen the ABPMJY patient classification and the provider payment system. As you're aware, recently we have rolled out the ICD, ICHI, and also along with that we are also having some states who are also present here who are actually being part of our pilot for diagnosis related groups. So in that sense, it's important for all the other states to also come up to speed to understand how we are going about, because post the pilot, we want to make sure that we are able to scale this initiative up for all the states. So just to give a brief, till now we have been talking a lot about how the health benefit packages are designed, what are the processes that we need to follow. So beyond having a very good health benefit packages, one of the key things that will help providers take up these services and ensure they are very active in providing such care is also based on the financing. So how we finance the hospital, how we reimburse the hospital also becomes important. So in that sense, just to give you a brief, there are different ways in which many countries and many schemes are reimbursing the hospitals. So one is actually global budget system, wherein based on your requirement in terms of the infrastructure and the population that you cover, they are given a global budget to the facility so that you take care of all kinds of services within that limit. And that could be based on historical budgets of how much you are spending. So especially the kinds of budgets that we get in public hospitals mostly follow those global budget system. So the other way is the fee for service. So wherein for every diagnostics, every procedure, every post follow-up consultation, you have different unbundled packages wherein for each of that service, based on the outputs of each of these listed services, the hospital is paid. So the main thing that happens here is the providers are incentivized to over-provide. So they feel that by increasing the number of tests, whether it is necessary or not necessary, by increasing the number of consultations, they can maximize the reimbursement that they can receive. So in that sense, it has got some extent, but it is very useful if you want to make sure that the scheme uptake is quite high and rapid, so that providers are also happy to take such kind of a service, and they will follow that. So capitation is again in a more advanced, with a very good public health systems. You try to pay the hospitals within a particular catchment area, and they are provided budget so that based on whatever services that their population require, they have to manage, whether it is secondary, tertiary, primary care services, all types of services has to be managed within that budget. So at that time, the providers tend to be lean towards primary care, because then they can actually avoid more high cost interventions. So in that sense, if you want to strengthen primary care, this is a good model to adopt. But currently what we are facing, utilizing is a per case payment. So here we are looking as a bundled payment system based on the type of procedures, whether it's a medical, whether it is surgical care. So we are looking at a per case payment. So in PMJY, we have per case payments, which is like a per diem payments, which is stratified. But for surgical packages, it is a completely bundled amount that is provided to cover all the pre-diagnostics, inpatient care, and then up to post-discharge up to 15 days. So in that sense, we are a little ahead in that PMJY follows a case-based payments. But one of the things to move towards an advanced payment system is also look at some of the tools that can help us move towards that. So we at PMJY are looking forward to move towards an advanced provider payment system, because what we have seen is with all these efforts, we still have limited provider participation. So for a country like India with a commitment of for nearly 500 million people, we are still having 24,000 hospitals who are part of our network. So in that sense, we are not sure whether that is enough, and is there any other way to incentivize. So one of the things is also, if provider payment systems could be a lever to enhance provider participation in our scheme, is something that we want to really look forward to. And for that, we are trying to look at DRG as one of an innovation, where we can combine both the clinical and the cost data, especially at the patient level. Right now, we are paying a flat rate to any patient, irrespective of their severity, comorbidities, or which level of hospital is treating that. We are providing a flat rate, but here we are looking at a very patient-specific cost that will be reimbursed. So mainly what are these diagnosis related groups? Here we are trying to identify groups of patients that are homogeneous from a clinical and a cost or a resource consumption perspective. So they can be of multiple specialities. So they might still fall under a similar DRG group. So in that sense, we are not looking here at a specialty-wise breakup or a procedure-wise breakup, but here we are looking at what is how these patients are, which clinical group they fall into, and what are the resources that are required to treat a particular patient. Here we are looking, this was mostly used in the hospital performance management area, but here we are trying to ensure that every discharged patient we are trying to measure and evaluate, so that would help us to get group them into a particular DRG. So here the discharged patient is the final product, not the investigations, procedure, tests or treatment, so which are more as a sub-products. So here what we are trying to do is to identify a case mix, which is a tool which will catalog the hospital's cases based on the similar clinical or the cost characteristic, because we want to make sure what is the kind of cases that the hospital is seeing on a regular basis. So what is the case mix of a hospital? Because if you look at the tertiary care hospitals, mostly they'll be of higher severity with major complications. So whereas a simple secondary care hospitals will be seeing a different set of patients of a particular level of severity or complexity. So here we are trying to see among our hospitals how these case mix of the hospital is there, so that will also form as a benchmark for in the baseline, and identify how sick or severe or resource intensive these patients are, because this is important as we try to reimburse per case basis. Based on the patient characteristic, we need to be able to identify and stratify them. Again, we also know that some hospitals will definitely require more resources to treat, again based on the characteristics of the patients that they are treating compared to other hospitals. So in that sense, we need to understand the case mix of the hospital, and one of the tool to identify the case mix is also based on the diagnosis related groups. So here we are looking at ensuring that we are able to distribute the money objectively and ensure that we are able to create some efficiencies, and also monitor service delivery, quality and any kind of fraud and abuse. So here we are not looking to cut the cost to the hospital or control doctors, because definitely there is a standard treatment guidelines or a clinical pathways which most of the clinicians do follow with 5 to 10% variation. Here we are not directing our efforts there, but we are ensuring that we are able to redistribute the money, since as yesterday also we have been talking, our resources are finite. So we need to ensure that because a particular case needs more money, the quality of care should not be reduced. So we have to match the resources with the care provided. So that can happen only at a patient level. It cannot happen by developing just a package reimbursement. So we are adding another dimension to the benefit package, that is the patient-centric reimbursements. So what can DRGs do, right? So what we are trying to do is distribute the limited resources in a fair and equitable manner to the providers, right, based on the kind of cases they are treating, so that we are not cutting corners anywhere. So whatever the care needed is being provided in the right setting, so that we are not incentivizing patients taking care for simple things in a tertiary care setting. Actually in Korea, if you are going directly to a tertiary care center for a procedure that can be handled at a primary or a secondary level, then you have to co-finance it. So the beneficiary, there is a limit that, if you come directly, apart from emergencies, so you will be a payment of 30% to 70% co-payment for that procedure. So there is a kind of limitations, so that people don't skip the referral pathways, and make sure that they are disincentivized for services that are available at the lower end. Many hospitals, when we have discussed at the district level, they say that, you know, at the district hospital, which is supposed to be the first referral center for complex cases, they are having a lot of overload of simple cases which could be treated in a primary healthcare center or a secondary hospital. So in that sense, when we bring in these thing, we might be able to also rationalize the setting of healthcare, and so that patient need not actually even be admitted for some cases. So whether we can have identify such ambulatory care services and disincentivize their admission. In RSBY, one of the most common issue was OPD conversion. Whatever patients could be treated on an OPD were being treated as IPD because only IPD was being reimbursed. So there was a forced admission so that they could claim that per day amount. So even in medical packages, many a time we do identify that sometimes if for a dehydration, if it could have been managed with, you know, a short-term drip and he's been sent out, he could be sent home, then they cannot claim. So they used to keep him for a day, at least so that the 1,800 rupees, whatever they could claim, that could be done. So again, here we are trying to see also the efficient way of delivering. So the length of stay is something which is very critical. And we see that variation for the same kind of cases, same level of severity of cases. Many a time we see wide range in length of stay based on the kind of payment. If it is a bundled payment, people are very happy to stick to that, you know, unless in exceptional cases, they are happy to stick to the recommended length of stay. But if it is a per day payments, so they tend to increase the number of days the patient stays in the hospital so that again they can maximize the resources. So in that sense, but when we know the clinical severity, when we know the kind of comorbidities, we can actually say whether these kind of patients require that additional length of stay or not. So there can be some kind of a better monitoring. So we can look at the data and we can also identify how we can make sure the quality aspects of care also. So we have many countries here who are participating. Any country who have moved to DRG, visiting participants, there is one. There's another one. So we have a couple of countries even in the developing, at the developing stage also. So in that sense, the main reason many countries move is because the earlier kinds of payments, provider payments may not be as sustainable. So for a kind of scale of program that the countries are moving ahead, especially UHC, wherein financing is very important. So we cannot stay with kind of a payment system. So, and secondly, the fee-for-service is so open-ended that it is very difficult to justify, and the effort made to understand why a particular additional services are being provided is much more than reimbursing them. So the cost of reimbursing them at face value. So they cannot do this on a regular basis. Further, they're not aware of what is being purchased. So many a time when they have this kind of fee-for-service, there's a whole list of line items that are being purchased. So whether what is relevant, what is not relevant is not very easy to distinguish. Further, they move because they want to increase the transparency of how they are paying the hospital and also share the risk between payer and provider. Because in the fee-for-service, all the risk is in the payer, because the provider will always keep on maximizing it. So we have to make sure that, you know, they have limited resources, how can they use it objectively? And also, this can provide incentives to deliver care more efficiently with quality. That is important, because as we move ahead with increasing access as part of UHC, we also have to remember that quality issues are also very critical. That is something which I want the states also to take it quite seriously, because we are trying to form quality cells in all the states.
right? So it is important that we are not only looking at how many beneficiaries are utilizing our services, but whether the quality of services provided by the hospitals is optimum. So in that sense, quality is something our division is really now pushing things, and we will also have a value-based care presentation followed up. So these are initiatives, and the quality cells in states are very critical to ensure our DRG monitoring once we roll out happens. So if your quality cells are not strengthened or not formed, please ensure that maybe this month we can have all the states complete the quality cell formation. So what has been the key lessons from various country experiences? I think this was something we did a lot of advocacy within NHA also to meet with various countries facilitated by World Bank, making sure that we interact directly with the countries which have actually done DRGs, so that we understand whether going forward with this initiative for a country like India, how relevant it is, and what is it that we can learn from them, and make sure we are aware of the pitfalls of taking this decision. So what we tried to do is, the key thing that came out is coding and classification has to precede any DRG movement. So that was something we took it on a war footing for the past 8 to 12 months, that we tried to get the coding, ICD coding going on and rolling out that, and we are happy that, since April, at least the rollout of ICD-11, which is I think one of the first few countries to roll out ICD-11 for a scheme like the big schemes like government funded schemes in any country. So that coding and classification work, we have identified that ICD and the ICHI, which is for interventions, that is rolled out strongly before we move to the DRG system. So it takes a couple of years. So we know we are refining. We have now getting data from the ICD coding that being done by the hospitals, but there's a lot of effort that we still need to work on. Second is piloting and phasing this initiative. So what we have tried to do is also, because in a country like India, piloting in a hospitals make no use, because it's so vast. So we are piloting in states. So we are taking states as our base, because then we'll be able to get multiple viewpoints and scenarios from various states where we can actually understand the ground level issues. So we are piloting in 5 states. So we are ensuring that we learn a lot from this experience. So we are very clear with our objectives. So we want to ensure efficient use of the resources. We want to ensure provider participation better in our scheme. So these are something, and we want to engage with the stakeholders, especially the states, the hospital, and make sure that when we do this pilot rollout and further scale up, we are all on the same page. And we are not trying to do anything very new, but we are trying to adapt whatever is the processes for the existing tools, especially the groupers, which are very critical. So we are trying to make sure that available groupers is what we will be identifying, and then seeing how we can adapt and customize it for the Indian context, and then look forward to other things. So one of we have shortlisted few choices on that, because there's a WHO grouper which is being developed, which is free and more could be used by any country. That is something our first choice. Then we have additional groupers from various countries we have explored and discussed with countries like Australia, the Nordic groupers, and also the US 3M groupers. So we are looking at how do we do this and use it at the pilot level, and make sure that we have a good idea of what we are getting into. So for us, since as I said, we are not in the bottom half of the kind of financing. So we are paying already a case-based bundled payment, which is a much advanced payment than a fee-for-service. So in that sense, the kind of jump or the transition or the delta that we will receive from the transition to DRG may be less, and it will be less complex also compared to some country going in for a fee-for-service to DRG. right? So in that sense, we are better off. So we do know that, multiple countries have taken efforts, and we have these systems in place, and it is very clear that they have taken a lot of time by the time they have matured enough and ensured that these systems are stabilized. So we do look at these learnings, what are the benefits, how this DRG has helped them. So more countries are benefited in terms of improving the efficiency, quality, transparency, and also being responsive to the patient's needs. These were some of the benefits that most countries have received after moving. Some of the drawbacks are, it is complex for people to understand. Implementation is a challenge, so we have to do more stakeholder engagement and keep getting all of them understand, and that we are trying a lot with each and every hospital whom we are who have been providing concurrence to be a part of our pilot. So we are trying to ensure that they understand. There's also an issue that maybe it increases costs, because now paying a flat rate to any case, we might get the same outflow. But when we are paying some, apart from the cost that is fixed, if we are paying additional cost for severity and comorbidity, there will be minor increase in the costs. But in terms of the overall, when you look at, you can actually, relook at how you price a regular case. So the base case could be priced better, but right now what we are doing is we are pricing the base case, considering 10% of these patients may go into complication. So we are building in a percentage or a amount into each case, and saying that no, we are paying a kind of a flat rate. But we are actually considered a little bit of complication cost into each of these cases. But now what we can do is we can even price the base package rate differently, and then see what is the additional cost for severe and complex cases. So in that sense, we need to rethink on how we do our packaging and pricing again as we move into these things. And definitely upcoding, cherry picking will continue. It is already there, so definitely it is something. But once you have a system, strong monitoring system, fraud control system, it can happen even whether you are in DRG or whether you are not in DRG. So we should ensure that the systems are in place and are strengthened. So in states where the SAFUs are working quite strongly, the state anti-fraud units, they're able to pick more cases. That doesn't mean that those states have more fraud. It is only means that the SAFU teams are quite strong enough in those states and they're able to pick. Whereas in other states, it might be weak. One, they might not be identifying. Second, even after identifying, they may not be acting upon it. So in that sense, they never get reported. So we need to ensure that the monitoring system has to be strong, especially as you move to DRGs. We need to strengthen that. So we have tried to see that, it is quite already being used widely in many countries. So we are looking at wherever there is DRG based, and also wherever it is mixed. DRG based payments doesn't mean that you will just jump into a new system. So you can always have that certain packages being paid by DRG, certain packages being still continued on your case-based system or fee-for-service or any other method. So it's a mixed group also could be there, and that could be one step in your transition. So even at our level, when we are planning our NHA transition, we are not looking to transition all our packages to DRG. Though in the pilot we are trying, whatever the hospital cases are coming, we are reviewing and we will consider. But later on, when we take a final call, we might start small, or we can see what kind of conditions need to move in DRG, where there is a maximum variation in how these cases are costed or how these cases, resources are required for such cases. So purely DRG based, Thailand is one of a very, neighbor example that we can actually learn a lot from, because they are quite similar in terms of the economic status and the kind of issues that they face. So even when we were doing the UHC in Karnataka, Thailand was our model, because they were already working on how do we converge these three schemes that they were having, and how we can do that. So Thailand is a very good representative for an Indian context, is something that we want to look at. And again, Chile, Vietnam, again, they're all moving ahead. They're in the process already. So we would be learning more from all of these countries. So that is something we, maybe the next time when we meet, we will be having something similar workshop specifically from DRG to learn from various other countries in more detail. Because here we are just trying to say what we are doing, but we are very early in the stage. So next time we want to be on the other side and learn a lot from all the countries who are experienced this transition to DRGs, and we hope to get the invites for that. So, these are the different ways where we are. So currently ABPMJY is in the case-based system, and the next level what we want to go is for the DRG based payment system. Why, what we hope is that PMJY will benefit by moving toward DRG is, I think anybody you ask them, and since yesterday we are also hearing that hospitals have huge concerns about package costs. Nobody is happy, whether it's 2022 package rate or 2024 package rate, they will never be happy, because to some extent many a times we will not be able to address all areas. So in that sense, one of the key concerns they have raised is you pay a flat rate. You don't incorporate complications. Even if sometimes the patient stays for nearly 10 days in our hospital, but still we can't discharge him because he's not fit for discharge. But nobody is going to reimburse me the cost for the additional days. So that is something we hope by having the patient characteristic into the system, we'll be able to address that. And here there is how the packages would be selected is mostly based on the diagnosis and the kind of procedures that they are doing, and these get assigned automatically as and when it is through the grouper, so that the rates additional based on the kinds of procedures are all calculated through a software. So in that sense, objectivity is maintained, there is greater transparency, and especially we hope that once we have a DRG based system, do we even need a pre-authorization, right? So we can really look at processes and a lot of time spent in processing pre-auths and getting approval, delaying care. So can we even do away with pre-authorizations when we have a good DRG based system for certain cases? So we can even think about that. Also, for comparison with the data, now if you ask me how many cases of a particular disease has PMJY treated, we get these parliament questions on a regular basis. Many a time we are not able to pick because we don't know the diagnosis. Half the time our data field is not very complete. So the diagnosis field itself is empty, but people are booking packages. Then you have to go to which are the packages, and then packages don't give you for what condition that package was booked, what is the etiology. So we are not able to link based on the packages used, what was how many cases of a particular disease was treated. But if we have a good coding, a good classification system, we'll be able to improvise on that. So definitely that is something as a byproduct of as we move to the DRG, we will be able to have better data and comparison with various other countries, and a good reconciliation. Whenever you have, I think hospitals also raise a lot of queries in terms of why my payments or claims is cut, why has this been not provided full payment for my claim. So there are many things they have queries. So when you reconcile, you can always say, the diagnosis, there is no diagnosis or a justification for booking a particular procedure. You don't even have mentioned the reason. So in that sense, it's very clear what is the kind of case history that the patient has and the kind of extension for enhancements they can look up. Further, we hope that we will be providing the right incentives, and definitely we are looking at it might help in empanelment of certain specialities. Especially we have very limited hospitals for neurosurgery, pediatric surgery, very complex kind of high level specialities, mainly because they feel that these cases are not, bundled payment is not good enough for them because of the kind of the longer length of stay and the kind of complications that are expected. So coming to this was the background with which we have been able to get the advocacy done for our initiative to be taken forward. So the approach, how we are going to handle this DRG is, we are looking at this as a step-by-step approach, ensuring that we have a strong advisory committee. We have representatives both internal and also from the various countries, experts who are in DRG. We have members from the development partners who have worked in the field of DRG and supported countries in moving to. So we have a strong advisory committee and a supervisory committee at NHA level, so that the oversight is there. What we say, institutionalize the process. So important is whoever is there in the supervisory committee, they will continue to oversee the process. So it is not that, there will be a lag time when there is some kind of changes. So we are ensuring that there are key discussions, technical discussions facilitated during these meetings, and ensuring that all the key areas or the challenges are discussed and reviewed with various inputs. So we shorten our learning curve, because that is very important, because DRG is a very long journey. So we are hoping to shorten it as much as possible by depending on the various experts and the country experiences. Second step is operationalizing the ICD-ICHI coding. We are very happy that we have started working on that, but more so we are now spending time building capacity at the state level, at the hospitals, at the SHAs, at the PMAMs and medcos, so that they are very much conversant with this process, and it becomes a normalized, like how you use your TMS, select your packages, procedures, fill in the data. It becomes a part and parcel of their routine activity than as a separate thing as I have to do ICD coding. So it is something that is a mandatory thing, and we work on that. So just a request that even if in the IT system you don't see it as mandatory, please ensure that your hospitals, your medcos and PMAMs regularly fill in. So keep reviewing at your end whether that field is being filled up, and in case the IT glitches sometimes happens is that because we have the API with the ICD, WHO ICD, there might be some glitches when we are accessing that. So even if it is not, try to ensure that as far as possible, even if it is non-mandatory, please try to keep ensuring your states fill in that data. It's very important. Maybe when we give you a feedback on that analysis, maybe sometime in our next meeting, you will definitely see the benefit of actually getting that ICD and ICHI coding done. And even for state level reviews, you can definitely see how the hospitals are performing and any kind of deviations that they are doing. So it's important that states take this ownership and do that. And the third thing is analytics. I think we have been looking at various analytical methods from yesterday. So using analytics for claims database is also important. So we have ensured that most of the minimum mandatory database that is required for DRGs is already part of our TMS. So there are no additional data fields required except for some costing related data field wherein we have plan to add that as for additional data collection, to start with only in the pilot states, but then later on it will become a regular feature as a part of the TMS. So we are looking at the next step of establishing the simple costing tool, because we do have a large costing study. I think yesterday Dr. Shankar also shared the CHSI study, which has already got a lot of health system costing data that is available, which we could use it to make some adjustments, and specific costs could be derived from it. But in addition, we have looked at specific additional requirement, mainly to see the kind of relative weights that needs to be used to adjust the pricing as we move towards the DRG. So we hope that this costing pilot will run for maybe around 6 months, so that we'll have a lot of data that will be collected. So as we see, we also have the specialty expert committees who have already been set up for HBPs. So they will continue to support any kind of DRG related clinical inputs that will be required. So in that sense, we are not duplicating the effort, but ensuring that we have the systems in place to get inputs when we need it. So we have had already 5 technical committee meetings and 4 supervisory committee meetings so far, maybe between December to now. So in that sense, it's become a regular feature as a part of our routine division work. So we also have the 5 pilot states, Haryana, Kerala, Maharashtra, Chhattisgarh and Meghalaya, who are also here. So who have given their concurrence, and we are working with them one-to-one to ensure that the pilots are rolled out. And it's already rolled out to some extent, but in the sense of maybe some additional data collection, we are looking at the processes to add that. We have a detailed action plan on how we are going ahead with it. So we have the supervisory committee. These are the members from our internal and external committee members. So we are very clear of how we are going to handle this. So we also have the NHA supervisory committee, mainly to concur and give approval to some of the action points proposed by the technical committees and make sure that they provide oversight. So we also have the technical expert committee, and we have members for the technical experts also. So mainly the expert committee works with action plan based on global learnings, ensuring that there's a proper, how do we do the patient classification, costing, how do we do the validation of the claims data. So there's a lot of clear direction to these committees on how they are going to support us. So we have done a lot of sensitizations, buy-in from every stakeholder with both NHA and the pilot states on how we want to roll out. We have ensured that they documented the concurrences that are received from the states, because again, state leadership also there is a changes, so we want to make sure that whatever has been agreed upon continues even when the state leadership changes. So we also looked at many times before when we were planning to roll out ICD-11 versus ICD-10. We also thought that ICD-10 is more very document based, and it is not fully in the electronic format. So what we looked at is that we are better off moving to the ICD-11 phase, even though there is not much of capacity building material and other experiences that has been developed. So it's important that we still work on that. And moreover, since there is a legal mandate that ICD-10 will be phased out soon, and other countries who are opting for ICD classification, it's good for them to move on to the ICD-11, because even if you move to ICD-10, you will again have to transition back, which is again an additional effort. So definitely we are working a lot on operationalizing the ICD coding and ICHI. So in terms of capacity building, we would request the states to take it forward. We have done one round, couple of rounds with some states, but the states will have to take it forward, because it will be very difficult to do centralized trainings for providers. So in terms of compliance and thing, we are also reviewing. This was launched on April 7th in the regional workshop in Tamil Nadu. We had made sure that a lot of sensitization sessions happen before the launch, and keep on continuing those sensitization sessions with different stakeholders. So claims database creation is also, again, most of the time we have looked at our TMS and made sure that all the minimum data set required is part of the TMS, and we don't have to add any specific data points. So this was the minimum database set. We had looked at the UB4 claim form of the US and made sure that all the aspects, and we made some direction to add is the mental health and the legal state. That is something that we just still need to ensure that that is added. So mostly what we have also looked at is most of the countries use acute conditions to start with in DRGs, but what we have looked at is to look at high volume, high cost with large variation in medical practice, and also with huge potential for abuse, to finalize which specialty and packages maybe in future we would like to narrow ourselves on. So the simple costing template we are working on, and especially we have already the data collected with the help of DHR and GOI. So in that sense, making sure that we have this costing template which covers most of the general costs, and procedural level costing also, but to get more addition, patient level data is missing. So we will be looking at more in detail patient level costing data in the pilots that we are doing in the 5 states, so that we can feedback even that to our overall PMJY package pricing also. So in terms of the main reason why we want to use the cost data is to develop the relative weights and also to assign the DRG price to each of the DRG, so that we can have our own DRG price list also, and also to make sure that we have some kind of a benchmarking and comparative thing. And we hope that in future when we want to have our own DRG system, these will be very handy. So what has also looked into is that most of the costs of patient care, 46% is due to consumables and implants, drugs is around 6%, diagnostics is around 5%. This is from the costing study done by PGI Chandigarh. So what we have tried to look at is that already we have some data on implant prices, though we capture it as a part of separately in our TMS. There's a lot of variation in the costs of implants, so we need to ensure that we capture that, and consumables again are not listed. So drug costs are not given separately, and diagnostics, again we don't have that data. So these are few things that we need to look at, and one of the things we are also identifying is as we do the diagnostics separately, since we are piloting an e-rupee concept also, wherein the voucher-based concept for diagnostic services. So capturing these diagnostics separately will also help us in identifying how much is the test that needs to be allowed. And the rest of the costs are more on the HR side, equipment and capital. So we do understand that these could be bundled into one system. So what we try to do is in this pilot is if we can assess the average cost to treat a particular condition, and also identify if we can make a differential payment systems based on the hospital characteristics and the resource requirement across patients with the same condition, because that is quite tricky. Because what we have seen is maybe the drivers of that may be because if I'm treated by a very senior health specialist and in a different tertiary care hospital, then my cost for the same condition may be very different. Whereas if I'm treated in a secondary level hospital with a fresh graduate, because he wants to ensure that he gets as many cases as he can to develop his skills, then he might not be charging too high. Whereas if you say, even in the consultation charges, you might see that, you know, if you want to meet a senior consultant, it is 600 rupees. If you want to get a mid-level consultant, you will have 400 rupees, or, you know, the very fresher, 150 rupees. So even hospitals are looking at that level of differentiation also on the skill level. So we want to ensure that those are some things we can look into. And we want to make sure that this is a very simple activity, not too extensive, and should be held much more integrated within our current IT systems itself. So we don't want to make another data study or a data collection study to get the cost data. So what we are proposed to do is to incorporate these 4 additional headers in our TMS, wherein the hospital will, as they treat the patient, will add in these data for the additional diagnostic tests, the drugs, the implants and the consumables separately on a case-to-case basis. So if they've done a particular diagnostic test twice or thrice, because the complexity of the case requires that he needs to be monitored on a regular basis, then we would have captured to some extent to collaborate with the kind of diagnosis that the patient has in terms of repeating a lot of tests. So we are looking at the input cost from the health system cost. So the overhead cost will be captured as a part of the health system cost, whereas I think this is repeated, so I'll move ahead. So in this sense, we are trying to look at the 2 precursors for us, the consumables, drugs, implants and diagnostics as we listed, and also the length of stay of the patient, because that also is indicative of the resource consumption in a hospital. So what we look at is other cost, input cost, we can capture it, contribute around 57%, whereas for the remaining proxy, we will use the overhead costs, so that we can ensure that it's easier to incorporate in our TMS systems. So here we are trying to ensure that we will use all these informations both at the health system level and at the patient level, and derive the price weights for each of the cases, so that we can see if we say a national reference price of HPP is something, then beyond the national reference base price, what is it that additionally has to be paid for to adjust for the patient level characteristics. So it could be complexity, it could be comorbidity, those characteristics we can adjust with the base price. So potentially we are hoping that this is a more forward-looking slide. So we are looking at, we might start with some super specialty packages, look at how we can roll it out in some empaneled hospitals, how do we manage these data, and also ensure that how we can define even the SDGs, so that will help us in ensuring the capturing and the patient level care also better. So mainly we are looking that we are hoping not to do a lot of primary data collection, make sure that the TMS is something that we will use to our best of advantage, and first round we will only identify on these 4 aspects, so that we can capture most of the things that we want to. So as a part of this, as we rolled out into the pilot stage, we needed to ensure that we have specific hospitals who are selected for this. So we looked at hospitals who are providing the top utilized services in terms of volume, value, and whether they are following SDGs, because some of the states are still yet to roll out SDGs into their IT systems. So what are the kinds of procedures we need to have variety, because there is more variations in the oncology services, and whether a hospital as a whole can be considered, or certain specialities we can, and the type of ownership of hospital, because we also know that the public private system, I think even today morning we had so much discussion on how do we price the packages for public and private, and how differential pricing we can look at. So in that sense, we want to make sure that how do we adjust the prices even for DRG based on the hospital type, the number of beds. Again, bed strength will definitely give you a lot of economies of scale, so the costs in a different capacity of hospital may be completely different. Tier wise, we have already used it in our HPP differential pricing. We are trying to ensure that we have hospitals from all the different tiers, and also look at conditions which are booked together, so that we also want to make sure that how these packages overlap and how will that have some bearing. So we have come out with this concept, and based on this we have interacted, ensuring that we have at least from the 5 states 35 to 40 hospitals, that is minimum, but finally we got more than what we expected. So there are more hospitals willing to participate in the pilot even from these 5 states than we had anticipated. So we have, and also from different tier cities, we are trying to make sure that there is a balance, and also with the size, bed size, whether it's a less than 50 bedded or even more than 200 bedded. So we are looking at ensuring that we have a good spectrum of different hospitals. Currently, the selected hospitals who have given the concurrence, who have being more a part of it, we are ensuring that there is a mix of public, medical colleges and teaching institutions, private. So again, with the bed strength, we have a good distribution. The tier wise is something we will not have in all the states, because some states there are only tier 3 hospitals. So like Meghalaya, we don't have any tier 1 or tier 2. Whereas in some states we do have mostly tier 2 hospitals, and in very few cases we have tier 1 hospitals, mostly in Maharashtra. So looking at these 5 states, we are rolling this pilot out. We are ensured that we had another round of sensitization with all these states, because getting the states and the hospital in one place, and now saying concurrence, yes, we will do is different, but then when you know the more details, there are many hospitals who have gone back. Those who joined the sensitization, after listening to all the things, there were few hospitals who denied or who did not give their final concurrence after the sensitization. So they were willing, but they felt that this is like maybe there might be some transparency issues or how they handle. So we don't know exactly the reason, but we are trying to get more refined reasons from the things. So we are trying to follow a faceted process, looking at one is creating awareness, and sensitization is very important at our stage to ensure that we engage with 5 states in a much more in-depth way. This is the same thing we might have to do it as we scale up to more states also. This is a very basic process we need to engage, and we also are actually, our own technical group is also enhancing our own awareness and skills about what is existing and our own knowledge through the experiences from other countries. So we are trying to have a lot of technical meetings to update our knowledge and how we can address the challenges that we are facing. TMS is very much important for us, so we are trying to ensure the TMS is ready to take on this load and take on these challenges. Since we are moving also ahead from TMS 1 to TMS 2, so we are ensuring that the TMS 2 may be much more advanced than the current TMS, which has a lot of challenges. So we hope that we'll have a much stronger IT system as we move towards the TMS 2. Again, operational issues, we are trying to address them by interacting with them, and especially for costing, we are also working with the SNOMED systems and identifying how we can integrate, especially for drugs and diagnostic coding with them, and we can work on that. So finally, we need to also think about how we also make the DRG payments. So currently in our pilot stage, we are not making any change in the payment process. We are only testing the operational and the feasibility of the processes. So we in the pilot stage, until we adopt a overall payment systems and we are quite comfortable with it, we will only be doing this pilot to look for operational feasibility. So once it's all done, maybe in the final stage, we would be looking at also paying the hospital through the DRG. So we want to move in a very phase-wise with a budget neutral phase wherein there is no change for the state to change their payment system. So I think I've already gone through this. So in looking at the way forward, our main steps still to do is integrating the costing tool, looking at collecting the patient-specific cost information and from the pilots, continue the capacity building both and start analyzing the ICD, ICHI coding through the dashboards, which we are closely working with the M&D team, look at the claims database review and analyze them, and also look at some of the things that we have identified during our sensitization session is how we can explore further options of collecting this cost data, and also where hospitals which don't have EHRs. So we also will have to put in a little bit more efforts to ensure that the cost data related to any kind of inventories are made. And further continue the sensitization session and get formal willingness letters from all participating hospitals. So we will be closing all these things in a short time, but definitely this is something we look forward that though it's a long process, though it might not happen in our time, at least we are happy that we have initiated these processes, and in the years to come, we'll be able to maybe follow up on how things are going on, and hope that we can cut this short. Instead of the 5 to 7 years or 10 years which other countries have taken, we are looking at a time period of 3 to 5 years to ensure that we move to a really the complete payment mode for the DRG. So thank you. Any questions or clarifications? Yes, sir. Mike. 1 second. Mike.
Initial sensitization session, but many of them later backed out because of I think there was some lack of clarity on how they will collect the data or how much data needs to be collected and all those activities. So is all the data going to be collected through TMS? I think that will be a big relief if all the data is going to be collected through TMS. It's going to be much easier in that sense. But what is going to be the frequency of data collection? Do they have to continuously enter the data for the patients, or do they have to work weekly once or weekly twice or bi-weekly once, or what is the frequency on which they will have to keep entering the data? Next is whether, let's say 100 patients are of ABPMJY are in my hospital, do I have to do it for all the 100 patients, or can it be specified to some specialities, or randomly X number of patients from across the 500 patients or whatever it is? Another is they also had the lack of clarity in because since there is issue of data collection and data entry into TMS or whatever it is, the private hospitals may not have a big issue because they have an itemized list. We have seen the itemized list at the time of discharge. Let's say 7 size, 10 pairs of gloves are used, 6.5 pairs of 6.5 size gloves, so much pairs of are used. So there is an itemized list at the time of discharge regarding consumables for private hospitals. But for public hospitals, they don't have much of an itemized list. And many of the public hospitals do not have a strong HMIS system to capture the individual patient-related information. So especially the public hospitals had the concern of whether I'll have to assign or deploy more resources for the data collection was also a concern for them. And that was the concerns regarding the pilot and the other things. Next is, you mentioned that now we are having a flat rate regardless of the comorbidities and severity and the length of stay. And in a future date after DRG, we might actually have a case in which the cases with complexities are priced higher, but the cases without complexities you mentioned are priced better. So which obviously means are going to be priced lower than that is currently there. So why would a private hospital, which may not see a lot of complicated cases, want to participate to contribute in such a stage that at a later stage they might get a lower price package for these cases? We are saying that the flat rate might be priced better at a later stage.
Yeah, I'll take the questions from the reverse order so that my brain will work reverse, so that I'll be clear in answering. So definitely when we say priced better, currently it doesn't mean that when you're doing something wrong you continue to do that wrong further all the time, right? So now what we are saying is we are already pricing it differently. Even for a simple cases we are adding that plus already there. So that may not be visible, but when we do our packages, we do discuss and keep that extra there. So what we are saying price better means the national base price will be better. So it might be better in both sense, that we are now pricing it appropriately, right? It doesn't mean that we will be bringing the price lower than the cost of the procedure. So we will definitely be pricing it appropriately, so that the hospital is not feeling that they're not going to lose out or they're not going to be covered for the care that they're providing. So that's why I use the word better, not lower. So we don't know exactly whether we will be pricing it lower or same or better. So we exactly don't know, but appropriately definitely. Okay, so that is something. And the other thing is, in terms of the clarity to the hospitals on, most of the data collection, we want to do it on the TMS. So it is not something that he'll have a file of papers and then he will start filling things in on a regular basis. No, it is as and when the claim he submits. If he's submitting 10 claims a day, then he will fill in up for 10 patients only. So there's no building up of too much additional work. As and when the claim submission happens, only we are asking them to fill the data. And it may be not for, to start with, we are not limiting to any speciality, mainly because we don't know the kind of case mix data that we will be getting. So we might be getting of different specialities, and as we said, we might pick specialities to further, roll it out. But it's good to have more information from various specialities or the hospitals who are treating. so all the cases that they are treating. So definitely that is something we are looking into it. And in terms of them having, the clarity of why we have to do it, or we might be paid lesser, or those kind of concerns, especially public and private related, we are still grappling with it. How do we get data from a public hospital who doesn't have an EHR or doesn't have much refined data? So we will come out with some more, but to start with, let them fill in what they have. So we will also know to what level we can and how we can use analytical methods to adjust for the missing information, right? So if in case if there is a huge case load, we can definitely work out something that they fill every 5th case or something like that, so that it becomes more representative. But initially, to start with, we want the hospital to start doing it. Then we can see what kind of relaxations in data. Then we might not even do for 6 months of pilot. If you're having such high volume, maybe we'll say 1 month, we are done. We have enough sample from your hospital. And similar cases are coming to your hospital, which is similar cost. So we don't want you to fill any more data. So we can take all that call once the hospital starts doing that, right? So we want to make sure that it will be as friendly to the providers as possible, but it should also meet the analytical requirements to make some good, robust estimates for our relative weights. So in that sense, we have to take a balance of the amount of data we collect and how we use that data and adjust for the missing information. I hope I answered all the questions, right? Okay. In the corner.
Pilot hospitals, can we get manpower support?
Yeah, currently no. The answer is easy. Because we want this to be as a routine aspect of your processes. So for filling a claims in the TMS, we don't pay anything to the hospitals. So this is an additional information. If we add an additional field tomorrow, we are not going to pay anything to the hospital, right? This is like additional clinical field. You consider that is some information which will help you get your reimbursements better. The hospitals may even get more reimbursement in future than what they are getting by filling in that additional data, right? Yeah, there's one last there, ma'am. Ruby, I think so. Yeah, Ruby.
Yes, it's Ruby from Ghana.
Okay.
I just wanted to find out, in Ghana, our experience is that we have different rates for public facilities and private facilities. And one of the major differentials is the human resource costs. So in public facilities, the government handles the salaries of doctors and other staff in the hospital. So we don't have to add that as a cost component when we are determining the rates for reimbursement. But in private, we recognize that they handle their own HR costs, their capital expenditure and so on to put up their buildings. So their rates are higher. Now, in one of the slides, I noticed that in your cost inputs, in taking the data, I think about 27% or so is allocated to HR. I just want to understand what that means. Does it mean the NHA reimburses the personnel directly? And if that's so, how do you envisage how that would affect having to redo your rates? Because anytime there's agitation for higher salaries, then you have to go in and redo. I just want some clarification on that. Thank you.
So we don't pay any personnel directly, but what we said was that access the overall overhead health system costs, which we are going to get it from our big costing study for which we have already conducted. So we don't need to collect that information again and again from different hospitals, but we have a minimum health system costs for certain kind of procedures and facilities. So we can use a proxy for that. Whereas other things which are very patient specific, only we will be collecting more information at the patient level. Okay. Thank you. And
Thank you, Dhananjay. So, the first presentation that Dr. Sudha gave was one of the initiatives that we have tried to introduce around diagnostic-related group-based payment systems. And the whole idea is to actually try and make changes in the system that also have some impact on quality of care as well. So, if you start paying hospitals according to the amount of resources that they are spending, the idea is that they are not disincentivized to cut down on certain resources that they have to consume in order to provide appropriate care. So I was having some discussion over tea and lunch, and I think some feedback was being given that why not consider incorporating some additional cost for care that is to be given to patients who are having some kind of seroconversion, either to hepatitis B infection, hepatitis C, or this thing. And even for dialysis packages, I think there was a feedback being given by one of the states, I don't remember. So the point is that this is only possible if there is some kind of differential payment system developed that takes into account the considerations of different patients of different levels of severity, comorbidity, complication of the same disease. That's the whole point. So that is why I think this initiative that Dr. Sudha mentioned becomes quite important. And in the initial phase, as we go, I think the intent is to be a little bit more ambitious, try and cover all possible patients in the hospital. This is only one time that the information is to be plugged in by the hospital, and that is at the time of claim submission. And at that time, we definitely want whatever information is there into the TMS itself. We do recognize we have also come across this issue that you mentioned about public hospitals not having enough information in other states like Haryana as well. We had site visits and we realized that public hospitals do not have very good information systems. One of the things that we felt could be perhaps relaxed in public hospitals is getting the price data, because generally the procurement happens at the centralized level. So you don't have a decentralized hospital level procurement for consumables, drugs, etc., the kind of things that we are looking at in our cost data collection. So in that sense, one major component of the information public hospitals don't have to provide. The second, so price and quantity, these are the two things that we are asking hospitals to provide information on for drugs, consumables, and implants and diagnostics. Price is not what we are asking the public hospitals to provide. They are only requested to provide quantity information. But yes, for quantity as well, there is the case sheets need to be complete and other things. One possible solution that I can suggest is that public hospitals on a case-by-case basis within a few departments sometimes have better HMIS systems. So for example, in Haryana, we went to hospitals, cardiology departments had some separate HMIS systems that was able to track at the time of discharge all the resources that were being consumed. So maybe a similar thing can be worked out and looked at in Kerala context. So this is the second new initiative that we wanted to discuss and sensitize the states, although we've had this consultations with the states, but we thought that maybe not all participants who are here may have had an opportunity to hear this, so we thought that we'll roll it forward. So this is basically around introducing concepts of value-based care and value-based incentives, and this is a consultation paper that we had hosted on our website to seek the feedback from stakeholders. And based on that, we want to come up with a policy and roll out some kind of pilot interventions. So this presentation is nothing but a description of what we have tried to articulate in our consultation paper. The first chapter in this consultation paper actually talks about the whole concept of value-based care and the intent of the NHA to move from more of a volume-based towards a value-based care. Although I do recognize, and I see Dr. Ajay Tandon sitting right in front, who's given us very strong feedback, and we definitely value all that feedback. And the bottom line is that the value-based care is a very, very broad thing, and it encompasses a lot of different things. We're just beginning to take some small steps in that direction, and I think that there are limitations to the extent to which we can go in the beginning, but yes, the intent is ultimately to try and improvise as we move forward. So the first section basically talks about the fact that in a traditional system, you tend to pay hospitals, providers in terms of based on a certain way which is some way correlated with the volume of services that they are delivering. So for example, whether you talk about fee-for-service systems or case-based payments, as we have in our PMJY, we have the case-based payment. Ultimately, a hospital gets paid at a fixed rate, but whatever revenue that the hospital is generating is based on the total footfall in the hospital, the total number of patients that are admitted, hospitalized, etc. What we currently lack is any measurement or any sort of change in the remuneration that is consistent upon quality. We do have some mechanisms, but those mechanisms do not necessarily look at the outcomes of care. So we are looking at the volume of care, the quantity of services, but we are not looking at the outcomes of that care that has been delivered in order to remunerate our hospitals. And I know that the audience sitting here does not necessarily need to be reminded of the fact that how much importance there is for quality in terms of improving the overall outcomes. Just to quote the findings from one of the recent Lancet commissions that tried to quantify the mortality that happens that could be prevented, and it tried to give attribution of this amenable mortality to that part which is probably which could have been addressed had there been better access to care, and the part that is attributed to those deaths that happened because of perhaps poor quality care. And the finding was quite startling for the low and middle income countries, and it said that about nearly 60% of the total such amenable mortality happens because of poor quality care. So which means that we need to definitely keep a very strong focus on ensuring that the quality of care is paramount. And there are different initiatives that we have within our PMJY in order to address quality, some of which were being highlighted in the previous session as well. And if you look at these initiatives, these are initiatives that try and have some kind of financial nudges, and there are some which have a non-financial nudge, for example. So for example, we have these quality certifications. We have hospitals that we certify as gold, silver or bronze category hospitals, which is consistent to certain accreditation standards. And the reason why hospitals are encouraged to get these certifications is because they get certain additional incentive over and above the base price. So you get a 5% incentive if you have bronze category, 10% if you're silver, and 15% if you're gold. And then similarly for public hospitals, there is a different system of NQAS certification for which they are entitled for an incentive which is equivalent to a gold certified hospital. And similarly, we have other non-financial mechanisms of promoting quality, one of which we are trying to stress very significantly in the recent days is setting up of these quality cells, which Dr. Sudha also mentioned, and we have in the past few trainings that we have tried to do for which our quality team has been trying to do, is to try and develop a checklist that our SHA staff who are working specifically on quality, when they go and visit the hospitals, they should use this checklist in order to see that what are the processes that are being followed in the hospitals, are the adequate requirements, norms for manpower, physical standards, etc. being met or not, etc. So this is the focus of this checklist. And we also think that even the staff at the district level, the DIUs, they need to be capacitated in order to further take forward, because at a SHA level it may not be feasible to cover the entire state, because some of the states are very large and it may not be practically possible for them to go. So I think the way out is that we make our DIUs stronger, and the DIUs also take up this role of maybe ensuring that the quality of care that is being delivered at the hospitals is appropriate. And it is in this slide that this quality checklist, etc. become an important handy tool. So this is, again, I was mentioning about the incentives, financial incentives that are linked to these accreditation standards. However, what the whole connotation of value-based care that we are foreseeing for PMJY is something which tries to target these different aspects of the care provisioning, whereby we are overall aiming to improve the quality of care. which eventually helps to generate better health outcomes. And it happens through a participatory manner wherein the providers engage to help the overall improvement of outcomes for the patients. And the way that it happens is that you standardize the healthcare processes. Now standardization happens through a variety of processes. One is that you have standard treatment guidelines. The clinicians adhere to those standard treatment guidelines. Others are that you follow standard processes. You follow standard infection control practices, standard procedures for biomedical waste disposal, standard principles which enable that there are less hospital readmissions, less hospital acquired infections, etc. So all those things ultimately aim at all these things. And from a broader payers perspective, we want that we have as much as possible higher healthcare efficiency. So we are able to provide more and more services within the same amount of money. We are able to maximize the health within the same amount of money being spent. And for different stakeholders within our health system, there are different meanings of or connotations of value when we talk about value-based care. So for us, if we are looking at from a purely payers perspective, then perhaps the technical efficiency becomes one of the most important features of what value we want to create. But if you look at it from a patient's perspective, for him or her, it's the satisfaction of, or the user satisfaction or the user experience as you get a particular form of care in the hospital, that becomes more important. Whether that care is delivered in a respectful, dignified manner, whether patient privacy is maintained or not, all those things become more important from a patient's perspective. Whether the time spent by the doctor was enough, whether the way that the doctors spoke to the patient, whether that was congenial or not. I think all of those things become quite important from a patient's perspective. And from a broader policymaker's perspective, another important issue that becomes important is that the entire set of resources that we are spending, there is some degree of rationality in that allocation. There is some degree of equity principles that we maintain in our overall allocations of healthcare, which is something that I think which is linked to a more broader connotation of this integrated healthcare. If we are able to bring about some continuums of care between our primary, secondary, tertiary, that I think is something that is likely to lead to a greater equity in resource allocation, because then we ensure that any specific focus that is laid on the secondary and the tertiary does not necessarily have any bearing on the primary healthcare, and all the resources that we spend on primary healthcare in a way also bring in greater efficiency for secondary and tertiary care, because then we have lesser complication, lesser hospital admissions, etc. And there are different interventions, different issues that we are trying to target at different levels, which we feel is aimed towards trying to enhance the value of care that we are trying to deliver. So if I move from in a clockwise manner, the first is around the integration of care delivery. This is a work that still needs a lot of work to be done, and I think that states are at the best place to actually try out different models of these continuum of care. And these are things that are not difficult, but these things require a bit of a dialogue across different stakeholders. So which means that the NHM and the PMJY, the NHM and the SHA talking to each other. Some states which are at a particularly advantageous situation in order to implement this particular issue. And these are states where you have a common administrative hierarchy between the General Health Services and the State Health Authority, or the agencies where the COSHA also in a way handles the work of the National Health Mission, or states which are running in a trust mode, because then it is the State Health Services officers also who are managing the operations of the State Health Agency as well. I think these are some low-hanging kind of opportunities where I think that the engagement to build this kind of continuum of care becomes practically more feasible. And there are many service-related areas where I think that the continuum of care perhaps can be made a reality in a more short-term time frame. Some examples that we have come across in our recent work, one example is peritoneal dialysis. We feel that the uptake of peritoneal dialysis is especially very low, and we know that given the difference between, there have been some analysis which show that peritoneal dialysis becomes more cost effective given the fact that it reduces a lot of patient travel, patient costs, and in an overall societal perspective it becomes more cost effective. But what it requires is that it poses a major challenge. The challenge is more at the patient level. How do you maintain the logistics of the supply chain for the PD fluids, consumables, etc. And that is where, and then who ensures that the quality of the dialysis being maintained in relatively non-hospital settings, home settings, is in an environment which is clean, quality is maintained. Even what to talk of quality, but even the adherence to the number of sessions are maintained. I think herein the integration between the primary healthcare teams and your PMJY ecosystem becomes extremely important. So once you have done the catheter insertion of the patients in the hospital setting and the patients have been once trained on how to do a PD fluid bag exchange, etc. I think the role of the role of the primary healthcare teams becomes extremely important if they can do some kind of training, counseling at the home level, ensure that there is adherence, and also there could be some mechanisms that could be built for the supply chain. The PMNDP program, which is the dialysis control program, is also trying to work out some modalities for that. And one of the things that they're proposing as part of that is that the palliative care nurse concept that is operational in some states. I know of Kerala, and other states, or Tamil Nadu also has that. That they are proposing that this palliative care nurse becomes a kind of change agent for making sure that the operational aspects of delivery of peritoneal dialysis becomes easier. But this is just to say one example. There are other low-hanging fruits where the continuum of care could be extremely important. One of them is follow-up packages. So we have introduced as part of HPP 2022 follow-up packages where patients, after getting discharged from the hospital, they go back to the community and there is some degree of follow-up where medication, diagnostics, etc. are paid. I think that's another area where continuum of care could be important. And then obviously the whole population-based screening programs that the ministry is working on the other side is extremely important, because that's the point where you detect the patients early on with hypertension, with diabetes, before they've actually gotten to any kind of a major complication, but if they require some treatment which is to be done in a hospitalized setting. So I think there are enough opportunities where these continuum of care models could be developed. And I think that at the central level, we can perhaps only frame or articulate case studies or guidelines, but I think the real implementation needs to happen at the state level. Then the other way in which we are trying to address this issue is by creating some kind of incentives whereby there is more geographic expansion of the healthcare provider network of the PMJY. One of the ways of doing that, we have tried doing that, is by creating some kind of incentives for hospitals that are located in relatively far off areas. So the hard to reach, vulnerable districts, which we label as aspirational districts. So we have an incentive of 10% over and above the base price that is given to hospitals that are located in such geographies. The differential pricing that we have introduced, some people did give us this feedback that, you have created a differential pricing rate that is different between tier 1 and tier 3 hospitals. Does it not really actually incentivize the tier 1 hospitals than the tier 3 hospitals? Which was a concern that was raised. But the way that that this differential price has been finally computed is that the extent to which the cost is different between the tier 3 and tier 1, The price weights are lesser than that actually. So the price weight for a tier 1 city is actually about 8% less than what it could have been if you simply used the cost weights. So which means that we've actually reduced the gradient between a tier 1 and tier 3. So which means that effectively, implicitly, we have tried incentivizing the tier 3 hospitals than the tier 1 hospitals. We've definitely given higher price to the tier 1 hospitals, but competitively speaking between the different hospitals located in different cities, I think the tier 3 hospitals also are not disadvantaged in that sense. The whole construct of our scheme, which runs on a strong IT platform, which has a paperless transaction, which was already highlighted by our CEO sir also during the inaugural. I think that's another major initiative towards inducing value in the overall healthcare ecosystem. And with the integration that is happening through the Ayushman Bharat Digital Mission, I think this is going to become more stronger once there are these interlinkages established between different levels of healthcare service providers. This subsequent part of the talk, when I'll talk about this, how do we incentivize performance for the hospital. So this is something that I'll talk about. And the whole first day we have spent more time on this particular issue, where we've talked about systematic measurement of costs and outcomes and trying to devise our health benefit package in a way that we choose interventions that are more cost effective. I think this is perhaps the most important intervention towards building a value-based care, because building a system that tries to place a higher value to those interventions that offer greater, better health outcomes at a lesser cost. So a lot of things that we are trying to do, in a way, we are trying to target trying to build the value within the healthcare ecosystem of PMJY. And then based on that, we had a number of questions that we requested our stakeholders. The second section of this consultation paper, we specifically talk about the incentives structure. So as I mentioned, that the current set of incentives that we offer to the hospitals, we have two types of incentives currently. One type of incentives that are primarily looking at the accreditation systems of the hospital accreditation systems. So which means that we either have an NABH accreditation or an NQAS accreditation, an entry-level NABH or a bronze certification. So these are all, in a way, if I look at, these are all sort of accreditation-based systems where you are looking at inputs of hospitals and to an extent processes at the time of accreditation, and you give some incentive to the hospitals if they reach to these levels. The other two type of incentives that we have built in are to meet certain other broader health system goals. So for example, if we give a higher incentive to hospitals that have a teaching facility also, the idea is that hospitals ultimately get incentivized to have some kind of teaching courses also, which is aimed to also ensure that there are more and more hospitals that also work on generating healthcare workforce. So we need more health workers, we need more doctors, more nurses. So if hospitals run these teaching programs, we incentivize them slightly higher than what it is. And then we have certain incentive, as I mentioned, which meet a broader social policy objective, which is that we want to ensure that there should be equitable spread of our healthcare providers. Access should be equitable. So which means in order to encourage hospitals or providers to go and work in relatively more remote areas, you have an additional incentive for those who work in aspirational districts or vulnerable districts. Now, the transformation that we want to make through the value-based incentive is that as the current construct primarily revolves around having an incentive that is simply looking at giving the financial additional top-ups based on certifications, we want to also ensure that there are some objective measurement of outcomes that are computed, and this performance measurement ultimately leads to the computation of the incentive amount, and the hospitals start to get incentive based on how much value they are creating within the health system. Now, one of the things that obviously becomes important is that in this entire slide, perhaps the most important thing is that how do you measure then these outcomes, and what is the basis of your outcome measurement? That's the most important thing. So in order to do that, we thought that we'll have some objective criteria, that we'll follow certain principles on which basis we will choose the indicators to measure performance. And the three broad principles that we thought we'll focus on is that whichever indicator that we choose should be such that ultimately aligns with the broader objectives of the universal health coverage, or it aligns with the broader principles of how you measure the performance of the health system. So that's our overarching objective, overarching criteria to choose a given indicator. The second and the third indicator, the second and third criteria are primarily more of feasibility and logistics considerations. So the second criteria is it should be based on relatively more easily obtainable data. So we don't want to necessarily engage. So as we talked about the DRG pilot, and immediately the concern is that more data is to be given. So the moment you ask more data, that means more work means more hospitals want to opt out. They don't want to be part of the system altogether. So we don't want to burden the system which is already burdened to collect more information just to measure certain performance. So we want it to be as minimal as possible. The third is that whatever data that we collect does reflect on the performance only, and it should not be easily possible for hospitals or people who are collecting the data to game that information. So we want to collect certain information, but if that information is to be provided by the providers, if you ask me, have I done my work today? Why will I say I have not done my work today? I have a natural tendency, I have a social desirability bias. I'll say, yes, I have done my work today. So ultimately, this data is being fetched through the routine system, so we don't want it to be in a way that it is gamed by the providers. So these are the three criteria. So based on that, the three major domains of universal health coverage, and we saw these in the cubes that we have seen in multiple slides before. So we aim at having care that is responsive to patients' needs, which is delivered in a way that does not impose any financial hardship to the individuals, and ultimately the overall outcomes are better. And linked with each of these three domains of universal health coverage are these set of indicators or data inputs that we want to measure. For responsive patient-centered care, we want to measure beneficiary satisfaction, and we want to ensure that there is no confirmed grievance that has been reported against a given hospital by a patient. I'll talk about how we collect this information and how do we analyze this in the later slides. Financial risk protection, we want to measure whether the hospitals have charged anything or billed anything to the patients over and above what they have claimed from the payer. And the third is that we want to measure the health outcomes, and we want to see that whether the care has resulted in an improvement in the health outcome of the patient. And there we have two indicators. One is readmission rate, and the other is improvement in the quality of life of the patient. So these are the 5 indicators that we want to base our decisions on for performance measurement. So these are the 5 set of indicators. It is not to say that there were not other indicators that were considered, debated, or there were strong arguments in favor of some of the other indicators also. For example, these were the 3 more important ones that we have listed here. There were others as well. So we know that hospital-acquired infection is again a very important and a very well-documented indicator for measuring the quality of care being delivered in hospitals. However, this is very strongly biased by self-reporting. So you start measuring quality of care based on hospital-acquired infections. As long as it is being measured only to measure the quality of care, it's fine. The moment you link it with incentives to be given, which hospital will say that yes, we had an infection that happened because we did not follow good practices of patient safety or likewise. So this is strongly going to be influenced by the self-reporting by the hospital. That's why we did not consider it for consideration of the performance measurement and the incentive calculation. The second was mortality rate. Again, this was very widely debated within the group, and we felt that mortality is definitely one very important indicator and it should be accounted. But the problem is that hospitals treating patients of different types, there might be certain hospitals that generally receive more severe spectrum of the disease profile, and certain hospitals that receive a more sort of moderate or a less severe spectrum of the disease profile. So automatically the hospitals that are receiving more severe spectrum of the disease profile, their mortality rates are likely to be higher. So I know that if you look at simply the mortality rate in labor rooms, perhaps the mortality in AIIMS and PGI would be higher than at a district hospital. And that is because you receive more emergency cases in these tertiary care hospitals and more sicker cases in these hospitals. So if we start using this, then it automatically incentivizes the hospitals to cherry pick the less severe cases and to shun off the cases that are more severe in nature. So that's why we did not include that. We thought that we could even consider disease-specific mortality rate, but even disease-specific mortality rate had a challenge, because then the hospitals of different hospitals may be treating different types of cases, and some hospitals may be predominantly taking care of certain specialities, and as a result it may not be a very good indicator across the range of hospitals. The third indicator was length of stay. Again, length of stay is a good indicator because you generally encourage early ambulation, but the problem is that if we incorporate this for performance measurement to be used for incentive calculation, then these hospitals could potentially be discharging patients early despite they needing care for a prolonged stay. So that's why again this indicator was not chosen to be included. One of the overarching consideration for any hospital to be considered to be eligible for receiving any incentive is that there should not be any kind of a fraud, proven fraud against that hospital. So if there is a proven fraud, then irrespective of whatever is the performance, there is going to be no incentive that would be that this hospital would be entitled to receive. So this is like the eligibility criteria to begin with. And then we come to how do we measure each of these different data points and how do we estimate the final score. Beneficiary satisfaction rate, which was one of the indicators for responsive patient care, we are trying to, as was mentioned in the discussion that happened in the previous session, when we had a very good panel discussion, it was mentioned that we have a call center which calls patients on the second day after the discharge and on the 15th day after the discharge. So what we are hoping is that during the second day call that goes to the patient, there's a question that asks that how satisfied you are with the experience in the hospital, and that will be used to elicit the patient satisfaction. We also recognize that patients generally tend to be very compliant in terms of their reporting of satisfaction. Majority of the people are very happy, at least as long as they come back discharged alive from the hospital. They generally have lesser grudges. That's the usual tendency in our settings. There are very few people who will complain, no, hamare saath bahut bekar hua, whatever. So there are very few complaints that we'll receive. So as a result, you can see the classification, the class intervals that we have kept here for the scoring is not such that starts from 0. The lowest marks are for the ones who have less than 50% marks, and then the highest marks are only for the ones who have more than 85% scoring. Readmission rate will be auto calculated from the TMS itself. So readmission rate will be defined as a readmission for which happens within 15 days of a previous discharge for the same illness that the patient was admitted earlier. And this could have been also gamed because the hospital. This may also lead to a fact that the hospitals may deny a readmission to the same patient who has been admitted in the hospital earlier within the last 15 days. But this is going to capture the readmissions that may happen even in another hospital, which may not be the same hospital where the previous admission had taken place. So even if the patient goes to another hospital, it gets recorded as a readmission. since there is a unique ID that is linked to the same patient. The grading system is based on international benchmarks that are available. Now here again we got very good feedback from during our consultations that these readmission rates should not be a standard readmission rate across a range of different disease conditions. And so what we are thinking is that we'll try to once we do the pilot and once we have the data, we'll try to also look at that if we can have disease specific classification of these readmission rates that are more representative of the relatively what should I say, acceptable levels of readmission rates which are more disease specific. The third item that was there, out-of-pocket expenditure, again by the hospital is to returns that amount to the patient. That's the usual closure of the grievance in such cases. And so what it means is that in such a case, the hospital in a way gets penalized only for that particular event or that particular episode where the expenditure has been charged. But when this becomes part of this performance measurement, this indicator in a way contributes to the overall hospital performance measurement. And when it contributes to the overall hospital performance measurement, the incentive amount gets lowered for all types of procedures that the hospital is performing. So it's a disincentive not just to that particular episode of care, but to a range of all the procedures or the volume of services that the hospital is delivering. The fourth indicator is confirmed grievance. Again, this is collected on a routine basis. So we have established systems of grievance redressal that were explained during the previous panel also. So there is a grievance redressal portal forum and that receives the grievances. If there is a confirmed grievance, again there is a binary scoring system that you get 0 or you get full marks. Till these 4 indicators, there is nothing extra that needs to be done by the system to collect information. Existing mechanisms of information collection are being used to compute these indicators and to assess the performance and to perhaps then link it to a performance measurement. The next set of indicator, which is on measuring the outcomes of the patient, is where there is an additionality on the hospitals to collect information. And what we are proposing to do as part of this activity is that we incorporate the use of a tool that is called as an EQ5D 5L tool, which basically has a set of 5 questions. So this may not be very clearly visible on this slide, but it basically asks 5 set of questions. Questions on mobility, self-care, usual activities, pain, discomfort, and anxiety. And in each of these 5 domains, the patient or the respondent is asked that how do you rate yourself on a kind of 5-point scale. So when you say pain, it means that I have no pain at all, and it moves on to I have intense, extreme pain or discomfort. So that's what you do. So what we are proposing to do is that this tool gets incorporated at the time of pre-authorization, and this is administered by the PMAM to the patient at the time of pre-authorization. So PMAM asks just 5 additional questions, and for these set of 5 additional questions, whatever response the patient gives at the time of admission, he simply says, he puts a checkbox at each of these points. That's the only thing that the PMAM does. Once these checkboxes are done, it in a way creates a profile of the patient. The profile of the patient, for example, in this case is that he has no problem in mobility because it is the first point here. There are slight problems in self-care. There are moderate problems in carrying out usual activities like studying, homework, etc. There is severe pain that this patient has, and there is extreme anxiety. It's an unrealistic example. Okay, so don't go by this. It may not be correct. There can't be a patient with this profile, but it's just a hypothetical question. The point much should be the improvement in quality of life or likewise. But what we are proposing is that let there be a kind of a percentile-based system. So within the hospitals, different hospitals in a given state, whatever has been the improvement in the functional status of the patients admitted in different hospitals, based on the available data itself, you do an assessment and say that hospitals which performed better get better score. So they are in the 85th percentile onwards, upwards of 85th percentile. Some hospitals are between 70th to 85th percentile. And that's based on the average improvement in quality of life of patients who are treated in different hospitals. Now again here, there was very good suggestion that we received that this is again dependent on the type of patients that are being seen. So which means that we need to adjust for this improvement in the quality of life according to the case mix that is there in the hospital. And again, for this particular purpose, the ICD classification and the primary and the secondary diagnosis that you are mentioning becomes extremely important, because that's the one way through which we can make some adjustment into this based on the case mix, because otherwise we have no other way to do to adjust for case mix. So I'll just skip a few slides. Dhananjay is showing me time. So we want to also place, we also recognize that we do not necessarily want to let everything be, transfer in a way the power to the call center, or transfer the power of this to the grievance portal, and likewise. We feel that there should be some kind of patient empowerment also in the process, and let the patients have some kind of mechanism for self-reporting of some of these outcomes. So we're also in the process of developing an app that is able to record some of these, as many patients who are able to have smartphones or able to submit their responses. So we want to create this app that enables them to submit responses on the level of satisfaction, whether any expenditure was elicited or not. So all these indicators are such that the patient can also self-report for each of these things. So this app will also provide a second opportunity whereby patients can report and patients can give back this feedback. And this was a very useful suggestion that we received from the ACS Health in Uttar Pradesh, who gave us the suggestion that this should actually be, you should try and place the power back in the hands of the patients rather than you yourself creating systems and placing the power more in call center employees or your grievance portals, etc. So moving forward, again we want to test all this proposed strategies that we have outlined here in states. So we are seeking willingness from 4 to 6 states who would be willing to participate. There's going to be no change in any kind of incentive system that goes to the hospitals during the phase of the pilot. There is the only thing that adds to the work of the state SHs as they move forward and participate in this pilot is that we will have to train the PMAMs who will have to collect that one information at the time of pre-authorization. That's the only additional work that goes in. There is nothing additional on the SHs or on the hospitals that goes in this entire framework. And we also hope that this is something that not only creates a mechanism based on which you simply generate you simply compute the incentive that is to be given to the hospitals. But so it is not something that works on the supply side alone. We want to also create some kind of demand side effect of this entire performance measurement. So which means that we aim that this should lead to a kind of a hospital performance dashboard that could be prepared, which could be a public dashboard. Patients who are to make choices about visiting hospitals could make informed choices based on the performance of the hospitals as is reflected on this dashboard. So which means that the hospitals are incentivized not in one way that it is going to influence only their incentive amount through the quality of care that they are delivering, but it also is likely to influence in future the footfall in the hospital if the patients become better informed through this kind of information that is made available to them. So I think that's it that I wanted to say. Thank you very much. Any questions, I'm happy to answer. We need 2 mics, one there and one Dr. Ajay here. One more mic here this side.
Thank you. We're just asking about the source of fund for paying incentives. do you plan to have a specific incentive fund, or is it embedded into the UHC fund? Thank you.
So the incentive amount, so it's not an additional incentive that we are creating for the performance measurement, for the performance of the hospitals. The hospitals are already getting an incentive, which is currently only based on their infrastructure and the inputs that are available in the hospital. For those hospitals that are already accredited, we are just saying that we are splitting that incentive to be calculated not just entirely based on this thing, but also on this basis, which is the performance of the hospitals. But what it also has implicitly built into this is that hospitals that did not have an accreditation, so which means smaller hospitals that otherwise provide good quality care but do not necessarily have the kind of NABH accreditations, they also become eligible to receive an incentive, at least that 50% component that is to be determined based on this performance. So to an extent, it will favor the hospitals, the sort of less than the kind of corporate hospitals, I would say, if I place it that way, because they are the ones who generally find it sometimes difficult to get a accreditation otherwise. Yeah.
Thanks for that, Shankar, and also for Dr. Sudha's presentation. Is excellent. So I have a brief question and also a comment. So the question is, did you look at this issue of inappropriate admissions? And is the sort of the pre-authorization process in India for under PMJ, is it able to pick up on those things? The reason I'm asking is that in many of the countries that we work, like in Vietnam, for instance, that's a big challenge. And that's also sort of a situation where it's not necessary for the person to get hospitalized, but because of the reimbursement associated, the providers view the patients as a revenue source, and so there's sort of a built-in incentive. And it's also a challenge in Chitra's country, in Indonesia as well. Whether you discuss that, and is there a mechanism by which one can pick up on those things? The second thing is just a comment I wanted to make, that I think what you pointed out about value-based care, very interesting and very much in line with global experiences. I just wanted to add that many countries are even going further, and just wanted to elaborate a little bit on what Dr. Sudha said, that currently the sicker you are, the more the providers are getting paid, right? So the more heart attacks there are, the more the providers are getting paid. So many countries are turning this around and saying, what can I do now to make the providers get paid more the healthier you are, the less heart attacks there are. And there's a lot of very interesting work happening in China, in the Philippines, in the US, in Europe, on using global capitation or global budgeting models. They will require that the beneficiary is very clearly tagged to a facility or a group of facilities, but then the facilities are paid in such a way that they get more money the healthier you are. It's turning the whole system on its head. And just wonder, that's taking the value-based to its extreme case. And so suddenly you have a situation where the hospitals begin to call the beneficiary and track their weight and to tell them to stop smoking and become healthy. So they become allies in keeping you healthy. And I just wanted to throw that out there, that this is sort of a movement towards really changing the whole paradigm of how you finance healthcare. It's not easy to implement, and it's not something that all countries can easily adapt, but certainly a very interesting concept for us to bring into the policy dialogue. Thanks.
Sure, I think, in the long run, it would be one of the wish lists, I would say. And I think that it would happen perhaps with a more and more integration across all levels of the healthcare system. Unless that happens, I think that's probably the prerequisite to moving towards what you're suggesting. So, or a kind of a system whereby the hospital has the entire responsibility for all types of care to be provided by the in the catchment population. So yeah, I mean, I would say it would be a big R reform, not a small R reform. Yes, sir.
Yes, you mentioned that when value-based incentives will be brought in, it will be like 50% to the certification-based and 50% to value outcome-based. So at that stage, does it mean that we have around 25% of maximum incentive currently, that NABH, let's say, entry-level certification is currently 10%, that will become 5%, and everything will currently half, and the other 50% or other 12.5%, maximum of 12.5%, will come from value-based incentives.
Yes.
So how do you grade the 12.5%? Like, is there a cutoff score, like 2.5% for achieving 0.2 score, or 5% and then 7.5%? Or is there any scale in which you will put out these 12.5% across the outcomes achieved?
Yeah, I think so. Right now, there is no weighting across each of these indicators that we have thought of right now. There is a scoring system for each of these indicators. And based on the scoring system, there is no weightage system. That means one indicator has a higher weightage or the other has a lower weightage. I think the final computation of how it works out, it will be once we start getting the data as well. And this is essentially one of the purposes of the pilot as well, to get the data and to set the systems of calculation of these incentives correctly. It is not. It is ultimately going to be a pooled amount of incentive that they get for the remaining 50%. You can later on stratify it across, and you can see that the incentive that a particular hospital is receiving is high because of A indicator performance is better, or B is better, or C is better. That can be later on seen. So right now there is the only thing that I can say is that there is no perceived weightage that has been decided for any one particular indicator. So it's like it's going to be more like a kind of arithmetic average of each of these.
So like many of those scales you mentioned, like let's say out-of-pocket expenditure, if there was something, it is zero. If it's not something, there is a particular set of marks. So if a hospital in which nothing is zero, so they will get some incentive.
Yeah.
They will get some, it could be 1%, 2%, 3%, 4%, that will come up later on.
Yeah. Okay. In other words, the hospitals, if a full accredited hospital is currently getting 15%, the maximum that they can get is 15% only later on also. The full accredited hospital, 15% is currently getting. This gets split into 7.5% amount. 7.5 he gets for this thing. The remaining 7.5, up to a maximum of 7.5 only he can get if he is the best performing hospital in the area. There will be, the hospitals may get slightly less than what they are currently getting, but then the other hospitals that were not accredited, they also become entitled for getting some incentive based on the outcomes that they are delivering.
So a very good hospital, let's say an NABH full accredited hospital, if it's getting 15% right now, even at a later stage they'll only get 15%, even with the full value-based achievements.
If they achieve at the highest level, they get 15% total at the most.
So even a full NABH accredited hospital is having the highest score, and as much higher score is achieved by a bronze certification hospital in the value-based outcome measurements, there is going to be a big difference in incentives in these hospitals, because let's say bronze is only 5%. So a hospital which has achieved full marks in outcome-based indicators, whose marks is as good as an NABH full accredited hospital, their incentive is still going to be 5%.
So of that remaining 7.5%, if there is a small hospital and a fully accredited hospital, if both of them are at the same level, both of them get 7.5% incentive.
Okay.
This is what I can say.
Okay.
But and it could be that this smaller hospital who performs much better on the outcome side is performing better than an accredited hospital, then he may get 7.5, but he may get 5% perhaps on that part. But this accredited hospital still is entitled to his incentive based on the accreditation level.
Okay.
So the remaining 7.5 that he has for accreditation, he still is entitled to that as of now, based on this sort of metrics that we are developing.
Thank you, Dr. Sudha and Shankar sir. We have few announcements. Yesterday in the file you have, which you have got during the registration, has an USB. I mean, it has a pen drive which contains costing papers and also the documents which were released by NHA yesterday, and some pre-read material on HPP and HTA. Relevant readings. So please go through all of them, which will be useful for you. We also have given the hard copy of feedbacks to all the tables. So please fill it up so that it will be feedback on the overall session to us to get improved from next time. So shortly we are going to start with the validatory session. Our additional CEO is going to attend, and please don't leave the hall as it is.
Hello everyone. So ACO sir is on the way, so we are expecting sir to reach in within 5 minutes, so that is why we are requesting you to wait. Thank you.
I kindly request everyone, please take up your seats and settle down. We have to start the final session. I request all who are outside also, please come up along with your tea. I request our Honorable Additional CEO sir to please come on to the stage. I request our Executive Director Dr. Sudha Chandrasekhar and also Shankar sir to please come up. And also we request the CEO of Jammu and Kashmir, ma'am, please come on to the dais. We also request the CEO from Arunachal Pradesh, sir, please come on to the stage. We had CEO madam from Telangana also. I request Dr. Shankar sir to continue.
Thank you. I think sir left. So I think we don't want to, we know that we've had a very long and quite an enduring 2 days session. So we don't want to necessarily keep you waiting for much longer. I thought that rather than we speaking, because we've been speaking since last 2 days and you must have been bored by us. So we'll rather have the other way around and have our debriefings for our ACO sir to hear that what the participants have perhaps felt something that was useful or something that they can take back. So I'll request we'll have some responses from the state participants and some from the international participants in terms of their experience. So can I request from Chandigarh, Dr. Nagpal sir, if you can maybe come up and say a few words.
Good evening, everybody. First, I must congratulate Dr. Sudha, Dr. Prinja for this such a wonderful, this academic and so-called practical, and such a fruitful 2 days. And we learned a lot from them. I know everybody must be too tired to listen to me, what I want to say, and he has touched every point. Both have touched every point. Whatever our doubts were there, they all have been as cleared. Chandigarh being UT is funded 100% by NHA, and we are constantly in touch with these people. There are very few points which I just wanted to highlight. First point is about the orthopedic implants. I'm an orthopedic surgeon. What I feel that initially when we started the National Blindness Control Program in our state, and the doctor used to get 1400 for per case, and doctor used to say to the patient that भैया देख 1400 रुपये मिलते हैं, and if you can afford a good implant, a foreign implant or a lens, you pay something extra to me. I think same problem will rise with the orthopedic also. The doctor will say that I get only 60,000 rupees for total knee replacement. And if you want some good knee, some important knee, you pay something extra for that. For this, I just wanted to apprise you people that we should make some guideline and some SOPs for that you should authorize some companies, maybe Indian, maybe foreign companies, at least they should be CE certified or BIS certified company should be there, so that the doctor may not fleece the patients. Most of doctors won't fleece the patient, but there may be some of the people that who may try to extract the money extra from the patient. And suppose something goes wrong with the patient, he will say, "मैंने तुझे पहले कहा था ना Indian मत लगवाई हो." That's why you have got infection. This is the one practical aspect I just wanted to highlight. Second aspect was this: in Chandigarh especially, the portability is very high. So some of the states have make a 2.1 package, some has got 2.2 packages, and the money which the doctor will get according to the state packages. Suppose somebody comes from the Bihar and get operated at Chandigarh, probably the doctor won't get the same package as he would have got from the Chandigarh people, sir, in Chandigarh population, sir. So this is a very valid point if you see this point, sir. And the third point I just want to ask you, suppose regarding medicines, there is a lot of disparity in the medicine cost of the medicines at all the places. At least we can, in government sector, we can do one thing, that Jan Aushadhi should be authorized to give the medicines at least for these patients, so that they will be as rationalized of the rates. And last but not the least, I know you all are too tired. I just want to say something in Hindi, that deep आशा का लम्हा जलाए रखो, एक बुझ जाए तो दो चार जलाए रखो. दीप आशा का लम्हा जलाए रखो, एक बुझ जाए तो दो चार जलाए रखो, क्या पता कब खुदा मेहरबान हो जाए, हाथ हर वक्त का दुआ के लिए उठाए रखो. नमस्कार. Thank you, sir.
Thank you very much, sir. Would any of the other state participants also like to share any of their feedback or experience? We had a lot of, I think I was having a discussion, and from Karnataka state, Dr. Sangeeta had a lot of inputs to give back, if she's here. Or Dr. Suresh, yeah, anybody, yeah.
Good evening, Pranam. So, thank you very much for inviting us for this wonderful workshop. Actually, it is a national workshop with international or global audience, because there are so many people from other countries. So it's a global workshop, and we learned so many new things here, because this is one of my first interactions with NHA, coming here and discussing, I hope, multiple things. So we'll be looking at HPP with more of a civil society perspective. We're going to host that whole document into the public domain, as you suggested, and wait for another 20-25 days to get the feedback. And finally, move it to the finance, because finance will speak different language altogether. So we have to have every perspective before pushing it to the finance. Then we are looking at the quality cell. Already we have moved the file on that. We are also looking at PMU, because we need more and more people to do research as well as to write the proposals. So our EC is on Saturday. If everything goes on well, I think we'll be getting all those things. Value-based care and DRG, very exciting things. And we'll be part of that if you could allow us. So we'll definitely deliver on those things. So thank you so much.
Thank you very much, sir. Any other state representative who might like to share some views, some feedback? Please feel free to raise your hand, and till the time you're thinking, maybe I can request some of the international participants, if anybody, Dr. John Mary, if you would like to maybe say something in terms of what you feel could be perhaps even relevant for South African context.
Thank you. And thank you to all the organizers, to World Bank, to CGD Joint Learning Network, and the Government of India for not only a very impressive 2 days, but an impressive set of results that you've been able to present and describe in very valuable detail for us. In South Africa, we have been working for some years to prepare for implementation of national health insurance. and we'll be starting to roll that out in the next few months. Our country context is a little different to India's, and as a result, our approach to insurance is a little bit different. But there are a number of themes that stand out, certainly for me, that resonate with our experiences and our concerns as we go forward. I think the first one is the codification of an explicit benefit package. It's been described that you will be taking it forward with ICD-11, with ICHI, International Classification of Health Interventions. South Africa has made the same decision, and will also be adding to that the International Classification of Functioning to our architecture for defining benefits. And then I think it's this codification that really then allows us to digitize, slowly but surely, the health system as a whole, and in that way really strengthen our capacity for improved data and analytics, which we've had a lot of information about cost effectiveness analysis and different approaches to priority setting that ensures that decisions around policy are evidence-based. And then overall, I think this digitization, together with defined processes for prioritization, really is going to do a lot to drive the governance, certainly within India, and what we are looking to do in South Africa as well. And listening to Dr. Shankar this morning speak about governance, I realized how much we can learn, not just from what you as the states have all done over the last 4 years, which is incredibly impressive, but what you are planning to do going forward. I think the example, looking back, that really struck me was linked to a similarity between South Africa and India, both having federalized context, and the fact that you allowed for these add-on packages that states could use and adapt for their own needs and context, and that you also then took back and looked at in terms of which of these might be worth incorporating into the national health benefit package, and where there were cases where they were in multiple states, to review the evidence on cost to try and find out what would be a fair and average price for those services. And looking forward, certainly the final presentation today on value-based care is something that we are planning to implement. Our defined healthcare benefits package includes a definition of outcomes that we want to see, and it sounds like you are that many steps further forward in terms of defining what that means in practicalities to collect the data. So I congratulate you at the national level, at the state level. It really has been a privilege to be here and listen to you. Thank you.
Thank you very much. May I request CEO J&K, Madam, if you'd like to share your views and your thoughts about the 2 days of the workshop.
Thank you. First of all, I'd like to congratulate National Health Authority for such a well-planned and informative 2-day workshop. It was extremely enlightening for all of us, I believe. J&K is one of those UTs which covers 100% of its population in terms of health insurance coverage. So optimizing and rationalization of health benefit packages as such becomes a really important aspect for us. So, and there have been extremely important key takeaways that we like to take back from here. For example, the value-based care that was present in the last presentation. Secondly, we will look into the price rationalization and price negotiation of consumables as well for price fixation of various health benefit packages. So several key takeaways from the 2-day workshop. Something that we would like, and of course, a lot of the participants also made some really important suggestions. For example, one of the participants talked about inappropriate admissions. That is something that we are actually facing in the UT of J&K. So probably we would like certain intervention from the NHA level, and probably a better think tank to actually
help us figure out how to combat this issue. So that's all from my side. Thank you.
Thank you very much, ma'am. I think your suggestion, and also which was reinforced by Dr. Nagpal in his comment about this issue of strategic purchasing, price negotiation, is something that is extremely important, and our CEO sir is also very supportive of this issue. So we'll definitely consider that and take it forward. May I request the CEO Arunachal Pradesh to also maybe say a few words.
Thank you. Thank you, NHA, for conducting this 2 days workshop, and it was a big learning for us. We learned a lot on various aspects of rationalizing health benefit packages. We are always in the learning processes, and we take guidelines because we don't have the capability of framing our own guidelines, so we always look to people, precedents, as whatever has been done. So such workshop like this will enable us to guide our policy makers, and maybe we seek more support from the other stakeholders or here to help us build this, because we are in a very raw stage, and we look forward to have more such experts inputs so that we are guided, so that the services are delivered. Thank you very much.
Thank you, sir. And I think your openness to try new interventions and to your suggestion about having a specific focus on the Northeast to support different initiatives is absolutely welcome. Finally, I'll turn to our ACO, sir, Dr. Gidam, to kindly give his concluding, wherever you want.
Thanks, Dr. Pinja and Dr. Sudha. It's been a very intense 2 full days workshop, and many of you are coming from, in fact, most of you are coming from out of Delhi, and when we talk about workshop, it is generally predominantly professional discussion and review and knowledge enhancement, and to some extent it is also a change from your usual routine in states and your own offices, and some going here and there. So I know at the end of 2 days valedictory at past 5 p.m. is not much advisable, because everybody is now looking forward to have some free time and also to go back. I am sure it was intense period. You had an intense discussion. HBP, or health benefit package, is a very vast subject, and we in India have just started with a pan-India scheme, which is truly pan-India. RSBY will say 30,000 rupees is hardly a cover. So this is practically the first pan-India scheme. While we as a government, I'll specifically speak to the policy makers, the state health agencies and NHA, we ourselves. We are definitely entrusted with the important task of protecting our public money, spending our public money very carefully, so that we get every bit out of every rupee that we spend, and don't allow anyone to make windfall profits out of it. But we have also to be very conscious of the fact that when we seek healthcare from private sector, they are providing healthcare with intention to make profit, and therefore our policies should ensure that it's not a bad word, profit is not a bad word. Not only that, we have to ensure sustainability and should provide a kind of confidence, a predictability in their mind. It should not happen that the package rates are revised in 2022 and he still has that uncertainty what will happen when inflation will increase my costs in 2024, whether I will start making losses. So maybe somewhere down the line we have to ensure that this kind of predictability and some confidence building is done by way of policy
which we can incorporate in some formula or otherwise some inflation linked index or some such input parameters which can define HBPs in the long run. This is important because it will also ensure adequate investment by private sector for particularly quality healthcare without frills, so that they have that confidence. Okay, I have assurance that for next 10 years, 30 years, this scheme is going to stay, and I can continue with this scheme. So that partnership gets even strengthened further. That's one point. And another is obviously to ensure that we don't spend on inappropriate technologies. Inappropriate, sometimes a technology may be scientifically proven, but inappropriate from the point of view of financing, whether we are in a position to spend 1 crore rupees on one patient when we can take care of someone. So that part is also getting discussed more and more, and we, Government of India, are going to have our HTA. I think you already had a session with the Department of Health Research. So all these things, there are a lot of takeaways like this. I would request SHAs to be aware of all these facts once they reach their states back and start implementing the scheme once again. That's all from my side. I wish all of you a very great evening and a very happy journey back to your home. Thank you so much.
Thank you very much, sir. I think this is the last final closing time that I'm coming on the podium. I'll not stay for long here, but I do need to definitely take this opportunity to thank all those who've been involved in making possible that this workshop, two-day workshop could be held. And I'll begin by thanking our CEO, sir, who's provided the overall stewardship and leadership to this entire program. And a lot of the initiatives that you see in terms of whether the DRG or the other things, you see the kind of digital blueprint in that, which is something that that is kind of coming as an inspiration from his leadership. I'd also like to thank our ACO sir, who's always super busy, but still he's able to take out time, and we're able to borrow time from his busy schedule, and he's always been kind enough to spare his time to come and join us for this valedictory. I know how busy he was, but he still made it a point to be here with us and share and hear back that what all work we did. So thank you very much, sir, for sparing your time. Our Deputy CEO, sir, could not join us for this meeting, but he's been instrumental in the entire planning of this meeting ever since the beginning, the conception of this, the plan that why we want to have this meeting and how we should go ahead and have this kind of an interactive knowledge sharing kind of a two-day event. It was all his brainchild. Unfortunately, we missed him during these 2 days, but nevertheless, we had his guidance and blessings all through. So big thank you to him as well. All our divisional heads at the NHA have been extremely supportive. You've seen several of them coming in during different sessions, attending the panel discussions and the talks, and sharing their rich experience and clarifying a lot of questions that the states have had. I think one of the main thank you goes to all the participating states. I think there should be a big round of applause for all of them who have been so patient, sitting through all the sessions, and a large attendance at the time of this valedictory is a testimony of the fact that at least all of them have been really very interested, and your queries and your feedbacks are things that make us stimulate our thinking process and help us perhaps think about some possible solutions that we can work out. Several international participants, experts who had come to share their experiences. I think we're extremely grateful to you for having spared your time, Dr. Andres, Dan, Ursula, who've been in absentia, but a lot of other JLN country representatives who are present here and who have been kind enough to stay back and share their experiences. And it's been a two-way learning process for all of us. I think we've learned extensively from your experience. So thank you very much for being part of this workshop and for sparing your time to and helping us learn from your experiences. this workshop would not have been possible without the support of our development partners who have been so kind and generous in terms of their support, starting from the World Bank, the Joint Learning Network, the CGD and the WHO. I think we have all those people who have been here, Dr. Sheena, who's been so supportive of us, Dr. Abha, I think Grace is not here, but Jaydev is still here, so big thank you to the WHO. And Naina, I'm not sure if she's here, but she will definitely convey our thanks to Somil. I would be failing in my duty if I do not thank a few individuals who have been extremely instrumental in this entire event. Dr. Sudha, who's here, and two of my colleagues who need to stand up to have all the applause right now, Dhananjay and Shikha. I think they've been and the entire team from the Health Policy and Quality Assurance Division who's sitting there. I think they've worked tirelessly over the last few weeks to make sure that this event does happen. So thank you very much, and I hope that all the states did enjoy, and hope that those of you who are staying back do enjoy your evening and go back with some positive things. Please feel connected with us and do share back your feedback and learnings. So I think that's it from my side. Thank you very much.
Very intense